Right. Good morning, ladies and gentlemen. If you could take your seats, we'll make a start in the next 1 or 2 minutes. And whilst you're taking your seats, I'm going to request co-moderators and panelists, Martin Schneider, Joachim Miro, to come and join us up on the stage, Hisashi Sugiyama, Mulyadi Jer, and Edwin Francis up on the stage. And then the topic once more is ASD closure and special patients. And we're going to deal with, in the first talk, small babies. And Kalyana Sundaram is the first speaker. Welcome him. Yeah, please.
Good morning to everyone. I thank Dr. Tin and his team for inviting me to give this talk. My talk is device closure of ostium secondary septal defect in small babies. Here we define small babies are less than 2 years old. Ostium secondary septal is classified into small, moderate, large size if it is less than 6 mm, between 6 to 8 mm, and more than 8 mm respectively. Spontaneous closure of ASD of more than 8 mm usually doesn't occur. Usually, the usual recommendation of ASD closure is before school going, but it's not clearly mentioned about the lower cutoff age in any of the literature. Device closure of ASD in younger children with a larger defect is a challenging task in view of thin pliable rims, requiring larger size sheets and devices compared to the older children. So we use a amplatzer delivery system, 260 centimeter 035 J-tip regular wires, not the stiff wire in all cases for JR catheter. Approach will vary, depends on the patient. Some of them can be deployed from left upper pulmonary vein, or some of them right upper pulmonary vein, or some of them from the left atrial roof. Before 2019, we used most of the cases TE and fluoroscopy guidance for deployment. Subsequently, from 2020 onwards, we used almost all patients only TTE without using, and fluoroscopy without using TE. So criteria for device closure: symptomatic children with the right heart dilatation. My case examples are. So this is the 11 months old female child with a weight of 7.8 kg. The ASD size was, ASD size is 11 mm, and there are two defects, but the separation between these two defects are less than 7 mm. So we plan to do a closure with a single device. So we did it, and both the defects were closed. Yeah. So this is a left upper pulmonary vein approach. So second case is the 1 year 4 months old male child with a weight of 9.7 kg. The A size was 16 mm. So we used 18 mm amplatzer ductal occluder. So this is also from a left upper pulmonary venous approach. this is the third case of it's a 2-year-old male child with a weight of 10.4 kg. The size of the ASD was 20 mm. And we plan to close the device 22 mm size. So this again is left upper pulmonary venous approach. So another case of 1-year-old female child with weight of 8.2 kg, size of 20 mm, we use 22 mm. So advantage of early closures, thin and floppy margins were our initial concerns, but we had a 19% successful rate deployment. So in our past experiences, delayed intervention resulted in unsuitable for device closure due to disruption of thin margins, especially IVC rim. Early intervention, especially less than 1 year, can avoid recurrent OPD visits or admissions for the treatment of recurrent respiratory infections and heart failure, thereby saving the total cost of the treatment. Our studies showed low risk of complications with the experienced operator. So our center, 15 years data, we took it out. So the period of collection of 2010 to 2024, the total number of age device closures were 2,192. The total number of age device closures done under 2 years of 275. The percentage of children under, device closure under 2 years were 12.5%. So weight, the range of 4.5 to 14 kg, median age weight was 8.6 kg, age size 7 to 24 mm, median size of the defect was 13 mm, device size was 9 to 26 mm, median size was 15 mm. So age-wise, so less than 1 year, the approximate percentage of the within levels less than 2 years is 30%. So device closure loss size is in small children is a challenging task in view of small caliber vessels, thin and pliable atrial rims, require larger sheaths and devices. And before 2019, we used TE for TE and fluoroscopy guidance for deployment, and almost more than 90% of the children. But subsequently, we used only TTE. So we no major complications observed in these periods, and a few had premature atrial complex, including atrial by Germany, substituted within 12 hours of procedure. The selection of the devices, so 2 to 3 mm more than the actual defect size, and device size used from 9 mm to 26 mm. All patients were discharged from the hospital the next day with the antiplatelets. Conclusion, so transcatheter close of age in less than 2 years old children are feasible, relatively safe, cheaper in overall management of ASD. Early closure can avoid surgery since some of them become unsuitable for device closure due to disruption of thin atrial margins. No complications were observed in our 15 years of follow-up. So no need of delaying the closure of large ASD to the later age. Thank you.
Thank you very much. That's a stimulating start. Any burning questions? One quick question. GT, I can see.
Yeah. I find that your hypothesis on the resorption of the IVC rim, is it really happening in your experience? Because it will like shift all our practice to closing more earlier rather than later.
Yeah, that's what I observed. Earlier we used to postpone the cases because of the small child, and then later on, earlier it was IVC rims we used to see, thought we can device closure later on, but those cases we follow later on become thin, so then we had to send for surgery.
It's just an observation.
Yeah, observation, I done it.
Okay, one more question, then we'll move.
Thank you for one fantastic talk. Did you have any patient who suffered from AV block and you have to downsize the device?
Pardon?
Did you have any patient who showed AV block after the device
No, I did not. This what I showed. There's a few cases had a transient first degree block, but subsequently it's reverted back. I did not have any permanent heart blocks.
Okay, thank you.
One quick question. Do you have, can you make a recommendation about device to weight ratio that above which you would say is too big for the defect?
So I recommend for the devices, the suitable for the device closure can be done daily. So
is there a ratio which would be too much for the small size of the baby?
So initially, actually, it started as small, then later on increased in size, but did not find any problem complications, and even during procedure and subsequently also.
All right, great. Thank you very much for starting us off. And we're going to go live to Tin's Children's Hospital, I think. Yeah. Good, good morning, Tin.
This morning we will bring a very delicious breakfast for you. And my fellow Dr. Willie, you can present again in our purpose. The first case I say today is the ASD daughter. I would like to present this case. This 4 years old female, full body weight 18 kilograms, unequal between was diagnosed cancer through light echocardiography. Chest X-ray and ECG show pulmonary and private for hypertrophy. On echocardiography, so ASD, ostium secundum diameter from 12 to 15 mm, left horizon. However, the epicundum and epicundum is deficiency. Yes. And so echo. Oh, nice. Hi there. Yeah. Comfortable with the left horizon, directed upward, INRD. On flat view, we can see the aortic really what deficiency. The diameter of epicundum approximately 3 mm. And by table, you can see that ostium, the defect is close to FD3 and FD3 in the slope.
Okay. So,
And,
Tin, are you doing this under TOE guidance or transthoracic?
how to know?
Ah, yes, I'm guessing.
And theory guidance.
Okay, so today we've got a secondum ASD in a 4-year-old, as we've seen. Quite an interesting section, slightly malaligned. The maximum measurements we're getting are around 14 millimeters, 15 millimeters. And we can just go through, this is the measurement at 0 degrees, where it's 10. There is no aortic rim, but the other rims are very good. Anteposteriorly, the rims are a bit deficient, but intraposteriorly, they're quite good. So you can see here we're getting measurements between 13 up to 15 and a half. And you can see very small aortic rim there, almost bold. But interestingly, I think this section is a little bit malaligned, so adjustment of this section is going to be needed. But generally speaking, it looks like quite amenable. This is a big right heart, as we saw. And you can see initially here, we've got that septum that's slanting off a little bit in towards the left atrium there. So we just need to bear that in mind as we're going along. And as I say, the measurements don't really exceed 15. This is 130, so we've got good rims, AV valve rim is good, convolution rim is good as well. If we just flick forward to the 3D, you can see a gibbous tendon defect, which is very amenable to device closure, I think. Measurements on 3D are about 13 and a half by 11, so in the same ballpark that we're looking at. And here you can just see on both views, from the left atrial side here, and from the right atrial side, decent rim defect to the aortic. That's what we've got to start with.
Okay, thank you. Lovely pictures, Sal. All right, Tin, before you carry on, let me just ask, Joachim, we got a microphone? I'll give you mine. I'll give you mine. Balloon size, or have you decided on a device size already based on those images?
Well, I personally balloon size ASDs if they're not too big. If they're too big, balloon sizing doesn't do it. I would balloon size, but I think it's going to be a 15 or 16 ASD.
Okay. Martin?
I would go for balloon sizing maybe. If the septum is not too floppy.
I think I don't think balancing is needed.
Yeah. Okay. Hisashi?
Yes, I prefer the balloon sighting. So in this case, balloon sighting.
Okay. All right. So it looks like everybody will do balloon sizing and then decide. Tin, what's your plan? Yeah, go on. I can't see one in SVC. Now you're coming. So Joachim, any experience with pure echo-guided device closure?
Well, the ones I've done, it's because when I'm traveling, sometimes the cath lab shuts down. So then you have to learn to do. I have a very different technique, though. I select the size, I bring my sheet in the array, then I just open part of the left disk, so it makes a bubble. And then with this, it's very easy to see an echo, and it's very easy to cross the ASD then.
But then you don't. It's more
don't put that
challenging.
wire. I don't put.
But
I don't do an
also,
exchange.
you don't. You presumably don't do balloon sizing.
No, no.
Then.
In those
Yeah,
cases,
yeah.
I won't.
Yeah.
When I'm doing pure echo guidance, the exchange wire, I think it can be dangerous. You don't know where the tip of your catheter is. You might just perforate the atria, the appendage. So I just do like I told you. I open the left disc in the right atrium as a bubble, and then you can steer it.
Mulyadi, Mulyadi? Mulyadi?
By the way, it would be very nice if companies would develop catheters with better echogenic tips.
Yeah. Yep. Just on the point that Joachim was making, Tin, and Sal will probably tell you as well, what we tend to do is when we're doing fluoro-free but TE guidance, we get the sheath up in the SVC, then whatever device we've selected, make an onion of the device in the SVC, withdraw that, rotate it, and it usually flicks across, and then you open up the left atrial disc and so on. Robin, go ahead.
Yeah, so on that point, actually, Dr. Pan from Fuwai actually designed a wire particular for this echo-guided procedure called a panel wire, where there is a nitinol knitted pointed tip that you can actually see very nicely on echo, and it can be delivered through a full French catheter.
But we need things like that for the catheters and everything, don't we? I thought he was going to do balloon size. So, Tin, so what size device have you selected? Hmm? Yeah. Okay.
And now you see, we show you some plasma device because the profile of the device, the smallest one. And it's more convenient for them to copy. Yep. And now the device goes into the tip of the tip and open the tip in the left side. And then open the tip in the
Can you go? Oh, too slow. I was going to say go slowly so everybody can see it. But now you've done it. No, I don't want you to take it out now.
sorry, can you say your name on the screen and my name? And I should open the this a little bit faster in case the left side this will collapse to the right atrium very soon.
Yeah.
Dietmar, good morning. May I have additional questions at first? The weight of the patient is, also age 4 years, and the weight is 12 or 14?
14.
14. And you use 18 millimeter. What is your maximum at first? I want to know. In such a...
In my experience, the maximum size of the device is body weight plus 10.
10?
The question is,
Okay.
14 years cannot go use the device more than 24.
Do you measure the distance of the total atrial septum in total, also in 2 dimensions? Is this a criteria for you too, in addition? That you goes...
On the small patients, we measure about the total length of the septum. It's very important for us to select the device, size of the device.
So you have now...
Normally,
You have 32 millimeter on the left side now. Is it correct?
Well, not exactly.
Yeah, I want to ask. Also, I want to learn. So
just a simple, short question, Dietmar. What is it you want to know?
I want to know what is the maximum what he would use in this patient age and weight.
Okay, let me ask Joachim.
Well, I agree with Tin that we could put 22, 24. Not necessarily, I mean, this defect doesn't need it. But I personally don't measure the length of the septum.
No, I don't.
First of all, the left disc of the device is not going to measure 32 millimeters because the device is constricted.
Yeah.
It measures 32 in the package, but not in the heart.
So is there a ratio of device to body weight that you work with or not?
No, I look, but as I told you, if it's too big, I don't balloon size because it's useless. I will look at the septum and try a device.
Yeah.
The thing that tells me that the device is too big is if you create mitral insufficiency. Many times the device is going to touch, but it doesn't create.
Okay.
If you have mitral insufficiency, then obviously you need to undersize.
Martin, do you have a working ratio for small babies? Device to the weight?
I don't know. I always measure the size of the septum, of course, and then I do the balloon sizing, and at least I use X-ray because we are less than 1 minute in this.
Yeah.
I don't see anything to.
Mulya, do you have a...
And Martin, addition. Do you use TE and makes an anesthesia, or do you do it by X-ray in the sedation?
So I have a TOE and general anesthesia as well.
Anesthesia?
Yes.
You didn't learn it by house stuff.
In this case, you can do both. He has wonderful, I'm sure she has wonderful transthoracic windows.
In my experience, I always measure the left atrial diameter. So the device that I use not less than the diameter.
Okay. All right, Tin, how far have you got now in your assessment?
We are waiting for the leads are not.
So, Tim, the only thing, I mean, it looks really good, the device. The only thing is the splaying around the aorta. It's not so splayed around the aorta, considering there's no aortic rim. Are you happy with that?
Yeah, I have to.
Okay, if you're happy, that's fine.
You don't do stability testing then?
Yeah, I can do.
Okay. Okay, well, go for it, because we'll then move. Yeah, that wasn't a very aggressive wiggle, was it, really? I didn't see it. It's all right, you don't need to repeat it. No, you don't need to repeat it, because you'll blame me. Okay. So what are you going to do? Look. Yeah.
Okay, so which view would you want me to bring in 45?
It's up to you.
45 is always good. You can see the cable in the middle of the release.
Okay, and release. Charles said it's okay, it's okay. And release embolize, not much.
It won't embolize.
Yeah.
It won't embolize.
Yeah. Yep.
Tin, was this the new, I mean, the delivery system, the Trevisio? Or was it the regular system?
This is Trevisio.
What do you think about the Trevisio? Do you like it?
It's all right. I mean, it's better than. Yeah. GT.
Yes. I think I like the Trevisio, the marker. It helps a lot. Yeah, especially you're doing for this kind of non-fluoroscopy. The marker in the Trevisio. Tin, since you can do it every time nowadays without fluoroscopy, is this going to be your standard of practice nowadays to do under non-fluoroscopic procedure for ASD? Tin.
I am many years ago,
Yeah.
and we started in maybe 10 years ago. But using non-fluoroscopy, we try to do something better for the patient. We just want to free from anything for the patient. And so we
All right. Straight after this, then, I think.
okay. We don't want to do the
Yeah.
complicated
Oh.
we do the maybe more complication.
Okay.
I think just the sound today okay.
Oh. Okay.
Tin, great demonstration, non-fluoroscopy, excellent images of TOE, and a very good result. So thank you very much indeed. We'll leave you and move to. All right, thank you. Let's move to Apollo Hospital in India. Nothing. Yeah. So who's there? Bhushan, I think it should be.
Yeah, check. I have one brief comment. In non-fluoroscopic imaging is also very important. But as nowadays, non-T, the eyes, that much more.
Well, that may be an important point to address later on, but because they're all waiting live. Yeah, good morning.
Yeah, good morning. From India, Navi Mumbai, I can feel the vibes of Vietnam. My boss has already done a very excellent case in the beginning. So thank you for this opportunity. So we started with a live case. Dr. Farid is going to present the PowerPoint presentation. Thereafter we will start.
So we presented the 33-year case of 33-year-old female, mother of 3 children with unwanted pregnancy, incidentally detected to have ASD on routine health checkup. She is currently asymptomatic. On examination, she is clinical with weight of 40 kg, saturation of 100%. On pre-surgery examination, there is cardiomegaly with S1 normal, S wide and 6 split, and grade 3 by 6 ejection systolic normal in the left upper sternal bottom. This is a chest X-ray of the patient which shows cytosolitis, phlebocardia, cardiomegaly, dilated artery. PR interval of 160 seconds, and QRS axis of plus 90 with right buttons as shown. There is a crossover time between these three areas also. These are the key images of the patient. So we can see at 0 degrees there is a large second of neuropathy with a good amount of mitral margin which can be appreciated. The defect measures 36 mm. This is the other, at 63 degrees, where we are seeing the retroaortic rim and that is the aortic rim along with the posterior rim also. So we can see there is a borderline small posterior rim. And this is the other images of 90 degree and 106, where we can see there is a borderline small posterior and inferior rim with adequate SBC rim which is seen. These are the measurements in the other angles, that is 34 mm and 22 mm.
So this is a 33-year-old lady with a large section ASD, and the maximum diameter of the defect varies between around 30 to 36 mm. We have a deficient retroaortic rim and a very small posterior rim, while the IVC rim appears to be just borderline and floppy. We have just done the baseline hemodynamics for this patient. There is a significant step up. The SVC saturations are around 70% and the PA saturations are around 95. The LVDP is normal. So we start from here, and we plan to do balloon sizing and probably a balloon to support large ASD device only. So any questions from?
All right, very good. Any questions for Bhushan? One approach you could easily take, I suppose, again, we always worry about costs, but it probably is less of a problem, is that you said something along the lines of 36 was the biggest size. So go for the largest device, 40 millimeters, without balloon sizing, and if it fits and sticks, it's fine, and if it doesn't, then you know. Teji?
Yes, this is a very big ASD. And even the common practice, patient is asymptomatic, even this kind of big ASD. And patient have no medications.
Yeah.
That's right. So that in this kind of situation, we put in that heart failure management first, diuretics for few weeks or few days, that almost always ASD shrink 1 or 2 millimeter. So 36, 34.
Yeah. Well, I don't think it's very good because once you close the ASD, the left atrium is going to, so you'll end up having the same diameter as before.
No, it's after the closure, it's a shrink.
Yeah.
Because the shunt is closed.
Okay. All right. Yeah. Go on. Sorry, Bhushan. Yeah.
So this patient was already on diuretics and ARBs for the last couple of weeks, and today when we have done the TEEs, the size does look like around 34.
So whilst you're talking, if you can carry on doing things as well, just so that we don't slow things down. Yeah.
So we'll go today now with across the ASD, and we'll plan with balloon sizing. So usually for balloon sizing, what we routinely do is I use the right upper pulmonary vein technique, as it gives a good support to the patient. The rims are not squashed. On the contrary, the rims get well separated. So this left upper vein I will keep for the access for the device.
And so at the moment, just for practical question, have you got bilateral femoral vein access?
Yes, sir.
Yeah.
Two femoral accesses
Yeah.
and one femoral artery for pressure monitoring.
Yeah.
So this is my suprasphincter wire in the left upper pulmonary vein. And we have already taken the PA pressures before with the reading of 20. Now we go from the, this is from the left femoral axis. Now we go from the right femoral axis.
Any comments about balloon sizing from Mulyadi? Do you do balloon sizing in such a large defect or not?
Yeah, in my experience, I very rare to use balloon sizing. Very rare.
So on the images you've seen, what device would you be choosing?
Yeah, even in the big HD.
Which?
I'll choose to use left upper prevent assisted technique first.
And what diameter?
At last, I use balloon sizing technique assisted if fail.
And what diameter device? The size of the device, what would you use? Because the measurements were around 34.
Usually the size time 1.4. The size time by 1.4.
Okay, so what's 34 times 1.4? Because
1.4 time to the...
What's 34 times 1.4?
Yeah, to measure, size.
So what device size would you use? You worked it out, have you?
Yeah, 24 to 26.
Yeah. There's no device 47, is there? Or certainly not in UK. So then do you use a lower ratio? Okay.
She'll end up with the biggest device
40,
available.
Oh, sorry, William. Oh, no, it's not William, it's Dietmar.
What is the left ventricle end-diastolic pressure now?
Oh,
you have a wonderful pigtail catheter in the left ventricle. What's the end-diastolic pressure now in the left ventricle? By closing the ASD by the balloon?
Yeah. What was it before?
Normal. Yeah. What is now?
Yeah,
after closure?
I'm trying to find out what it was, the number, not...
9.
No, they said high, was it, or not?
What is now the end diastolic pressure? Because I guess that is the same.
At what? What is it, the number? 9, okay.
Okay.
Is the ASD occluded now?
Well, I'm assuming the balloons inflate. Yeah. Yeah. It's 200 scale. Yeah, let's have a quick look at the TE. We've seen the pressures. Yeah. Okay, yeah. And that looks like no flow or tiny bit there. Yeah. No. There's a bit of leak, yeah, so on 45 view. Okay. So, what's the diameter of the balloon now? You can see a little indentation on it. So if you could get diameter of the balloon measured on fluoro and TOE. And then we can ask Joachim what device to use. They're doing it. Yeah, I mean, looking at that, as I said earlier, I would have just tried the 40 and see if it stuck or not. $30? Yeah, measurements are not wrong. Correct. It looks, I mean, if it's a 34 balloon, and you've pretty much fully inflated, so it should be at least 34.
Can you
And
measure?
are they measuring the balloon on the fluoro as well?
Yeah.
Whereas as same as the other members in
What's the measurement?
big
Sorry?
ASD, it's almost always that
Hold on,
balloon-
Teji. Hold on. Sorry, what? We can't read the measurements. What are they? Oh, it's not calibrated.
How much?
Yeah.
Oh, it's pixels.
Sorry, Teji, now you can go on.
Yes, the transesophageal echographic echo monitoring balloon is over the out of the screen, so that almost very difficult to measuring for the T measurement for bigger ASD.
Yeah.
Yeah. I don't do balloon sizing.
People who started doing ASDs a long time ago, we used to measure the balloon with the plate.
Yeah.
And there was nothing more precise than this.
Absolutely, yeah. Yep. Technology has moved on.
They stopped providing it, but it was very useful.
Yeah.
Because here they're calibrating with a catheter, and they're measuring something that is going to be 20 times as big as their catheter, so the calibration is going to be inaccurate.
Miro, you can calibrate with the balloon. The balloon, there's a marker there. So this balloon got a marker. You calibrate with the bigger marker, easier.
Yeah, the problem in different softwares is that you can't. There are some machines that don't calibrate that length.
Then you can do a like what we used to do when we had, the angiography is not numeric.
Yeah.
We would calibrate by hand and.
So what does that measurement say? That's complete rubbish, isn't it?
Well, it's something doesn't fit, because if they had measurements at 34 on 2D, they should never. They should not have complete occlusion unless it's a very, very ovale ASD. But something is not fitting.
So, yeah. Well, it doesn't look as if we can believe anything, so I would try 40.
Well, no,
but
there's something. I think we have to put everything together before choosing a device.
Yeah. Now I'm going to ask Dietmar.
Instead, you measure the balloon now. I would measure the marker at first and looking if it is 1 centimeter or not, or 2 centimeter.
It's supposed
and
to
then
be 15
you
millimeters.
can calculate the balloon.
I think the big markers are separated, but 15 millimeters in this type of catheter.
Mm-hmm.
So what did the TOE say?
Same thing, 30.
30.
30, the T said 30.
Have you got any better views of TOE so that you might be able to get some measurements there? Because your fluoroscopy is not giving an accurate measurement.
And again, what was the balloon size? Which balloon is it?
It's a 34.
34 balloon.
Which company? Okay. All right.
If it's a 34 balloon, I would go for a 36 device at least.
At least. Mm-hmm. Okay.
Well, yeah. He's putting a 34. What is he putting?
Well, I think he's thinking of 36 device.
Good.
Oh, and with your, your measurements on the fluoro calibration doesn't seem to be right. But Are you able to calibrate against the dots or markers on the balloon? Yeah.
In Canada, what I would do is what we call a device sizing, is that we would put a 36, and if it doesn't work, the thing is that in Canada, they charge me for only one device. I don't know how it is in UK, but the distributors, if I use two devices because the first one was not properly sizing, they just will charge me one device. And I think it's very good policy because then you'll have less complications.
Correct. Okay, so carry on. What have you got any further? Because we'll have to move you. Yeah. 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 Okay. And have you made the final decision on the size? Okay. So 36 device, yeah?
Makes sense.
And which one? Yeah. Okay. And if you, I'm not trying to put a spell on you, but if you use a 36 and it comes through and you have to upsize to 38, do you pay the company for 2 devices or 1? Well, many of the audience, companies only charge for the device that stays in the heart.
Well, for one device.
Right, okay.
No device stays in the heart. They still charge me for one device,
right.
but not for 2 if I need to change the device.
Okay. All right. So tell us what you've got at the moment. So you've got a catheter in the right upper pulmonary vein. Okay. So you're going to deliver the device from the right upper approach, yeah?
Yes.
Okay.
While they're doing this, in countries with lower resources, let's say you put a device that doesn't work, do you re-sterilize it and give it to another patient? I would. I've done it, by the way. I've done it.
Well, in Canada?
Not in Canada, but when I travel, we have a device that didn't work. We put it, we sterilize it with peroxide so all the blood goes away, send it to...
So I have no idea. I daren't speak on behalf of those countries. But Bharat, did you pick up on Joachim's question about...
Yeah, we have not been sterilizing any of the devices.
No.
But they look like new,
but I'm
by the way.
aware, Joachim, no, I'm aware because of the prevailing circumstances, some of the centers do keep those devices and get them re-sterilized and reused.
Sure. And you give it to somebody who cannot pay. It's not...
Yeah. But it used to be done a long time ago, but not now, I don't think.
Yeah.
Okay. Anybody else? Any other countries or centers that re-sterilize? Yeah, go ahead, Sushil. Yeah.
We do re-sterilize the devices many a times because of the cost issues. So
Yeah.
we do
and then re-sterilize and use it in a different patient, yes?
Yes, we do that.
Yeah, okay.
And how do you re-sterilize?
We have a ETO system there. Ethylene, they have a different system to re-sterilize. I don't remember exactly, but yes.
Mm-hmm. Okay. All right. So let's get back to you. Yeah. Okay.
So why did you change to the left upper?
He wasn't getting stability. Bit closer. Oh, never mind.
How big is the left disc of this umbrella? What size?
So what's the diameter of the left atrial disc? Martin wants to know. What's the diameter of the left atrial disc? Yeah, but 14, yeah. 1, 4, yeah. So 50. My maths is a bit better. Yeah. There are some And when you're doing this, yeah. So whilst when you're doing this, do you stay in AP projection or do you go LAO or any thoughts on that?
Yeah,
Yeah.
lateral for the IVC rim is very good.
Yeah.
But for the rest of the device, LAO cranial is very good.
Yeah.
I always deploy my devices using LAO cranial. It's only, I mean, you see it immediately if the device is well positioned.
No, just a comment on the projections. I think with transesophageal or intracardiac imaging, fluoroscopic projection really makes very little difference, at least in our experience, irrespective of whether you go LAO or frontal for deployment. Because most of the assessment will be on TOE.
Yeah, okay. So, yeah. You don't flush?
Sorry. You're not just checking that there's no bubble. You don't draw blood or something.
Any flushing or blood?
Yeah, I know. Well, I would still.
I would, yeah, old-fashioned.
I would still open the valve and see if there's just a couple of bubbles of blood, but it's okay.
Can you show us TOE, TOE as well as the fluoro, if you could split screen? Yeah, but we can't see fluoro. We can only see the echo. Okay. Yep. I was just trying to see the mitral valve on the. Mhm. Yeah, looks good on that view. Mhm. Mm. Yep. Yeah.
It's
Did you
actually,
remove the wire from
it
the
actually
balloon?
looks oversized.
Yeah, if anything, yes. Is the wire? The wire is still in place, isn't it?
Yeah.
Yeah. Because you might as well now move that just to align the device.
Can you show the ECG?
I would remove the wire from the balloon.
The end diastolic will not increase immediately because the device is so leaking in the first minutes. It's in the evening that she will do pulmonary edema.
Yeah, but
did you have
30 something?
Did you have ST changes? Is it the same ST segment? Okay. Good, good.
Okay, so yeah, let's see the fluoro.
Maybe you have to look for the coronaries or you have to remove it.
Yeah.
Yeah. Well, yeah, even
Yeah.
32, honestly. Could you go on LAO and show us the separation of the disc? They seem very, very separated.
Very quickly because the other center's waiting as well now.
It's extremely oversized. It's
So
extremely.
maybe the measurements were okay.
Yeah, I think the balloon measurement was okay. The thing that was not okay was the initial measurement at 34.
Yeah.
I mean,
And
but it's
I'm
definitely.
not going to ask you to do this, but normally I would say, can you measure the waist on the device?
Well, it's.
Yeah, but it may be inaccurate. Yeah. But let's do the final release because they're ready in Calcutta.
The waist is going to measure exactly 30.
Or less.
Or 32. But it's very, very oversized.
Yeah. And then very brief, quick look at the TOE.
Your LifeTech device, the delivery cable is a normal cable or is it articulated? It's a normal cable, huh?
Yeah.
And it's quite stiff, huh?
Yeah. TOE images, and then we'll cut away from you.
What is the ECG now and the blood pressure and the coronaries? Please, I would like to see it.
EDP is unchanged. Coronary is unchanged. EDP is lower. It's all right. I'm having a go at Dietmar. Yeah, quick look at the TOE because we've got to move away from you shortly.
The device now look better.
TOE images.
Just one comment. The experience with the LifeTech devices, the larger LifeTech devices, that immediately post-deployment, the LA does always look a little bulkier. By next day, it usually conforms its shape. So that is the reason why it is looking little oversized now.
Yeah.
But if you come and look at next day, on the echo itself, you will see that it has taken its shape. That's the problem with the LifeTech device, larger size.
All right, so very quick color Doppler on that. Especially on the mitral side.
The discs look less separated after release.
And now the device, no, good. And now the device, just look at any leaks on that view, looks good. And short axis. Yeah, okay. So that looks very good. That looks very good result. As Joachim says, it looks a bit oversized, but I think that's as good as you're going to get. So thank you very much for that excellent demonstration. Well done to the team. All right. Okay, well done. So we're going to move away to Calcutta now, Narayana Hospital. Amitabh Chattopadhyay. Can we connect up with Amitabh, please? Amitabh? Can you hear us? Hello? Amitabh, can you hear us? Hello? Can you hear us? Yeah, good morning. Can you hear us? Thank you. Yeah, absolutely. So let's get you started and case presentation. So the drainage is in the right ventricle, which part? Inlet or a? Any suggestions for Amitabh, Joachim? I mean, yeah. And your plan also, your plan is to plug at the right ventricular end, or are you going to do multiple? Okay.
That's a good plan.
All right. So let's, we're a bit behind, so let's keep you moving. Okay. So we can come back to you then when you've done that, yeah? Oh. Okay. Amitabh, we can't hear you. Yeah. Okay, no, this is interesting. So, all right, we'll come back to you when you've done the balloon interrogation. Right, okay, thank you. All right, we better move on. So let's get Sushil on the stage for back to the lectures. Elderly patients this time. Sushil, sorry about this. Go back and have a sit. Have a seat again, because Tin's ready now. All right, let's join Tin then. Tin? Tin, can you hear us? Oh, we were told you were ready. That's why we linked up with you, because we're behind on lectures. Okay, so present the case, then we can decide on going back to a lecture after that. Just pass me mine. Okay. So, yeah, so just remind us of the weight, because we've now got 22 diameter of the defect. 12. Okay. Yeah. So that's quite an impressive defect. Any suggestions or from the audience? Anybody? Bharat? Impressive?
Yeah, I think it's a very impressive defect, but I think probably doable. Apart from the technical considerations of getting the device sit properly, the other issues I have dealing with such large defects in children is the AV conduction.
Yeah.
I really get a little concerned about AV conduction with such large defects.
So attempt or not attempt? That's the
I
first.
would definitely attempt.
Attempt, okay.
Definitely.
And device size?
Maybe we would balloon size and not add any millimeter to whatever the balloon diameter we get by stop flow technique.
Yeah.
And if I have to just go by imaging, then maybe if the maximum diameter is 22, I would go by 22.
22, okay. Martin?
Just a question to Gareth. Why don't you send the patient to the surgeon to do them exercise ASD occlusion in the OR.
Okay, show of hands in the audience if you're going to proceed with catheter closure of this defect. Show of hands. And those who would refer directly for surgery? Okay, still majority for catheter closure. Yeah, I think it was. I think we can tell you anything we like, make it complex, and Tin will probably do it in sort of 5 seconds.
That is a very complex case, and so I need his guidance for example, and I stay outside.
Oh, you've got Warwick there as well, yes. Yeah. Okay, so that's reasonable. So who's, I'm confused now. So is Warwick doing this or Tin or you? Okay.
But sadly, we asked questions for the audience too, like what kind of device do they prefer? Because yeah, we have Octec and the Amosec. We don't have the Theraplex on it. So what do you guys think?
Well, I think it's not a good question to ask really, because they'll use whatever is available to them rather than choose. Yeah.
For the same size, Amplatzer devices are slightly stiffer.
Yeah.
So I would use an Amplatz device in this patient.
Okay. Well, I would use an Occlutech or a softer device, but for the same logic. Hmm?
We'll end up putting a bigger device.
Yeah, yeah.
Than the Amplatz.
Mm-hmm.
And then this one they talked also technically, we think we need enablement at least
So,
maybe just 12 kilograms.
okay. Warwick, what size sheath is this? I missed it.
It's 9 French.
9 French. And the device is 22 in the end, or 24? Oh, 24. Sorry. Yeah. Okay.
I personally would have put a larger sheet because there's chances that you will need to recapture this device.
Yeah.
And 9 French is really the minimum sheet you can use with a 24. So I would have used maybe even a 12. So if it embolizes, you're ready to get it out.
Yeah. Okay. Yeah. Joachim is being optimistic for you.
But I mean, she can get a 12 French sheet. Going to pop.
Oh. God, that was quicker than Tin.
Looks nice. It looks very nice.
Yeah. Okay, shall we make the echo bigger? Because pictures look good.
Perfect. When, just to make a point, when people measure the length of the septum, definitely we underestimate what we can put. You see the left disc of, it's over the plane of the crux of the heart, and on the other side, the left disc gets a little bit into the pulmonary vein.
Yeah.
So this is why measuring the septum makes no sense.
Yeah. So, comment on the left atrial disc and the mitral valve, Sal. So, yeah. Hisashi, what do you think of the pictures at the moment, Hisashi? Would you be happy with that or release it if it came to it?
I think so the mitral valve touching is the concern. So to reduce the size, the 22 or something, 22.
So you would release it?
No, let
Oh.
leave and change to the smaller size.
Right. Okay, Mulyadi, what would you do?
I think the device look like larger, yeah.
It's what?
Yeah, maybe 22 is okay.
So would you release with
Yeah,
that?
I agree. Release.
You release, yeah. Martin?
I wouldn't release because the aortic root looks a little bit sandwiched, so I would go for a smaller device.
Okay. 20 what?
20.
20 or 22? 20. Okay. Joachim?
I would keep it. Maybe a 22 would have been okay, but I wouldn't retrieve this one. Is AV conduction normal? The PR is not longer? It's fine. Because it's a posterior, the posterior ASD, so it's...
Yeah. Gareth? Mm. Yeah, I agree. Jonas?
Can I see that TE again? I am worried about the indentation created in the aorta. Aren't we not concerned about that too? On top of the mitral valve being...
Yeah, that's always going to be a concern, really, in the longer term. But what we saw was not too bad indentation, I think.
The mitral is not an issue because the left atrium is going to grow and it's going to push.
Okay.
If it was an adult, it would be different.
Yeah.
But
So,
in a child,
Warwick, what have you decided, Gareth? Yeah. Sal, yeah. After 100, also 150, look at the mitral that way. Mm. And on 150, Sal, look at the mitral. Bring the anterior leaflet in. Yeah. Mm. Yeah. Okay. Let me just get final word from Warren. Let me just get final word for Bharat, and then we'll move you on. Bharat.
No, my concern is a mitral valve. I think hurting a mitral valve would be a disaster in a child like this. I would definitely consider doing it with a 22. Although Gareth says that it will not make a difference, I think for a child of this size, there is no harm in trying a 22.
Yeah. Okay, fair point. Okay, so Gareth, Tin, Warren, what are you going to decide?
Tin, can we measure the waist of the device, please? Waist of the device, if you can measure. And even on echo.
So, Warren or Tin, would you consider downsizing? Mm. I think what are you getting the disc to be on the TOE? Yeah. I think for me, it's all or nothing. It's either this or you stop and refer surgery. Okay. All right. Warren, decide. 10. Okay. Yep. Yeah. So either release or retrieve, because they're waiting for us in India now. And there's no way this is going to move, is it, once you release it? It's so big. Yeah, didn't change an angle at all. And so make the echo big.
Yeah, check your mitral valve now.
And look at the mitral, yes.
Definitely a 22 would have fit, but I think it's very nice like this. See,
yeah.
It seems like the mitral valve has disappeared, like the mitral insufficiency, because there was some traction from the.
Yeah.
Oh, it's still there.
Whiff, yeah.
But it's definitely not bigger.
I think Joachim meant mitral valves disappeared.
You know, Shaq, one
Yeah.
of the things is when you put such a large device, and if you were to traumatize the mitral valve, even the surgical access to the mitral valve becomes a nightmare for the surgeon, believe me.
Yeah, very good point. Okay, Gareth, Tin, Warwick, thank you for that. We've got to move on. Yeah. Okay. All right. Well done. All right. Let's go back to Amitabh in Kolkata. All right. Amitabh, can you hear us? Amitabh, can you hear us? We're back with you. We're back with. How long was the balloon inflated for? Yeah. And what is the waist? What is the waist on the balloon at the neck? So, Amitabh. 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 Amitabh, stop talking. I'm guessing he can't hear me. Does anybody know what size device this is or what type? So it's MFO at least, I caught that.
No, it's not an MFO.
Hmm?
Is it?
I think so.
Shaq, I think he said 10.8 MFO.
10.8?
MFO, he said.
MFO, okay.
Yeah.
Yeah, I can't.
What is this thing going up?
Well, I want to see it in a different plane. Well, can you hear us, first of all? Ah, well, I was trying earlier on, but is there a check angio now? Because before you release it, you've still got a guide wire circuit, haven't you, or not? Oh. Okay. And different projection as well, or not?
What's the coronary coming up now?
So what is on, I wanted to see the different projection, because when you see the native coronary, it's also filling, it's cross-filling something else.
Can we have a look at the ECG?
Okay, so what is that branch?
It goes. Does he have a
What?
normal left coronary?
Yeah, what is that branch going across to the left, so posteriorly?
Doesn't that look like the left system, but it doesn't wash out properly from the aortic end?
So what do you think it is, Alison?
It's interesting collateralization. I would expect that it should spill off into the aortic sinus if that opening was patent, but it looks like it's stenosed.
And the small one, is it the sinus node artery, or what is it?
Yeah, well, right at the top.
This,
Very interesting. I don't know about trying to see the left coronary directly from the left sinus. Maybe on your pre-procedural CTA you had a clue.
Bharat?
Yeah, this looks, this looks like a circumflex artery to me. So I would like to see what was the left angiogram before the
Sorry,
No, I don't think root angio is good enough. In this case, you must have a selective left angio to know what is the configuration of the left artery.
Yeah. Okay, in practical terms, in practical terms, you've got a guide wire circuit with a device alongside it. So are you going to break the circuit first, or remove the wire first, and then release the device, or are you going to keep the circuit? Okay. Okay, well, let's keep you moving. Change the curve. I think so, yeah. Use the 3.5 then. So you're going to change the curve of the gel? On the original CT scan, did you have a clue about the left coronary system? Okay. Mm. Yeah. Bharat?
No, no, the thing is, Shaq, if it is a point atresia of the left circumflex, on a CT scan to make out that there is a interruption of the flow at the level of the origin of circumflex may be difficult unless you are really looking for it.
Yeah.
So I think better to do a selective
Yeah.
left system because of this finding on angiogram.
Yep.
The longer one.
It's even longer. Bigger. Amitabh, what I was going to suggest is if you take your time and sort that out, we will do one lecture, and then when you've clarified the picture about the left coronary, we'll come back to you. Okay? All right. So let's disconnect live transmission. We'll get Sushil back on elderly patients who seem to have got older since he started.
More older, sir. Thank you, organizers, for inviting me. So what I'm going to talk about ASD closure in elderly patients.
Let's disconnect the transmission and have Sushil's slides, please. Okay.
Okay, so what I'm going to talk about is the ASD closure in an elderly patients. So we all know that ASD closure is definitely recommended in all patients whenever there is an RA-RV volume overload without significant pulmonary hypertension, irrespective of the age of the patient. But there have always been concerns regarding the outcome in view of coexisting comorbidities and hemodynamic changes which happen over a period of time because of the age that the patient has. So what I'm going to discuss about all those things in a couple of case scenarios that I'm going to present. This was the first patient who presented to us. She was 65 years old, female with hypothyroidism, presented with typical chest pain which was radiating to the arms, presenting to the adult cardiologist. They did an angio. They evaluated the patient, did an angio, did an echo. Echo showed large atrial septal defect, but angio showed a critical coronary artery disease and subsequently underwent PTCA to the left anterior descending and ramus way back in 2022. She improved symptomatically, now presented to us for the evaluation and management of the atrial septal defect. Echo was done, which showed a large atrial septal defect with significant left to right shunt, moderate TR, moderate PH, significantly dilated RA-RV. Rhythm was sinus. There was a normal systolic biventricular function, but the LV function, the LV diastolic function was borderline with average E by E prime of 14.5, which was borderline LV diastolic dysfunction. We took up the patient for the cath lab. The aortic pressure was significantly higher, probably because of the anxiety, because it was under local anesthesia. The PA pressure was moderately elevated. The LV and diastolic pressure was 18 to 20, but there was significant shunt. QPQ was 5.2. The PVR was low, 1.6. So we decided to take up the patient for the device closure. And this was the TE images. The images, you can clearly see a significant large septal defect with significant left to right shunt. The size of the defect in various views was varying from 24 into 32 to 34 millimeters defect size. So it was a significant large defect. So the coronary angiogram was done prior to the procedures to check for the status of the stents. The stents were patent. The coronaries were normal. So routine procedure, the wire was placed in the right upper pulmonary vein, left upper pulmonary vein, and subsequently the ASD was closed with a 38 millimeter device size after creating a fenestrations using a 10 millimeter balloon. The size of fenestration was around 5 to 6 millimeters. This is how it looked before implanting the device. This was the fenestration that we created and subsequently implanted the device. And these were the TE images. After checking the stability of the device in various projections, the device looked stable with no valvular insufficiency. And this was the color. The fenestration was flowing with a left to right shunt across the fenestration. And this was the post-procedure hemodynamics. The LV and diastolic pressures had reduced down to 16. The PA pressures had also come down, probably because of the once we closed the shunt, the LV and diastolic pressures came down. The patient was kept on diuretics, and patient is doing subsequently very well. This was another case. A 67-year-old female presented to us with dyspnea on exertion, class 3, evaluated. ECG showed atrial fibrillation. Echo shows moderate TR with PH. They completely missed the ASD, and CT angio was dilated PAs. So because of the symptomatic status and they didn't detect the ASD, they did a coronary angiogram, and she was found to have a non-critical CAD with plaques in LCX and LA. She was managed symptomatically with diuretics since the echo was showing moderate pH. They started pulmonary vasodilators and was managed with antiarrhythmics, statins, and routine anticoagulation in view of atrial fibrillation. She presented to us in class 2. We did an echo. There was a large atrial septal defect of around 24 millimeter with significant left to right shunt. The PA pressures were moderately elevated with significantly dilated RA-RV. Again, the systolic function biventricular was normal, but the average E by E prime was slightly elevated around to 12.5, suggestive of covert LV diastolic dysfunction. Again, we took the patient for an angiogram. PA pressure was moderately elevated. LV and diastolic pressure was 18. QPQS was significant, 2.8. PVR was 3.7. So we took the patient up for the device closure. This was a pre-procedure T, a large atrial septal defect with significant aneurysmal interatrial septum. This defect size was approximately around 24 millimeters. So the coronary angiogram was done to recheck the status of the coronaries. There was non-critical coronary artery disease in the circ and the ramus, and it was non-critical, so we just decided to leave it. And we did a 32 since the atrial septum was aneurysmal. We decided to slightly oversize the device with 32 millimeter device after creating a fenestration in the device using an 8 millimeter balloon. And this was a post-procedure T. After looking at the stability of the device looked stable, and we put the on the color, the fenestration was flowing. There was a mild MR which was pre-existing before the device closure, so there was no change in the function of the mitral valve. So this was a post-procedure hemodynamics. The PA pressures had reduced, and the LV and diastolic pressures had also come down to 16. Now, ASD. So to discuss, the hemodynamics features are significantly different in elderly patients whenever the patient comes to a later age as compared to the young adults. And it is also complicated by the presence of comorbidities, because of the ASD has been there for a very large duration of the life, presents with pulmonary hypertension, arrhythmias, and the most important thing that worries before closure is the presence of LV diastolic dysfunction. It can be overt, it can be covert. We need to be very sure about this before contemplating closure of the defect. So ASD, technically, if the margins are adequate, it's not a problem because we've been doing it for a pretty long duration of time now. So technically, it is not a problem if the margins are adequate. And there have been a lot of studies which have happened now that even if the ASD is closed at an elderly age, it definitely improves the symptoms, and definitely there is a ventricular remodeling happens. There was a large meta-analysis which was published in 2023 in the Heart Journal, which showed that symptomatically it was a meta-analysis of 1,200 patients, approximately 1,200 patients more than 60 years of age, and it showed that it showed significant improvement in symptomatic status of all the patients, but only thing was that arrhythmias once set in, they didn't improve. And the major concern is because of once you suddenly close such large defects in elderly population is the abrupt elevation of the LV volume, LV preload, the LV diastolic pressures abruptly elevate. So ASD in such situation do serve as a pop-off, and once you close, the LV diastolic dysfunction can be unmasked in such situations. So we have to assess it very carefully. So there are two ways to assess this: either temporarily occlude the atrial septal defect, and if the pulmonary capillary wedge pressures or the LV and diastolic pressure is rising more than 10 millimeter from the baseline or going more than 20, it's definitely considered high risk. It's advisable to take the patient out of the cath lab, diurese him for a few weeks, and then come back again and check the LV and diastolic pressures and then take up the patient. The other way is because most of the time these changes happen abruptly and it's for a short duration before the LV starts to adjust, is to electively create a fenestration in the device, because this avoids the abrupt hemodynamic changes. The only issue is what size and how many fenestrations that you have to make. So that question is not depends on how high the LV and diastolic pressure is. Usually 4 to 5 millimeter fenestration is adequate, but sometimes if the LV and diastolic pressure is very high or the PA pressures are very high, you may need to create more than one fenestration. So this is an example. This was another example where we temporarily occluded the atrial septal defect. It was small, 12 to 14 millimeter defect. We occluded it. The LV diastolic pressure went up to 28. So we didn't close in this particular patient. So although, to conclude, the elderly, majority of the elderly patients are complicated with comorbidities, but still high procedural success rate can be achieved. Technically, it is not difficult. and significant functional improvement is expected, especially if the shunt is large. The only thing that we need to worry about is the left heart hemodynamics, which change abruptly after closure of the atrial septal defect. And we can usually avoid those changes by either electively creating a fenestrations or temporary balloon occluding if they are more than 20 millimeters of mercury, decongest them aggressively and come back later. Thank you.
Thank you very much, Sushil. We haven't got time for discussion because we're 1 hour behind already, so we'll move on and you can have questions during the coffee break. So let's move on to, I don't think Edwin Francis is here. Is that correct? Otherwise, we'll move to Teji. Teji, up next with multiple deformities.
Okay. Oh, yes. So I'm totally did not understand what is a multiple deformities. So, but I like to introduce one interesting cases. Don't move. Okay, more older patients. 80 years, platypnea orthodoxia syndrome. Maybe you may have experienced this kind of patient, mainly very geriatric patients. Their saturation is stable in the supine position, but once they getting up, sitting position, saturation was significantly dropped. That is a platypnea orthodoxia syndrome. So initially the diagnosis was done in another hospital. That record said PFO-related platypnea orthodoxia syndrome. They sent it to the transesophageal echocardiography findings. So in the case of the PFO, I almost always do the sedation plus ICE monitoring. So in this patient, I do the same strategies. This is the T findings, huge atrial septal aneurysms, and aorta shifted very anteriorly. This is a cause for the why IVC flow passing through to the PFO to the left atrium. This is one of the very typical anatomy of the platypnea orthodoxia syndrome. So we start for because the big atrial septal aneurysms, we simply decided 35 millimeter Amplatzer PFO occluder to close this device. After the deployment of the 35 millimeter PFO device, still that transesophageal, transthoracic echocardiography, very funny findings, and still saturation was not goes up. Usually platypnea orthodoxia syndrome, after close, the saturation was rapidly goes up. So very unsuccessful cases. Of course, I think that this is not good, and retrieve the device. And also, I asked to the echo person, please bring the transesophageal echocardiography for de-evaluating for this PFO. So this is suddenly we perform for the ST findings in this patient. I should done this before the patient comes to get catheter. And the PFO is widely opened this directions, and the height is 10 millimeter, and wide is nearly 30 millimeter.
So that even in a 35 millimeter PFO occluder cannot completely cover it. So we changed to the too close for the ASD device in this particular case. And we put in a 44 millimeter Gore cardioform ASD device. Because the procedure is very simple. Once you look the fluoroscopic imaging, device covered for the very vertically, and you can image for the IVC flow directly hitting for the device. This is one of the typical shape of the pneumonia orthodoxia syndrome. So I do the bubble study again. From the IVC, no bubbles go into the left atrium. And the saturation was significantly improved after the Gore AC device deployed. But sometimes I think I saw this kind of funny shape of the ASD recently. Maybe it exists before. And very unique shape. So this shape is not matched congenital ASD. Of course, maybe you know, this is we call the stretched PFO. Of course, this is stretched PFO, but hemodynamically, this is not PFO, ASD. So once we classify this kind of the crescent-shaped ASD, not classified before, because this is originally PFO. But now we have a much more patient, this kind of a unique shaped PFO, because patient getting older. About 10% of the patient who aged over the 80s, we find that this kind of crescent-shaped ASD. Because the device selection is very difficult to be the crescent shape, that we should measure for the maximum diameter of the crescent. So that in the elderly patient, sometimes this kind of very unique ASD exists that is not congenital or rather acquired ASD. It's a stretching of the atrial septum. And this is another target for our field. Thank you very much.
Teji, thank you very much. Again, comprehensive talk. So we'll move on. And next up is Ming Tai Lin. Yeah, there you are. Multiple comorbidities. Ming Tai.
Thanks, Jacques, for the introduction. Good morning, ladies and gentlemen. This is Dr. Ming Tai Lin from Taiwan. First, I would like to thank the organization committee to invite me to have this talk. Today, my topic is transcatheter ASD closure in the patients with multiple comorbidities. I have no disclosure. Here's my outline today, including current status of my hospital and the comorbidity before the procedure, during the procedure, and after the procedure. That is a summary and a share. The figure demonstrated the annual case number of transcatheter ASD closure in my hospital. Each year, we had around 60 cases with ASD closure in my hospital. The first one comorbidity I would like to mention is pulmonary hypertension. As you know, the pulmonary hypertension has been noted in certain patients with ASD. And the prevalence of ASD-associated pulmonary hypertension...
Ming Tai?
Yes.
Sorry to disturb you. If you just stay there, we're going live to India. But if you stay there, we'll just interrupt.
Okay.
Or you can have a seat in the front row if you like. Yeah, have a seat. Okay, let's go live back to Amitabh in Kolkata. All right, Amitabh, can you hear us?
Yeah, good morning.
Can you hear? That's, okay. I still don't know what that branch is, but never mind. Okay. Yeah, that surgical side is always difficult with these coronary fistulas because the surgeons either it's complex, close it at the ventricular or whatever cardiac cavity it is, or they clip it from outside. So it's not, we can't really compare the results with that. So, and it's not easy. But that looks like a very good result. And so congratulations to the whole team. Well, not particularly, other than the coronary question. I think it's a good practice just to do selective right and left before you occlude the fistula because it saves a bit of time. There is one question. Go ahead.
There are two observations. One is that I think that the MFO...
A bit nearer the microphone, can't hear you.
I believe that the MFO was quite oversized because it's lengthened a lot. And since you showed us in the beginning that the opening was very close to tricuspid valve, we like to see on echo whether the tricuspid valve is behaving well or does it have any obstruction with the device. Okay. Right, right. Yeah, I think that's a good idea.
No. Oh. Okay. Okay. All right. Thank you very much, Amita. Well done again to the whole team. Okay, we'll move away. And if we get Ming Tai back for the carry on with the talk.
Okay, let's continue. So the prevalence of ASD associated with pulmonary hypertension in our hospital is high up to 24% in the age group older than 40 years old. For such unique subgroup patients, we follow the ESC guideline to manage our patients. And for those with QP over QS more than 1.5 and PBR more than 5 units, we provide another choice of treatment modality, that is partial repair and the treat principle. Here is a case demonstration. She is a 47-year-old female, large ASD, pulmonary hypertension, and the PBR high up to the 12 units. We deployed a 40-millimeter device together with 2 fenestrations. And the left panel demonstrated the fenestration. And 7 years later, she continued her Rebatio, and the fenestration is still there. We did the stenting to keep the fenestration. And as the video demonstrated, you can see the fenestration flow is quite good. We ever did a review for a patient who had such intervention. And most of them had improvement in the functional status and the BNP levels and the estimated pulmonary artery pressure by echo. The second issue is about the venous access. This is an 8-year-old girl, body weight only 15 kilos. She was a premature baby and had a large ASD and a complete AV block associated with maternal SLE. We decided to do ASD closure together with battery exchange. Before the procedure, we realized we will have some trouble regarding to venous access, and it did happen. You can appreciate the interruption at bilateral femoral vein. We also failed to detect the useful internal jugular vein. Should we go to the hybrid approach or transhepatic approach? And finally, we found some venous engorgement at her right neck. So we approached through her external jugular vein. You can appreciate the wire goes through the external jugular vein to the SBC and then to RA. And the LA angio demonstrated a large ASD. TE confirmed the finding. The ASD size around 2 centimeters. So I deployed a 24-millimeter device, like the right panel demonstrated. After some wiggle, and the device sit very well, and the T confirmed the finding. The last issue is about atrial fib during procedure. So she was a 53-year-old female who had a moderate size ASD and a paroxysmal atrial fib. The T showed the ASD size was 2.3 centimeters. The angiography confirmed finding. Initially, I used a 28-millimeter device to try to close the defect. However, you can appreciate that the device didn't sit well, and also arrhythmia, atrial fib, was detected. And you can appreciate the color dupla demonstrated some residual shunt over there. And the 3D reconstruction again showed the device didn't sit very well. Under fluoro, you can appreciate the atrial fib. Then I deliver the DC shock to convert the rhythm to sinus rhythm. After that, I changed it to a 30 millimeter device to close the defect. But when I was ready to deploy the device, I found the terrible thrombus in the right atrium and also on the cable, on the cable of the delivery system. So at the time, what I only can do is quickly deploy the device to stop the thrombus, to prevent the thrombus run to the left side. And from the right panel, you can appreciate some thrombus still in the right atrium. And luckily, the TE follow-up didn't show any thrombus in the left side, and the 3D reconstruction showed a very good position. So the lesson from the case I learned, the pull out the cable and the device before DC shock, because such DC shock will cause large thrombus burden. And remember ACT monitoring and the heparinization, especially in the patient with a history of paroxysmal or persistent arrhythmia. And I would like to also take this chance to thank our surgeon colleagues. They always provide 24-hour support to our cath lab. So ladies and gentlemen, I would like to share in the summary here. First, the pulmonary hypertension is not uncommon in the ASD patient, especially in those older than 40 years old. And the second, external jugular vein may be one of the venous access for your right side cath. The last is don't deliver DC shock when your long cable is still within the cardiac chamber. Thank you for your attention.
Ming Tai, thank you. Some important lessons there. We'll keep moving. And the last talk is, by the way, we'll have a working coffee break because we're way behind. And so if you want coffee, if you nip out and bring it back, we'll carry on with the session. So Lucy Eun from South Korea, ASD with arrhythmias. Lucy.
Thank you so much, Shaq. I'll go first very quickly for arrhythmic issues. Thank you. All right. Doesn't move. Sorry, it doesn't move. No disclosures. Okay, we all know about why arrhythmia happens in ASD because atrial level shunt make atrial arrhythmia is very common and naturally, and then ASD closure may not diminish the atrial fibrillation and flutter burden because arrhythmogenesis appears very multifactorial issues, and then atrial left to right shunt sometimes make RAIV volume dilate and then chronic volume overload that makes RA structure remodeling, and then time course dependent longer and longer, the histological change, and that makes electrical remodeling. So this is in-hospital patients' data about with AFib, ASD, and then rather than without AFib data, hospital mortality and then heart failure, cardiogenic shock are all significantly higher. This is why we should take care of AFib. Especially elderly patients, concern of AS device closure, long-term complication, atrial arrhythmia is very important. And comorbid cardiac and systemic disease in elderly, also AFib or A-flutter is almost half of the patients. So that's why the major cause of morbidity in ASD is afibrillation. And then age larger than 60 years old, much increasing incidence. So we should be careful. And then after ASD closure, the AFib incidence sometimes decreased, sometimes no change, and sometimes increased with older age. So new onset AFib after ASD closure already 2.20%. We all know about follow-up duration is longer and incidence gets longer. So this is kind of recurrence of AFib. Follow-up duration is longer, and we notice much longer instance about recurrent rate. So less than 1 year AFib in case ASD closure helps to normal sinus rhythm conversion, but recurrence is common in longer than 1 year, longer AFib, so different. ESC guideline suggested about rhythm control strategies better than rate control, but we always have to remember about LA size, LA index, and then age, and then the AFib duration. And then after ASD closure, if persistent AFib happens, we can do transseptal puncture adjacent to ASD closure device, electroanatomical mapping of ASD closure device. I will show you one case. 56-year-old male, so not older than 60 years, elderly, but not young, 56 years old male, dyspnea, exertionia, class 2, and atrial fibrillation there. And then we diagnosed ASD, large size, and then we, luckily no pulmonary hypertension and then not much comorbidity, so we decided to close ASD, fibula flex 2. So performed successfully. After that, 5 years, the AFib persistently continued without relief. So half puff, and then even though the appropriate medication, still AFib there, so we decided to consult EP specialist, septal puncture, and then for pulmonary vein isolation, and then RF ablation successfully, and the normal sinus rhythm conversion, and then still more than 6 months, he's doing very well. So, of course, stroke prevention, we should remember all the time anticoagulation and the bleeding risk assessment is necessary. And then if we need, sometimes LA appendage closure is helpful for it. So considering points is ASD with AFib patient, atrial arrhythmia patient, AFib ablation first, or ASD closure, and then we will wait and see, and then AFib ablation, or sometimes AFib recurrence in older age, EP procedure or surgery we need to consider that. So conclusion, all the time ASD closure and then atrial fibrillation, we have to take care of those things before and after, and then EP consults help we are remembering. Thank you so much.
Lucy, thank you very much again for a very comprehensive talk on arrhythmias there, and a lot of challenges for the future. So we will, I want to thank all the live case centers and all the speakers, moderators and panelists for this session. So as I said, we'll have a working coffee break. You can nip out and then come back for the next session, which Mario Carminati, Trong Phi and Bezard will run together with Hasri Warrakan and Martin Mon. All right, so thank you very much.
about like well, dear colleagues and friends, as we know, we are well behind with the program, so I think we have to start this session. And I have to add the moderator here. The other moderators are supposed to join me, hopefully, Tronfilet, Bezad, and the other guys. And I'm not aware whether in the Cath Lab they are ready, so I think we'd better get started with the first speaker, Martin Snyder. Martin, you're here? Yen is here. Yeah, the first talk is going to be delivered by Su Yen Ho, talking about the morphology and variations of ASD. Thank you. So you can get started, Yen. Thank you. Wizard. Yes. Can you have the slides on?
Okay, good morning. In the interest of time, I'm just going to look at true atrial septal defects on specimens. So by that, we mean that not all interatrial communications are true atrial septal defects, or ASDs as you call it.
Okay.
So in terms of communication between chambers, why is it not? Sorry. In terms of communications between the atrial chambers, we see that right in the middle, we have the overfossa defect, so-called secundum ASD, which are the most common. And then we have the other interatrial communications that are outside the true confines of the overfossa. So I'm going to focus on overfossa defects. So in terms of nomenclature of overfossa defects, it's often called a secundum ASD, but I'm not too sure which secundum that term refers to. Because in the development of the atrial septum, we have the septum primum growing from the roof of the atrium down towards the atrioventricular canal to meet up with the endocardial cushions to close off the septum primum, the ostium primum rather. Whereas this septum secundum is an infolding of the atrial wall on the right side of the septum primum. So are we talking about persistence of the ostium secundum, or are we talking about deficiency of the flap valve, or the, in other words, septum primum? So, but nevertheless, if we look at the overfossa defects as we have here, your so-called secundum ASD, in this specimen, we have one in which the overfossa valve, septum primum, is quite deficient. There's a large persistence also of the ostium secundum. In this other example, we have a very big hole in the atrial septum. You can see the margins are not quite sufficient. If we turn it around to the left side, we can begin to see that that valve of the overfossa is actually quite aneurysmal or bulging into the left atrium. And there are various smaller holes within that flap valve. And indeed, on closer examination in the still image, you can see that fenestrated flap valve bulging into the left atrium, and also the muscular rim, which is actually the septum secundum, or the rim of the overfossa, seems to be deviated towards the right atrium. So is there some sort of septal malalignment? In this other example, we have quite a flat flap valve, and we just have lots of fenestrations within that flap valve. Just there, I don't know where the central orifice would be if you're aiming for a device closure, for example. There's a tiny little vestibular defect also associated with this primum, or septum secundum ASD. In this other example, again, a valve with fenestrations, but this time very much pushing into the left atrial chamber, kind of like a windsock arrangement, if you like. There's a big orifice right at the top. But here's the windsor bulging into the left atrium, again, full of fenestrations. So already in these three examples, you can see that so-called secondum ASD can have quite variable morphologies. In this case, very big defect, a tiny little rim of flat valve remaining posterior and inferiorly, whereas the anterior margin is very close, or aortic margin is very close to the back of the aorta. And here, turning around to the left side, you can see this big opening again, and there's quite some proximity to the right upper pulmonary vein, as you can see just coming into view here. So in terms of size and locations and margins of a secondum ASD, as you call it, you can have some examples here, high ASD, or a low ASD, pretty close to the inferior caval vein, but still having its posterior inferior rim around the fossa ovalis. And you can also have a huge defect, as you can see on the last example on the right there. A very small anterior rim, perhaps the more substantial posterior rim, but nonetheless a huge atrial septal defect. So in terms of ASDs, you can already see we have quite a few examples already on the specimens. And in the interest of time, I think I will stop here. Thank you very much.
So thank you very much. Very exhaustive explanation. We are ready to go live with Tin. Tin, can you hear us?
Yeah, I can hear you.
Hello, is Mario here with? Yeah, hi. We are ready to follow you. Yes, we can hear you and see you. Tin. Hello, Tin. Hello, Tin. May I ask you, hello? Can you hear me? Well, I mean, you're making a loop, an arteriovenous loop, because I think you're going to implant a device from the venous side antegrade. Is that the reason to select this, or why not to do device implantation directly from the retrograde way?
I think they're doing just fine because they'll need to pull this device inside the pouch. If they would just push it from the aorta, most of the device would remain under the they need really to push it and to plug the pouch. So they need to go venous.
Well,
Garrett? This is Bezad. I want to ask you, and is there any contribution of the tricuspid valve, tricuspid leaflets to the VST pouch? And
so the defect is completely closed by the sheath, right?
You probably don't have two holes because the sheet is completely occluding, so it means there's only one hole. If not, you would see the second one.
Omar?
Even two exits, I think you have only one.
I mean, here's Omar. I think you decided what to use, but I thought because of the vicinity to the tricuspid valve, AD01 would be also a device to use. I mean, the VSD is very small, but has very nice conal shape.
AD01.
AD01.
Sorry,
Yeah,
we
it kind
cannot
of
hear your
looks like
discussion.
you are in the
Alice,
aneurysm, and you can see leak on the echo.
can you get the echo larger, please, with the color on? Well, in this picture, the orientation of the device look a bit odd to me. I wonder if the tension of the wire can be this, and if the device, if you release it, will be readjust itself. What do you think?
And Garrett, I think the radial force of the sheet is very high here. And so I think if you uncover the sheet and just the wire, the cable, it may be much more visible. You know, one of the difficulties with Occlutech devices is that this device is not very opaque. So it is very hard to see that where it is really. So I think that if you uncover the sheet and you have the cable more freely moving, will be much more better to see that.
Yeah, that's right, Bezal. However, the delivery cable is a bit stiff, isn't it? So it cannot leave the device movement and to achieve the final position until you release it. Tronfi, you had some comments?
He's Tronfi speaking. Oh, ready? Release. Tin, you hear me? I think I'm happy with the results because this is covering completely the VSD. And if there is a second perforation, it is already compressed or closed by the device. And so far, I understand the echo. There is some flow between the inside the between the discs of the occluder. I don't care. I would go forward to release the device. Yeah. Yeah.
So therefore, you're going to release it, right? Well, it looks like the device is within the funnel-like orientation of the differ, right?
I could rely more on echo. Is a shunt and flow?
Well, apparently there is a residual substantial flow across the differ. What do you think is the mechanism of that?
And Warwick, are you afraid of hemolysis for these kind of patients? And Warwick, what do you think about, is it really a residual shunt across the device, or it is the another orifice of the defect from the... Oh, yeah. So it seems that there is another orifice. Yeah, there is another exit. So, Garrett, would you like to pass another wire from that side and close it retrogradely by something like ADO2?
Easy to cross, Tin, now.
So what are your definite plan now? To re-enter the residual shunt?
I have a question. Can you tell us if the second perforation is partially covered by the left ventricular disc or not? Okay, okay, it's a pity, but in this case, I think it could be a good idea to put a second device.
Okay, so sorry, we are running out of time, so we will leave you now. You progress and do whatever you plan to do because we have the other cut lady for another like case. So we'll be back to you whenever you like. Is that okay for you? Okay, thanks. Can you change the connection to the other lab? Hello? They're not ready. So. Okay, sorry. So we carry on with the lectures now, and then we're back with the cath lab later on, whenever you like. So I'll ask to Martin, are you here? Yes, talking about how to deal with floppy rims, talking about our ASDs, of course. Please, Martin.
Is this working? Yes, it's working. So how to deal with the floppy rims? The anatomical consideration we should do is, of course, like we do every time, defect size, size of the rims, number of defects, additional aneurysm and alignment of the interator septum. Consideration on device and procedural. Device self-centering or not self-centering. Connection between delivery cable and device. Is it rigid or is it more flexible? Then balloon sizing, yes or no? Opening of the LA disc on the left side or on the right side of the LA? And do we count on ASD device ratio or even more septum size and device ratio? Now that's the reason why I like the balloon sizing, so much because it's not because of the size of the defect, and it's more the alignment of the septum, which is shown by the invitation of the balloon. So is it more perpendicular or more horizontal? If it's more horizontal, the implantation will be easier, and if it's more perpendicular, the device will jump more if you release. So this slide is more than 20 years old, and it shows the movement of the device when you release. So just a couple of cases. First case, multi-perforated floppy septum with aneurysmatic formation. So in this situation, I would not do a balloon sizing. So first of all, we explore a central hole guided by a TOE, then enter the left upper pulmonary vein, position an 35-inch wire in these veins, and then invert a 10 French long sheath over the wire into the left upper pulmonary vein, withdraw the wire and check the aneurysm formation. It's crucial that you go to the left side of this aneurysm. And the last point is start to open the left-sided umbrella inside the left upper pulmonary vein, pull the aneurysm formation with the fully opened left umbrella down, open the right umbrella side in the IVC whilst pushing the whole umbrella and septum into regular position. So the idea is to cover the whole septum by the biggest non-self-centering device. And here we go. This is idea of aneurysmatic multi-perforating septum defect. This is another view. And so we use a non-self-centering GSO device. And as I told you, pulling the left umbrella down to the IVC and then opening the SVC. And the idea is, as you can see here, to cover the whole septum, sandwiching the aneurysmatic formation. The second case is an 18-month-old, 13-kilogram child with a 40-millimeter defect. The septum size was about 30 millimeter, and we choose a 13.5-millimeter Occlutech device with a left atrial disc size of 28.5 millimeter. It was a floppy septum with big central defect. In this situation, we prefer to do a very gentle balloon sizing, not to make the defect bigger as it was. And this is the patient in the echo. And again, the idea is to cover the whole septum by implanting the biggest device which will fit into the left and right atrium side. And in this situation, we did this last week, I think, we choose implantation from the right side of the LA because I think the positioning of the defect, even particularly in a big defect, is easier coming from the right side. And as you can see, it worked. And this is the final result on echo. So again, we tried to cover the whole interatrial septum. And you see here the septum size and the device ratio is almost 1. So last but not least, the third case was a 70-year-old patient, 55 kilogram with a 3.2 centimeter defect, 47 millimeter septum, and we choose a 30 millimeter Occlutech with a 45 millimeter LA disc. So again, you see the floppy situation, a big hole, and here we go. And this is balloon sizing. You see there's almost no waste, and the umbrella was big enough to do a decent wriggling, and this is the situation after we implanted the device. So in conclusion, for the closure of single or multiple defects in the floppy interatrial scenario, I would recommend to choose a maximum oversized defect
device must be fixed. Therefore, the ratio between the size of the septum and the size of the left side of the umbrella should be approximately 1. In a floppy septum with multiple defects, we go without balloon sizing. Thank you.
So thank you very much, Martin. For the sake of sparing time, we have to carry on with the following lecture, and because of the Dr. Deepa can have to get a flight, so we modified the program a bit. So I'd like to invite Deepa Sasikumar from India to give a lecture about the malaligned septum. Please, Deepa.
Thank you. Good morning, all of you. Can I have my lecture?
Can you have the slides on of Dr. Deepa Sasikumar, please? Here you go.
So my talk is on device closure of malaligned malaligned atrial septal defects. How do I go forward? Okay. So septal malalignment, it's a risk factor for failure of device closure of a malaligned ASD. So device closure is extremely challenging in this situation, and there is limited literature available on malaligned atrial septal defects. We are, I think, recently started to diagnose malaligned ASDs, and it is so difficult to recognize on TT. There are a lot of institutions which do device closures on TT alone, but I would say that this is one entity that you fail to recognize by transthoracic echo. It is typically visualized by transesophageal echo in mid-esophageal 45 or 90-degree sectors. The hypothesis is that the septum primum is malaligned towards the left atrial side, and there is a significant separation between the septum primum and the septum secundum. It's a difficult concept, and I will show you by examples. This is a 33-year-old lady. We measured a 20 millimeter ASD by transthoracic echo. But transesophageal echo told us a different story. You see how the septum seems to be moving so much leftward on the 45-degree and the 90-degree view, so much so that the actual ASD, when you measure, comes to 23 millimeters. So if you don't adequately upsize, there is a high chance of embolization. This is another 43-year-old lady. Again, her defect measured 20 millimeter by transthoracic echo. But you do TE, you see that there is significant malalignment on 90-degree and 120 degrees. So again, her device defect measured 29 millimeters. So there's a 9 millimeter difference between what we measured by transthoracic echo and by transesophageal echo. This is an 8-year-old girl. We thought it was a nice, simple 12 millimeter atrial septal defect by transthoracic echo. Transesophageal echo told us a different story. You see here that the malalignment seems to appear even by 0 degrees, and then it gradually seems to worsen at 45 degrees and 90 degrees. So much the left atrial protrusion by the septum primum. So her defect measured 17 millimeter by transesophageal echo. So when you measure, you tend to measure the blue line. So in a malaligned atrial septum, you have to measure the orange line. And you see there is so much length difference between the blue line and the orange line. If you miss it, I again say there is a risk of embolization, especially if you're doing it by transthoracic echo alone and you fail to understand that the septum is malaligned. In case 1, this case, actually the first case that I showed you, it was done some 8 years back when we were slowly starting to recognize malalignment, and we closed it with a 26 millimeter septal occluder, and the device embolized to the left atrium. If you look closely at the 90-degree, apparently it is sitting well on the aorta, but this is not how it should sit in a malaligned ASD. You see the discs are close together, the LA and RA discs are close together, almost parallel, but this is not how it should sit in a malaligned ASD. I will show you in the other cases. This is, see, looks like it is sat on the defect, but you see that the septum is going actually far leftward from your LA disc. So you should catch the point where the septum is attaching and not on the midpoint of the aorta. So the device should be very well splayed in 45-degree and 90-degree where you see the aorta. This was the second case. If you notice in the second panel in 90 degrees, you see that this time the LA disc is very much splayed and it has caught the septum primum where it has shifted leftward. So you see it is so much splayed. And you fail to recognize this if you just look at the bicaval view in 90 degree and come out. You have to take the bicaval view, you have to notice IV serum and SV serum, and then you have to rotate your probe clockwise to see the area where you see the aorta. This is a third case. Again, we confirmed that the left atrial disc is straddling well on the aorta, catching the area where the septum primum has deviated leftward. So there is so much straddling. So again, to reiterate, this was the case where it embolized. You see that it is not splayed well over the aorta to catch the malaligned septum primum. In the second case, we have made sure that it has caught the septum primum where it is deviated. Third case also. So in all malaligned ASDs, you have to look at the 90 and 120 degrees carefully before release of the device, and look at the view where you see the aorta, not where you see the actual bicaval view. So again, to say septum primum is malaligned towards LA side, and you get clues when you start doing the transesophageal echo from the beginning. In the 0 degree, ASD is usually not visible when you do the four-chamber. You take the probe up, and ASD starts coming into view when the plane of the aorta is seen. Same is when you see the 90 degree also. In the bicaval view, the ASD may not be seen at all or may be very restrictive. You rotate the probe clockwise, and when the aorta is seen in 90 degree, you begin to see the ASD. Those are clues that the septum is malaligned. See, in this view, in the bicaval view in 90 degrees, I have not changed the degree at all. You rotate towards aorta, you start seeing the ASD. In the bicaval view, there is no ASD. So this is how we teach our residents. In a normal ASD, it looks like this as on the left side, and malaligned, you start seeing the septum getting deviated. 45 degree also same thing. In 90 degree, in bicaval view, it looks deceptively normal. You rotate the probe clockwise, you start seeing the malalignment. So again, this is something we tell the residents. It is very difficult to recognize by TTE. In our institute, we do all device closures under TE. We don't do balloon sizing. We depend entirely on transesophageal echo, and we know that we have missed a lot of malalignment on TTE and subsequently diagnosed them when we did a transesophageal echo. It is also difficult to diagnose under fluoro. It looks like any other device position. This was a highly malaligned ASD, and the device looks like normal, how you do in a usual ASD. So always rely on transesophageal echo to diagnose malalignment. So now we know that certain cases, from the beginning, we know that it is going to be difficult malalignment, especially if you start seeing the malalignment from 0 degrees itself. You see in this case, the malalignment is already started, getting worse in 45 degree, 90 and 120 degrees. It looks quite bizarre. So this one, we didn't even attempt. You see here, it is so malaligned. The distance between the septum primum malalignment and the other septum is so much, so great. This was another case where we attempted. Here again, the malalignment starts by 0 degree. This one we attempted. We knew that it is going to be tough because this case has got a very floppy posterior rim as well, along with significant malalignment. We attempted with even dilator support and significant oversizing of the device. Still, it was continuously flopping, and we backed out. So this is our 10-year experience from 2009 to 2019. Out of 2,600 ASDs, nearly 10% had significant malalignment. We were able to successfully close it in 201. We backed out in 18, and 4 embolized. Now we are very, very careful when we deploy the LA disc in a malaligned ASD. Now we don't have any more embolizations after we realize that the LA disc has to be really splayed, and the sizing is entirely based on TE. So importance is that it is important to recognize that there is such an entity. It is important to identify it before you deploy the device, and you have to appropriately upsize the device size based on the malaligned septum. Device must enclose a superior and inferior septum in between the disc without either disc being wedged in between the septa, and it should be well splayed, especially in 90 degree and 120 degree views. Thank you.
Thank you very much, Steve, for clarifying this challenging and difficult anatomy. Thank you very much.
Thank you.
Now we are ready to get the connection with Mumbai, Apollo Navy Mumbai Hospital in India. Can you hear us?
Thank you once again. Yeah. So this is the second case for the day.
Yes. Okay, we can see you and hear you.
With normal growth and development, with asymptomatic cardiac status, incident is detected to have a normal version of school health checkup. His HbA1c grows with weighing around 31 on 80, saturation 100%. Precaution examination shows no fibroinsufficiency, S1 is normal, SNP white, with deltoid weight 3 by 6 continuous normal all over the pre-quadrant, Western in the right lower sternal bottom. This is the X-ray which shows cytosolitis, tachycardia, left heart, and no hidden cardiac arrhythmia. ECG shows normal sinuses visible with normal action. There is an RSRM number which can be appreciated. This is the echocardiogram of the patient. So we can see that the right sinus appears to be dilated. We are also seeing some continuous flows across the infraatrial spectrum towards the right atrium. This is the subcortical view, which again shows the smooth flows of LVP. And you can clearly see there is some continuous flows across the LVP-RA junction, including in front of LVP-RA junction. So these are the stream flows from the right side. There are no flow reversals in the aortic arch, and we did not find any chamber enlargement. So this is a CT pulmonary angiogram, which shows that the right sinus appears to be dilated. The left coronary, what we are seeing left angioid descending and left circumflex appear to be normal with no dilatation. Again, this is the 3D MTR, where we can see that on the axial tract there is a tunnel which is feeding from the right sinus towards the right atrium. Some measurements show around 7.3 and some around 7.4 across the tunnel. So this is the diagnostic angiogram which was done for the same patient. And in this view, we are able to appreciate that from the right sinus appears to be dilated. There is a different definite artery which appears to be normal and a tunnel across it from the right sinus. This is the selective angiogram of the right coronary artery. We can see that there is no dilatations across the right coronary artery. And this is the selective angiogram of the tunnel, where we see that there is a dorsal close of the tunnel from the right sinus, and the LV is at the SVP-RA junction, which appears to be constricted at the exit point and with a dilated dorsal tunnel.
So this is the case that will be a little different one for this session, but I thought this is one of the best cases that we could go into. We have some beautiful images for transesophageal echo.
So in the vital port window view, as we can appreciate that there is no chamber enlargement. And this is the right sinus appears to be dilated.
Sorry, we can see you, but not the pictures.
So this is a 12-year-old boy, weight 30 kg, and he has to go for the transesophageal echo for the same.
So the vital port window view, as we can appreciate that there is no obvious chamber enlargement. And as we go on to the aorta, if we can see that right sinus appears to be dilated, and we can appreciate a
Any comments or questions from the panel or the audience? Result, trophy.
Thank you. It's a very exciting case. And have you any concept about the QPQS in these kind of patients?
Agree.
I find if you close only the exit point, you're going to leave a lot of dead space, which is, of course, so I would probably close, I mean, try to put another device closer to the exit of the right coronary.
I think that this is a high flow shunt. That means we need enough material to get complete closure. I think you can use any kind of device, but
Okay, now,
should be
now you
economic.
have a navy loop. What kind of delivery sheet you're going to put in?
When you close the exit, you have a long distance of very huge coronary fistula. What do you prefer for the anticoagulation during the growth of these children?
Hi,
There's
Dr.
another
Bhushan.
question from the audience,
Yeah.
please.
Hi, Dr. Bhushan. Dr. Abhimanyu from India. Yeah. Sir, I just had one suggestion that since you are worried that you don't want to close the entry point because it is very near to the coronary ostium of RCA, why can't we use an AVP2 plug and put it just inside the aneurysm sac? Because the sac is quite tortuous. I think your AVP2 can also hold very well in that location. And that will, leave us with a smaller sac. The first convolution, just after the origin of the entry point of the sac from the aorta, we can just pull it a little back inside the ostium of the sac and place it there, because there is one very nice 180-degree bend there.
Why can't we place it there? Because I'm a little worried about the length of this tunnel being very long, and if we just close the exit, it might predispose to thrombus formation in future.
Okay, we follow you now. Can you see the fluoro? Can we see the fluoro? Now we see the fluoro. Thank you. Okay. No, we don't. We just see the fluoro. Now we see the echo picture.
Although your echo pictures are beautiful, I feel like this is an angiographically driven procedure. So either do something through your pigtail retrograde or perhaps take your dilator out and do a hand injection through your sheath, and you can outline your anatomy.
So let's go back to angiogram, to fluoro. We can see your hands now. Okay. Well, we can hardly see the fistulous connection now. What does it mean? Is that the long sheet almost closing the hole, right? Right.
Can you inject the long sheet angio? Ah, thank you. Thank you. You don't have to break the loop. You can inject now.
Another thing is that all the cases we've seen, they put a terumo exchange, which is very stiff. I think if we would rather do the rail with a noodle, the guide wire would maybe loop a little better. Now your device is, your fistula is completely straight out.
What do you mean, Joachim? That you would like to, you prefer to have a soft wire.
Exactly.
Keeping the loop instead of straightening out.
Exactly.
Everything.
Either an 18 exchange Terumo or simply a noodle wire that the ones we use for the VSD closures.
Yes. You have to decide where is the point to put a plug in, correct?
And what size do you prefer?
So you're saying that you cannot inject or cannot aspirate because of the wire inside? So you remove the wire. I can see your hands now. So you remove the wire, breaking the circuit, and you're going to do an injection through the sheath, correct? Okay. Can you see the floor now? Yep.
I think if the sheath is completely closing the exit, this kind of angio is useless. We cannot see the tunnel.
Yes, but injecting through that, yeah, well, there is no much information, isn't it? We see the pulmonary artery because you're injecting forward in the right side. What is? Where is the sheath?
Right.
Yeah.
Yes, yes.
Yeah, it's out of that.
Yep.
Yeah, yeah. Sorry for asking you to do a sheet angiogram. I think it's out. The connection that just now you're using a T connector, so you won't be able to shoot it. You should have used a Tohi boss to kind of inject from the side port of the sheet.
I think one problem sometimes if you use a PDA occluder sheet, there's so much curve and it's quite stiff. It sometimes will straighten and there's too much tension versus using, let's say, a guiding catheter, a large guiding catheter, which is more flexible, which you can use if you have a softer device like an MFO. Sometimes you can deliver it, a guiding catheter. It doesn't seem like the hole is that big. So you can actually use a relatively small MFO and a guiding catheter, which is more forgiving in a circuit like this.
Okay, so I think you had to do a lot of work. You start all over again, actually. If you don't mind, we disconnect with you now, and we reconnect with you later on. So thank you for now. So you carry on with our program with the lectures, and next speaker is going to be Elison Chabalka. Elison, please get to the podium. And Elison is going to talk about ASDs with deficient aortic rim. Please, Elison.
All right, thank you. Can we have the slides on the screen, please? Okay, I will talk about ASDs with deficient rims, and a number of things we've seen already this morning kind of cross over with this topic. Looking at rims, again, it's very important to look at multiple views. So especially as we saw with TEE, looking in terms of anterior superior, posterior, importantly for malalignment that we may not recognize by our regular transthoracic. Typically, deficient rims are defined as less than 5 millimeters, and large ASDs greater than 25. Obviously, that depends on the age and the size of the patient, but the combination can make our job harder. Certainly closure, deficient rims, we talk about inferior posterior rim being nearly absent, probably a game ender where we would refer the patient to surgery. Sometimes it's not easy to tell if a rim is non-supportive until we interact with it, whether that's device interaction or balloon interaction. And again, are we doing this in a large patient or a small patient? In the echo here, we can see that little nubbin of a posterior rim is somewhat non-supportive. So some of the tips and tricks, and the people who have reported this have sat in this audience. I know Lee Benson is not here, and we saw a beautiful example of this left upper pulmonary vein deployment technique this morning in the case from Ho Chi Minh. So LA disc in the pulmonary vein, getting that pulled back in a fairly brisk maneuver, and the idea is to prevent the LA disc from prolapsing when you have this deficient anterior superior rim in most cases as you deploy the RA disc. So some will describe this as American football appearance, and as you saw this morning, it's a very brisk motion. Tin probably does it faster than anyone. This is a depiction of what that maneuver looks like. So the LA disc is deployed in the left upper pulmonary vein. It assumes that football shape and is retained until the right atrial disc is deployed, and that tension brings the device together, sandwiching the septum, giving you nice positioning. Dr. Dalby, who's in our audience, or maybe in the other session, showed us right upper pulmonary vein balloon-assisted technique in the early 2000s also. So there are multiple ways to do this to counteract this deficient anterior superior rim, typically in large ASDs once again. So the goal of all of these maneuvers is to prevent LA disc prolapse during deployment of your device. So in this situation, the sizing balloon was actually used. You need an extra set of hands for this maneuver as you're deploying the device on the wire in the left upper pulmonary vein. And then as this balloon is gradually deflated, device stability hopefully can be maintained. The right upper pulmonary vein can also be used in smaller children with larger devices trying to maintain that superior anterior interaction before you fully release your device. We have some techniques that we've utilized for the Gore cardioform ASD occluder. Again, this is a device that has an adaptable waist. Device sizes from generally 32 up to 48 are what we use. Defined as ASDs up to 35 millimeters, although we know a 35 millimeter ASD may give all of us some challenge. As we look at this, we can also see deployment angle issues coming from the IVC. We can have prolapse of this device, and we can see here that this very vertical orientation is not favorable. We can change that orientation by curving fairly aggressively the hypotube on this device. So we reshape that. We essentially are trying to make a Hausdorff sheath curve and then transition into a more coaxial alignment in the left atrium with that LA disc. So if we have a deficient anterior superior rim, which is typical situation for a larger ASD in many situations, This will help to curve that hypotube so our device is more coaxial and we can allow that right atrial disc deployment without prolapsing the superior anterior part of the LA disc. So you can see how the device alignment changes entirely. This is, again, a description published from Multicenter on a Mullen sheath facilitated delivery of the same device, trying to simulate that Hausdorff sheath curve. And again, trying to avoid this superior prolapse in that device as we deploy it so that we change the trajectory and can maintain a coaxial deployment and capture all of those rims appropriately. So this doesn't always work. This is a patient where we look at the defect, and I did this case, but the patient had been enrolled in the national trial when the ASD device from Gore was under investigation and had a failed attempt at closure. Lest you discount this posterior inferior rim, it was actually very non-supportive. So our 44 millimeter GCA device had superior disc prolapse, which you can see on the right-hand picture here. Don't think I have a pointer, but we tried this multiple times and it did not work. So thankfully we have experts in our field who are very creative. This is Mary Hunt Martin's a way of showing how to create not only curving the hypotube, but manipulating it directly as you're implanting. You take a very long O-silk tie through the end of this monorail, and you can typically curve this. And with that maneuver, actually, we were able to successfully implant this device. We did not have prolapse, and we had a very nice position. So I think successful deployment can rely on multiple techniques, and I will always go back to my mentor's quote: if you did something 4 times and it didn't work, doing the same thing next time won't work. Sometimes you just need a different device. This is a patient on the left-hand panel, a 48 millimeter Gore cardioform ASD occluder. We just didn't have enough reach to collect all of the rim superiorly. And with a larger ASO, 34 millimeter ASO gives us 2 more millimeters on the left atrial size, enough, and a stiffer device, very nice result. So I think there's many ways to ensure success: balloon-assisted technique, left atrial pulmonary vein or left upper pulmonary vein deployment with the nitinol device, curving the delivery hypotube or manipulating the delivery monorail system with the Gore device can work, and changing the device also. So everything you have on your shelf, and also phone a friend. So with that, I'll thank you for your attention.
Thank you very much, Alison, for this huge amount of information and tips and tricks to deal with different and challenging situations. Thank you. Now we have to get the connection with another hospital in India, Narayana Super Specialty Hospital. Can you hear us? Hello? Yes, we are connected with you. Yes. Okay. Would you mind to introduce yourself, your team, and the case? Yeah. Okay. Any questions or comments from the panel? Well, personally, if I have to deal with multiple defects, balloon sizing or balloon interrogation is of paramount importance, in my opinion. What do you think?
Yes, most of the times when you have multiple ASDs, the main concept that you have is deciding what size for what defect. And if you have balloon sizing, you have go for the first one for the smallest and then for the biggest. So it is very important to know the sizes.
Yes, any other comments from the panelists, please?
I think it's very useful to size it, but more important thing is to make sure which defect they need to cross first before sizing, because of it is important to go to centrals of the defect, yeah. And if the central defect is not big enough, it's small, then you may go to the big one at the peripheral. I think that's quite tricky. If you go to central, you may use different kind of device like.
So you have to have at least 2 venous axes.
Yep.
Right.
No, I
Prof.
don't
D.
think so. It's not primary necessary. I think balloon sizing is mandatory first, and we have to try to cross the bigger hole. And in my practice, I use a pigtail, a small pigtail with angled shaft. You know what kind of, this is a pigtail with the angled shaft.
Yes,
Then
an angled pigtail you're talking about.
Yeah, I use this pigtail to cross, and the chance to cross the largest hole is very big. Then I will balloon size this, and if the balloon close everything, so I would go forward to use only one device.
Yeah, that's right. You have to decide whether the tissue between the 2 defects is so tiny, so inconsistent that you can figure out a single large ASD instead of 2.
Right.
Or
Mario?
you have to deal with 2 different sizes, 2 different devices to be implanted in. Yes. Joachim.
The
has a
3D
comment.
images were wonderful, but I think they overestimate the distance between the ASDs, because, I mean, they're done from the 2D images. When you look at the 2D images, the septum between maybe there's more than one, actually, more than 2. They seem very floppy. I think this device needs only one device, and what we need to do is cross the bigger of the ASDs, do a gentle balloon sizing, not to break the ridge between the 2.
Yes.
And then I think one device will be enough.
Yeah, that's right. So there are the comments. What are you going to do? Sorry, we cannot hear you well. Can you improve your audio connection? That's
It's
a
not
bit
so
better.
clear.
Carry on.
There are 2 defects, one bigger and one small. You assure that the second one, the smallest one, is not a stretched PFO or not an a very small PFO.
That's the reason to balloon interrogation. 16. Yes.
I'm not at all sure that I'm not at all sure that you're across the biggest ASD. I mean, it would be the first time that the biggest ESD is not the retroaortic one. I think you're across an inferior posterior one. I would bet that you're not in the biggest ASD.
Do you agree?
Have you heard the comment from Joachim? Yeah, the question is whether the balloon was through the big VSD or not. That was the question. Well, another point, if I make a comment, another point when you have multiple ASDs and rather floppy septum, when you cross one of the defects with the catheter or stiff wire, the anatomy can be modified significantly, so you cannot be 100% sure where we are. In addition to that, maybe the 3D reconstructions or 3D pictures that you can achieve can be helpful. Okay, carry on, carry on. Do whatever you want to do.
Dr. Lee, you had a comment in this situation for using a curved pigtail and from another venous side.
Just
So you deployed, what device was that? An Amplatzer, one number? LifeTech. Can you see the echo? You deployed the device very quickly. We couldn't, yeah, now we see that. Now, excuse me, tell us again what the device is this? Life.
Life take, yes. Life.
Look like look like a yes.
Yes. It's a life take.
Well, I don't know. In my mind, the LiveTech device has a different appearance anyway. This looks like an Unplatzer device in my mind, or whatever it is.
Okay. Yeah. Yeah, good job. Thank you very much. Can we see the short axis view of the echo? Yes. Yeah, and no compression on the aorta. Okay. Okay. Okay, thank you very much. I think it was a good job. Thank you very much, and thank you for your whole team. Good night.
Okay, thank you very much. Very, very interesting case. So now we go back to Mumbai. Hello, can you hear us? Can you see? Yes? We are back to you.
We snared it, we made a loop again. When this was the 7th French sheet, which is trying to not even negotiate with the exit. You can see the curve there. So instead of that, then we tried a 6th French sheet also, long sheet.
Yes.
Same. We had to change our plan. This is not the way it is going to work. Probably when we remove the diameter, the sheet just pops out of the exit. So we changed the route. We have taken an MFO 5 French sheet and we have got retrograde through the fistula out to the right atrium.
Okay.
So you're So you are just crossing the coronary artery, right coronary artery.
Yes.
Yes.
Yes. This is the last picture you've taken? Okay. Carry on. Absolutely. Absolutely. Carry on.
Could they just do an angio through their guiding catheter over the wire?
Joachim, another question for you.
Yeah. Could you just do an angio over the guide wire on your...
We would like to have an additional angiogram there.
Be sure that they're in the right atrium.
Can you do that? Well, I think the echo picture are nice, but are not so much informative. You would like to see the angiogram. Well, I don't know. But you can also do an angiogram leaving the wire in place, isn't it? Yeah. Okay.
No, it's not necessary, I think. But you know, one of the reasons that you were dislocated when you were approaching from the venous side was because you used a PDA sheet. If you use an ASD sheet, which not curved, it may be right positioned with not dislocation at all.
But anyway, you decided what to do. So please carry on and show us. Yeah, show us. Yes, show us quickly, click the device and carry on, please.
What is the size?
Can you zoom with your hands if you don't mind? Can you zoom with your hands? Now we can see better. Yes, thank you. Okay.
So the PDA side is stuck to the cable, and the other is will be into the gate.
All right.
So we, as we break the loop, I will go gradually from the other side of the wire, and we'll start inserting the device from this end.
Okay.
So you want to have just a disk on LA and the bulky side of the device in the current sinus. Yeah.
Exactly, exactly, sir, exactly. So I feel that the PDA shape of the MFO is going to give you a good resistance across. So, angle please, we are going in.
Mm-hmm.
There it is, and we have broken the loop. We are
Yeah.
at the exit of the sheet. I just put my first disc open.
Yeah.
Can you check on the echo, please? Chances of the echo? Do you see? The exit is completely blocked. So I'm going to take the whole assembly behind angio, please. And I'll show you the deployment, and then I'll do a check angiograms.
Can you see the bottom of the fluoro a bit better?
Show the bottom of the fluoro on the angio.
Yeah. Well, move the table. We don't want to see the aortic arch. We want to see where the coronaries are. Yeah.
Slow down. Slow down. Okay.
No. We want to see more the lower part of the heart.
Lower part.
All right.
Okay. Does that sound good?
Yeah.
Yes, and now zoom it.
And make a zoom, if you don't mind.
Yes, yes. Zoom. Go zoom.
Come on.
Okay. Shall I go? Is this better?
Yes, yes, yes. Now it's better.
The deployment sequence.
Okay.
The whole assembly I am putting behind. It's just under fluoro, not PA. Are we close to the exit?
You do a check angiogram, don't you?
Yes, we'll do one now. Angio at this level. Increase the contrast. Make it 2020. Button 2020, 800. One angiogram will do, and then we'll proceed.
I'm sorry, one question, please. Can you feel any resistance during pulling back? You have to feel resistance.
Yes, yes. Once I feel the resistance, then only I will push the other part of the device. I'll just wait for one angiogram and then we'll go. And also the transdigital echo is in place, so I'm ready and set. Shall we go with the angio?
Yes.
So here's your angio button.
Okay.
More clear?
Yeah.
We are getting away from the exit.
You have to pull more.
Okay.
Pull more behind. Yes. Just roll back. I'll pull it more. The whole assembly.
Yes. Now you feel some resistance, right?
Yes, yes. I can feel the resistance now.
All
Okay.
right.
Now you can open up the remaining part of the occluders.
So the device is fully released, full deployed now, yes? Okay.
And it's disfigured. I take a single image of the same.
Please.
Can we do one more angiogram in the same view?
Please do. Well, more or less.
Yes, echo, please.
Well, can you zoom a bit more just to see more clearly the shape of the device, if you don't mind? Yeah. Mm-hmm. Yeah. Yes. Can you see the floor again, please? And maybe with the zoom and maybe and injecting through the sheet. If you inject through the sheet, we'll be able to see better everything. Well, actually, the shape of the device is rather funny to me.
Yes, I wonder.
Can you do additional angiogram in different projection, maybe?
It's strange that the proximal part of the device is not open up.
It seems like the device got stretched and the proximal part attached to the cable got stuck and it couldn't open properly.
Yeah, that's right. That's exactly what we want to know. And to understand about the shape of the device, if you had to modify or whatever.
I don't think your exit is really blocked with the disc because there was way more than foaming. There's a big shunt through it. And the deformity, can you just sneak down and completely recapture it and see if it will reform? Because there's something wrong with the middle of it. It's a Cobra
Yeah, that's
MFO.
right. It looks like a Cobra shape, like an ASD devices.
No, now it looks better.
Yeah.
This is not a cobra anymore. It's another snake here.
Mario, can I make a comment?
Yeah, sure.
I think, as Alison said, the distal disc is at an angle and it's not closing the orifice. And the device is a bit twisted so that it is not occluding either. I would recapture the distal end, the proximal end, and reposition it so that it is more conformed.
Yeah. Did you hear the comments from Joseph Betukatil to recapture the device, try to redeploy in more proper way?
Yes, yes.
Now it looks better.
What kind of snake is going to be? Yeah. more promising. Alison, are you more happy with that? Yes, she is happier. Okay.
So,
I would do a different view. I would do a different view where the distal disc is profiled, and then you would know exactly where it is. You understand maybe cranial or caudal, but you need to put your disc. You need to profile your distal disc. Your
so you have some tension from the wire, and so if you release it, it may be good, a bit better in shape. Yes, go on. You have some residual chance, maybe because of the foaming through the device.
Yeah. That's right.
Okay, go on.
So actually, I think it's going to be satisfactory. So you're going to release the device. Yes. We look forward for it. Let's carry on, please. Okay. We are ready to applause. Thank you very much. Okay, that's. No more snakes. That's the proper device shape. Okay, so thank you very much. Shall we do a final angiogram?
Yeah.
Please. All right, 1 minute. Yes, yes, I think it's very, very good. Congratulations. Okay. Okay, congratulations. Bye-bye. Okay. Thank you very much for your performance. Very, very, very interesting case. Okay.
Thank you.
Thank you.
Very much.
Thank you. Very nice demonstrations. We are running very, very late, so we have to finish the session with 3 remaining sessions. So
Yes.
would you like to introduce the next speaker, Bezat?
The next speaker, Sang-Ho Kim from Japan, and how to deal with the multiple holds.
Yes, we are very late, so I will ask the speakers as much as possible to speed up their presentations, if you don't mind. Thank you.
Thank you for having me. My presentation is closely related to the live case just before the previous case. And yesterday's session of the interesting cases of the ASD closure around the world held in the function room, I enjoyed all the 20 presentations, and nearly half of the cases focused on the multi-fenestrated ASDs. So this highlights the significant interest in the assessment and methods and closure techniques for this special morphology, which has been extensively discussed over the years. No disclosures. 35 years ago, Dr. Jim Luck classified secondom ASD into 4 morphological categories to eventually apply transcatheter closure techniques. One category is the PFO type, followed by the defects predominantly involved in septum primer. And this also notes that the defects involved in the septum primum could often exhibit multi-fenestrations. Here, this is a landmark report from Chicago in 2007, the early days of multiple implant device placements. Their criteria of implanting more than one device for multiple defects included the presence of more than 7 millimeter rim of tissue between the margins of the defects. If the rim tissue between the less than 7 millimeter, they have been using one device to cover those defects. And Dr. Jeon Choi and colleagues emphasized that the 3D TEE is very useful to assess the morphological characteristics for multiple defects, and balloon sizing may provide additional anatomical information on the defects. On the other hand, I am always wondering whether this kind of defect should be referred to as multiple holes or a single big hole divided by strands. So in this presentation, I like to focus on the fenestrated ASDs, especially those subdivided by the strand tissue. Strand is the keyword. We perform balloon sizing using 2 approaches, strong and mild inflation, to estimate the strand's compliance. So if the strand is structurally supportive, we considered it can act as a part of rims for device anchoring. In this case, the device was placed in the defect posterior to the strand and leading to complete closure. So if you can see the waist clearly, it means less compliant, so to support the device. Okay. I will present a typical case involved in the report. The patient is a 41-year-old lady suspected to have a Raban sequence with a history of micrognathia, post-surgical repair of the cleft palate, and pectus excavatum. She had 15 to 30 cigarettes per day smoking history. She presented with palpitations, shortness of breath, and chest pain and back pain. She was 150 centimeters tall and weighed 42 kilograms. CT scan revealed a significant pectus excavatum compressing the left atrium, highly mobile tissue within the defect. This is a 3D reconstruction of the same CT. Scanning from the back to the front, we see a sail-like strand dividing the defect. Here we observe the strand from within the left atrium equally dividing the defect. In still images, the strand forms an isosceles triangle with apex folding into the roof of the left atrium, and the IVC side rim appears deficient. Now you have multiple options. What is your approach will be? Balloon size and deploy one device in anterior superior defect. Number 2, balloon size and deploy one device in posterior inferior defect. Number 3, deploy 2 devices, both anterior septal defect and posterior inferior defect. Number 4, cut the strand and deploy one big device and bring the patient to surgery. In this TEE view, the strand appears on the side of the narrow left atrium, and you can see a Chiari network in the right atrium. Here we can see the aortic root with a limited rim. The defect measured about 16 millimeters in both the anterior superior and the superior inferior aspect with the deficient posterior inferior rim. We anticipated we are not able to anchor the device at the posterior inferior defect, so we explored the possibility of placing the device at the anterior superior defect. Inflating a 35 millimeter occluded sizing balloon in the anterior superior defect easily created a distinct waist, measured 24 millimeter on TEE. We selected a 27 occluded device and deployed using left superior pulmonary vein technique due to small left atrium. The anterior disc was flared against the aortic root. Both the TE and ICE imaging at the same time showed the posterior inferior, sorry? So the posterior inferior defect is not completely captured between the two discs, but the device remained stable with a small residual leak. This is the CT taken 3 months later. The leak resolved by this time, and she has been doing well for more than 5 years now. In summary, our current thought process for multifenestrate ASDs divided by strand is like this. When the main defect is located anterior superiorly, or the defects are equal in size, if the balloon sizing test shows the strand promises the adequate device support, we proceed to transcatheter closure. If the strand shows poor support, we recommend surgery. The main defect is located posterior inferiorly. We decide according to the original posterior inferior rim, which ensure the stability of the device. So in conclusion, the strand can act as a part of the margin for the device closure. The defect position and deficient rim should be evaluated along with the compliance of the supporting strand and with balloon sizing. Thank you very much.
So thank you very much. Okay, so we proceed with Bezard that will talk about how to deal with big holes. Bezard.
Well, thank you very much. About ASD closure, how to deal with big holes. No disclosure. These are my team. And I just want to describe some cases. When I am speaking about big holes, the big holes have many difficulties. The flappy rims, the malaligned rims, all of them are in very big holes. The case one is a 64-year-old gentleman. He is heavy smoker and with aneurysmal intraatrial septum with moderate to large size ASD secundum and a smaller additional ASD. Both of them together are a very big hole. So we had an injection in right upper PV and we had two ballooning in two holes. As you can see, one of them has no waist and another one is smaller. And we decided to close with two different devices. So the first one was the smaller one, and because instead of use of a very big one device, we decided to have two devices. So the first device was the smaller one, and then we started with the second one. The second one was the bigger device in 22, and you can see, I told you that this patient had other difficulties, aneurysmal intraseptal intraatrial septum, and in this device, when we went for the second device, it was very good sandwiched and both together with no problem. But we started to release them, both of them in together, as you can see in the last slide. But as soon as we released them, they were dislocated because of the aneurysmal and the anatomy of the intraatrial septum. So two devices was in the place, but not in the same alignment anymore. You can see they were somehow perpendicular to each other. This was the first device, the second device, the bigger device in a place. And you can see the second device in a perpendicular position. So it was because of these two, the septum was very small, the septum was very loose. But, sorry, it doesn't work. Yes, but everything was okay and no problem. Yeah. In the last two slides, you can see that two devices are in, and they have an angle together, but no residual shown. Anyway, the second case was a 16-year-old boy with a large ASD secundum. It was suspected that there is another ASD secundum also too. And yes, you can see in the first injection on right upper PV, it seems that it may be another defect. We started to deploy the larger one with number 24. It was a cocoon device, but not so successful. So we used a wire to help the wires to take it in a good position, but it was good, everything was okay. And we released the device. But when we saw the device very carefully after releasing it, unfortunately, we saw that we realized that we might have passed the smaller device because on echo, this was the pictures that you can see. The device was not in position, and the device had a very bad angle to the septum, especially in the last slide. You can see that it is not in the place, but so it was not good at all. So we decided to change. It doesn't work. Yes, because it was in the smaller one, and we lost the larger one, we recaptured this one because it was very difficult for us to cross the another one when this device was in the place, and we tried it to capture it, we snare it. It was somehow difficult to take it, but fortunately, we done it. And then we had a balloon in the smaller one. We had the first catheter, the first sheet in the place, and we proceed for the larger one this time. As you can see, we were ready for deploying two devices in two different holes. But fortunately, when we closed the larger one this time, an echo, we were happy, and the second smaller one was also covered. And the third and last case was a large one with around 26 millimeter with very deficient anterosuperior rim. It was a high septal ASD, a large size ASD. So again, an injection in the right upper PV, balloon sizing, and we tried with a number 24 device, but this was not so easy to deploy it because we had a deficient also rim at the anterosuperior beneath the aorta. So we used another way from using from right upper PV technique. It was not so easy, and also it was not helpful.
So this case is going to be quick, Bezard.
Yeah.
Yes.
Okay, and we tried to use a wire to support it. It was not helpful. So finally, we decided to use the balloon sizing inside. And after that, also it was not helpful. So this time, we placed the balloon in a bicable alignment between the
Bezard,
SVC.
sorry, but we are too late. You cannot follow your
finished.
steps now. I beg you, you have to finish your topic.
Okay, it finished. And this was the result by using the balloon in bicable position, and finally it was released in a good place. So there was a ceremony of techniques for large holes. Thank you.
So thank you very much. We'll carry on with the next presentation, Hari Krishnan, that I asked this speaker to be very strict on time. I would say 5 minutes, please.
Can I have the slide, please? Good afternoon to all. I thank Dr. Chen for the opportunity. So the topic is how to deal with special septum, that is aneurysmal double spiral septum. It's quite a big topic. And when you deal with special, when you mean special, it is special in multiple ways because as you have seen, all these things come together, big holes, multiple aneurysmal and malaligned defects, they all come together. So I'll be discussing what is an IAS aneurysm, evaluating the floppiness of rims, and all the aspects that we discuss. I would be thankful to the other speakers who have already discussed many of these things, and it would be a little overlap between those. So single versus multiple defects, balloon sizing, whether to perform or not, and options like ribriform device. So IAS aneurysm is described as a circumscribed bulging in the atrial septum, protruding into the right atrium or the left atrium with a base width of at least 15 millimeters, or in a child it is 8 millimeter per meter square body surface area, or it could be an oscillating membrane with excursions. So the problems, we have discussed multiple problems. It could be multiple perforations. The rims are usually floppy. It interferes with device positioning stability. And is there a likelihood of thrombus formation? And so what would be the antiplatelet strategy? These are certain described classifications of intraatrial septal aneurysms. So what are the strategies? The ideal strategy would be to implant a single device that traps the entire aneurysm between the discs. So multiple techniques like assist deployment, single, multiple, whether balloon sizing is required. So we'll be discussing each with certain case examples. So this is a very simple case, conventional device delivery, a small defect. Though it is aneurysmal, there's only a single small defect which can be done by conventional techniques. Or a larger defect which needs a slightly larger like oversizing of the device size based on the sturdy rims. That is what is important. So this one, a 13-year-old with a 26 into 20 millimeter ostium secundum ASD, you can see significantly floppy rims in multiple aspects. These are the TE pictures, again showing very floppy rims in the 0 degree, 45 and the 90 degree. The postero-inferior rims are floppy. These are the TE pictures, again showing a very floppy postero-inferior septum. This initially we tried with a 30 device. We had measured 25 millimeters, so we had tried with a 30 device, but there was frequent prolapse. Probably we thought we had undersized, upsized to 34. Again, the same problem, prolapse, despite the PVSS techniques. And then with additional support, using a catheter with a stiff wire across the ASD into the LUPV, it was successful. So here, whether it was device undersizing versus more support required. That was the problem. Post-deployment, you can see it is very well seated without any residual. And usually we continue these patients on dual antiplatelets. So this is a 6-year-old with intrahiatal septum aneurysm with multiple openings. So you can see that although the rim between those septums are floppy, it had a length to it. So we decided to go for 2 devices. We've confirmed that both the defects were crossed. And as we've already described, simultaneous delivery of 2 devices. You have to sandwich the smaller device between the larger device discs, and both the discs are delivered. So this is an intrahiatal septal aneurysm with multiple perforations all over the septum. So it is ideal to go for a cribriform ASD occluder. So this was a 25 millimeter cribriform device. You usually pass through the central hole and make sure that all the defects are covered. Another example for a cribriform device. This is how it will look on fluoro. So another case, 8-year-old with incidentally detected murmur, a large ASD. Here you can see there's an intrahiatal septal aneurysm with a thin septum between the 2 larger defects. But another thing to note is that there's marked malalignment, that is the separation between the septum secundum and septum primum on the TE 45 degree, as was elegantly described already. It was 8 millimeter difference. You can see that the septum is going to the gutter between the RPA and the aorta here on 45 degrees.
Hari Krishnan, we're going to need you to speed up because Tin's waiting and then we've got another talk. So
yes, sir,
really
yes.
fast.
So this was an aneurysm with spiral septum. So we have already discussed malaligned septum. I'll skip through these slides. These are the clues on a transesophageal echo. That is, you don't visualize the ASD typically on a 0 degree. Only when you see the plane of the aorta it is seen. There's absent aortic rim, and the rims appear towards the gutter between RPA and the aorta. So this was also successfully closed using a 28 millimeter ASD occluder. The role of balloon we have already discussed. It is not so much for sizing. It would be to make sure that you've crossed through the intended larger device, and for balloon assisted deployment technique. So this is another interesting case. The last case is a 16-year-old with dyspnea, cyanosis, with saturation of 85%. You can see on TE images that RV is not significantly dilated, which you expect for an ASD, and there is significant septal malalignment on 40 degrees. Very interestingly, the girl also had moderate LV dysfunction with small RV and diastolic dysfunction. That was the reason for the right to left shunt across the ASD, causing cyanosis. You can see the angiograms also showing a small RV. So here what we wanted was an ASD device to suit this malaligned rim with a fenestration. So this is an innovative device design. The VASO device, the versatile ASD occluder. This has multiple grooves in the central waist. So this would be ideal for a malaligned device, a malaligned septum, because it will catch different rims on either side, as you can see in this TE. So to conclude, device closure can be challenging in intrahiatal septum with floppy rims. The sturdy margin should be taken for determining the device size. Different maneuvers would be required, like we have discussed. We must differentiate the undersizing of the device versus need for additional support, either with a dilator or a catheter. Double device specific considerations are floppiness, the interdefect distance, and making sure that you have interdigitated the disc. Balloon sizing is not necessary in all the multifenestrated septum. It is better to slightly oversize to avoid residual ASDs. And in a spiral or a malaligned septum, the device must enclose both the septum primum and the septum secundum without being wedged in between the septa. Devices with multiple ways would be ideal for spiral septum or malaligned ASDs. Thank you.
Thank you very much.
Thank you, Hari Krishnan. We haven't got time for discussion because we're way behind, so thank you. Before the last talk, we're just going to go for a live case with Tin. And let's see if we... Tin, can you hear us? Yeah.
Yeah, we can hear you.
Okay, very quickly.
Yeah, it's a lunch time, and so I give you the heavy lunch now.
Yeah, exactly.
And,
Yeah, it needs to be a fast lunch, so go. So, Tin, have you got about 50 of these cases lined up for the rest of the week? Yeah. Okay, let's go through quickly because I'm sure you're pretty much finished.
Can you see the angel now?
Yeah.
I and Tony Pa and our program, we did it together. And after seeing the angel,
Yeah, that's a fairly straight fistula for you, isn't it? Not very tortuous.
We learn to don't it's just very distal for ascending for using buster tube.
there are little bit challenging because the fistula because very tortuous. But luckily, the guy thermal wide and cross easily, and we see and try to advance very wide through the exit. And luckily, also luckily, go to the Burma artery. But after make the IV look, you see, I found that we crossed a very tiny hole.
Yeah. What sort of wire was that? Terumo or something else?
Thermal exchange thermal wire.
Yeah. Okay. Then you've got a circuit.
Yeah, and we use very for fixing technique because I could not advance the very catheter even though the very catheter just a five frame. I think we crossed a very tiny small hole. It's a multiple hole. And I did the angel again. You see the hole we crossed is a small hole. Another hole maybe multiple extra exit. And what we do, we try to cross again.
Yeah.
But fail again, second try fail again because the looks not so good, looks very ugly. And we cross a lot of times we try to cross and snare again. Luckily we cross a bigger hole.
Yeah.
And then you can cross the exit very easy. And we use fishing technique. And then advance the catheter to the fistula from the
I'm assuming there are no important myocardial branches of that fistula vessel, certainly not the ones, the bits we see, but were there any others towards the aorta? All right, whilst you're doing that, presumably you've decided what device you're going to use, because this would be suitable for anything, really. Tin? Hello?
So,
we've lost
Tin,
connection,
can
have we?
you show us? It was a pretty proximal fistula, I think. I know we could see the one origin of the normal left coronary, so just trying to figure out where that is and whether you would do a retrograde device and an antegrade device both to cap it.
Well, this could be, if they've got a circuit, it could be antigrade. If you couldn't get a circuit, you could do it retrograde. So options are there. There are multiple holes, so you've got plenty of choices of whatever device you want to use, really.
Yeah, I think the catheter from the right side is probably just past that choke point.
All right, so
I think we lost
I
them.
think we lost connection with Tin, otherwise we'll go with the lecture. Can somebody tell me? All right, we'll go with the lecture. Abdul Momin, let's go for a tour of different types of ASD closures. Can we change over to the slides?
Thank you, the organizer, for inviting me for this speech. I'm here to share my experiences with different type of ASD patient. I deal with the adult case, so all of my patients are adult one. This is my institute, and ASD with morphological variation, procedural complexity, different mode of presentation, concomitant other structural heart disease and LV disease. And when the rims are floppy, we took the support, these are the posterior superior, posterior inferior, and the IVC rim are floppy, and the device prolapses across the IAS. And we took the catheter support, and the catheter support works. But when catheter support fails, this is the case, the catheter,
did they just...
and when we remove the catheter, the ASD device rotated. And then we upsize one size bigger, and then the catheter support acts well, and the device is in position. Multiple ASD, we close this defect with a single device. First attempt, the device was prolapsing to the small ASD. Then on the second attempt, we assured that we are through the larger ASD, and then we deploy the device and confirm by transesophageal echo, single device. And floppy and malaligned rims, when we are not sure that we are the device got all the rims, we took the snare with the device, release from the wires, and keeping the snare in position, and then when we are sure, then we release the snare. How to tame cobra? This is the LA disc cobra, some gentle movement and pulling and pushing, the LA disc is in position. And this is the RA disc deformity. And this is also by pulling and pushing, the device is in position. And this is a permanent cobra deformity that we cannot tame, and then we have to pull all the settings out of by femoral root. And different mode of presentation. This is a post-surgical cases 2 years back, and we assessed by transesophageal echo some malalignment is there. So we faced the difficulties. Then we took the help of the equalizer balloon, and then the ASD in position, and we release the device. And this is another post-surgical cases, and we have no difficulty to deploy. This is an extremely kyphoscoliotic patient, the nightmare of a surgeon, and we deployed the device. Look at that, the heart shadow is on one side of the spine, and we deploy it by LUPV approach without any difficulties. This is a STEMI patient, STEMI inferior with ST elevation in inferior lead. There is a primary PCI done in the RCA. And during discharge, we diagnosed her large ASD. And after 3 weeks, we deployed a 38 millimeter device in this patient. And concomitant other structural heart disease, this is then Lutembecker syndrome, severe mitral rheumatic stenosis, and with an ASD. And look at the valve area is 0.8, but the gradient is 5 only because it underestimates due to the presence of ASD. So we first do the mitral balloon valvuloplasty with the 25 millimeter Inouye balloon and with a good result of 1.9 centimeter square MPa with minimal mitral regurgitation. And after 2 weeks, we deploy the device. And this is the result after the 2 structural abnormality managed by intervention. And the blue girl turns into pink. This is an 18-year-old girl with severe cyanosis and clubbing with oxygen, SpO2 is 45 to 60 at baseline. And look at the RV. There is a severe pulmonary stenosis with LV with a gradient of 159 and the trabeculation in RV. And this is the, we traversed with a smaller balloon. The smaller balloon burst it out. And then we successfully done the balloon valvuloplasty and the RV pressure comes down to 38, which was 160 previously. So this is the result, and 2 months later, we devised the ASD closer, and the pulmonary gradient is 34. But this is the most, and this is the SpO2 as before at baseline 43, 76 after pulmonary balloon, and 97 after the ASD closer. This is the second, this is a very interesting case of 18-year-old girl having a history of stillbirth 8 months back.
Dr. Momin, if you could wrap up, because Tin's
This
waiting.
is a clubbing and cyanosis in the patient, and we have done the pulmonary balloon valvuloplasty first. But still, after 3 months, there is bidirectional shunt across the ASD. So what to do next? We confirmed that bidirectional shunt in the in the levels, and then we decided to occlude the ASD with a device, wait for 20 minutes, and repeat the cardiac CAT data, and there is only 1 millimeter rise of RA pressure. We have very few literature in to search out. Yaniv and colleague has similar cases, and they deploy the device if there is no hemodynamic instability and no rise of blood, RA pressure more than 2 millimeters. So we deployed the device, and after 2 years, this lady gave birth to twin babies. So this is the LV disease, the heart failure with preserved ejection fraction, a coronary angiography, LCXS bifurcation lesion. We fix the lesion and then do the ASD device closer 3 months later. This is another case of heart failure with reduced ejection fraction, LV ejection fraction 35, and there is an ASD also. And we have the raised LVDP in echocardiography.
They're waiting now.
This is the last case. This is the last case. So the triple vessel disease, the surgeon refused him for CABG because diffuse LAD disease. So we fixed the RCA lesion first, and then in the first attempt, the LVEDP was 25. And after 3 months of medical therapy, we deployed the ASD device, and with occlusion of the ASD device, only 2 millimeter rise of LVEDP, so we deployed the device. So this is the result. So this is my endpoint, the heavenly smile in the patient face after successful device closure, avoiding the pain of sternotomy and complication of cardiopulmonary bypass is beyond comparison. Thank you for your patience.
Great. Thank you very much. All right, thank you very much. Right, let's join Tin again, please. Tin.
Yeah.
You've got, I'm going to give you 2 minutes, so tell us how far you've got. And this was, sorry, this was AVP2?
Yeah, AVP2.
What diameter?
Which
what
sheath
sheath?
do you have, Tin, and which device did you try? What size?
Oh. Okay. So that didn't work. What did you do next? What? Oh, everybody's hungry. They don't have any suggestions. So you tell us what you've done.
Honestly, if he has large size coils,
Joachim.
if you have large coils, you can just drop coils distally to the last coronary branch, and it's going to occlude.
Yeah.
We see branches there, by the way.
I see branches. Are there branches from this
Yeah.
retrograde injection there, Tin?
All right. So, Tin, what have you got there now? Okay. So is that where you're going to deliver it and release it or pull it back? Yes, what? I think so, yeah. I think we've lost them again, haven't we? Tin, can you hear us? What?
They lost.
Lost again.
Transmission.
Okay. All right. Well, we'll disconnect them even if we've lost them, and then we'll hand over to Alison for the next session. Thank you for previous panelists, moderators, and speakers. And so, Alison, if you take over for the next session. Thank you.
All right. Well, we're changing moderators and changing gears slightly.
Oh,
all right. Tin is back.
Tin, you're back. Can you hear us?
Sorry, we lost you quickly.
You can hear us. Okay. So tell us what you've done then. Yeah, I was going to say there's really nice flow through the device. And remind us, is this got covering patches or not? I don't think this has.
What size is it? 6'8" wouldn't have that.
No. So there's no patches. So there's no harm in you're there with the catheter, put another device in. Yeah? So, and you could put the same size in. Yeah. Right. So do it in 30 seconds if you could.
What size is it, Jacques?
8'6", I think.
8'6".
That's looking
very
better.
nice. It's
now.
Yeah. So release it very quickly.
This case.
It's a good example of a distal fistula because you see your side branches.
This patient could have had problems because we didn't see the distal branch until the end.
Yeah.
People don't do occlusion angios, and we always should be doing an occlusion angio before
Yeah.
putting any device.
Yeah. Important message. Okay. Tin, so have you released it yet? Yeah, show us and then we can disconnect. So do an angiogram at the other end, which will look good. Yeah? And then we disconnect. There you go. And you can see myocardial branches distally as well. Okay, Tin, thank you very much again to the whole team. Oh, right. Okay, this is a very important question. I would be worried about those branches, so I think I would anticoagulate this properly, not just dual antiplatelets. Yeah?
To me, it looks as if we would have patients, the first device would have been enough. Look at the angio.
It may have been or it may not have been. It's just
No, but here it looks, because the flow stops completely at the first device.
Yeah. Okay. Okay. So I think anticoagulation. I don't know what Tin thinks. Yeah. Okay. All right, Tin. Thank you. Well done to the team again. A big hand for Tin and his group. All right. Alison, all yours.
All right, thank you. Thank you, Shaq. We're going to move into the lunch session. So if anyone has not had lunch, please do. We'll bring it in. We will move with lectures because once we come back to Tin with his next case, then we'll be live again. So I want to thank my co-moderators. I think almost everyone is here. So Omar, Teji, Masood, yep, Ramod Kumar is not here. Dr. Wong is here. So we're going to start with embolized ASD device, Jay Young, and we'll kindly ask our speakers to recognize the time constraints that we are in so that we can be on time for the gala tonight also.
Good afternoon, ladies and gentlemen. I'm Jang Choi from Severance Cardiovascular Hospital, Seoul, Korea. My talk is about embolized ASD device. Device embolization is the most common major complication in ASD closure. Percutaneous retrieval is feasible and safe in majority of cases. However, for the initial decision, we have to consider several the issues: patient clinical condition, location of embolized device, and suitability and risk of catheter retrieval, and whether the device embolization occurred with a correctable cause and institutional circumstances, etc. For example, in this case, with the embolized the AS device tangled with a valve apparatus, surgical retrieval should be safer. So what to do when the device embolizes? Don't panic. In most of the cases, the patient maintains a hemodynamically stable condition or take proper action to stabilize the device in a safe location, and the team members may take action like simultaneous action, like call for surgical backup and ensuring proper anticoagulation. Then you can take time for the detailed strategy of retrieval, including the upsizing the sheath or using the special snare technique. So the cath lab should be equipped with the necessary hardwares, including retrieval sheaths, catheters, and or retrieval tools. The snare has some key role in the retrieving the device, and also some other the devices to stabilize the device, including biotome and some forceps. And biplane fluoroscopy and proper echo guidance is very helpful. So this slide shows some algorithm approach on the embolized ASD occluder. If the patient maintains a stable condition and there is no valvular interaction, you can proceed with the snare technique. You can consider to upsize the sheath in this stage and also later. So if a simple snare technique is not successful, which means the complete recapture of all the device into the retrieval sheath is impossible, then you can escalate the technique to a more advanced technique. Or in this stage also, you can consider to upsize the sheath. So then when is the device unable to retract into the sheath? There may be some difficulty in capturing the device or clamping pin, and also there may be some difficulty in collapsing the snare device into the sheath. So the details of the retrieval mechanism, mechanical retrieval technique depends on some release mechanism on the device. So devices with screw detach mechanism, retrieval ultimately requires snare technique. So difficulty due to the latching of the RA and the screw at the orifice, like this pictures, may be the main problem. Several tips are known, including beveling of a sheath tip, use of an oversized sheath, and the elongation of the device in the IVC. However, with the beveled sheath and the elongation of the device in the IVC, the latching may still be a problem. So if you use two snares, push the first snare while pulling the second snare, it changes the orientation of the end screw, and you can see the device can be introduced into the sheath, as you can see in this movie clip. Otherwise, if you snare the opposite side of the RA end screw, the device can more easily be introduced into the sheath. Then how can get an opposite position of two snares? Pass first snare catheter using the second snare, and then advance the snare to the device and push the second snare while pulling the first snare. Then it takes up the opposite position automatically, as you can see here. On the other hand, the device with small clamping pin like Occlutech device, the problem is that the snare slips off the RA pin in the majority of the cases, and the simple snare technique is very difficult to retrieve the device. However, if you use two snares, the second snare may give a more grabbing force and helps to securely hold the RA pin. However, with any snare technique, there may be an unexpected cause of retrieval failure using snares. As you can see here, the enfolding of the sheath tip at the orifice may obstruct the lumen and cause a failure to bring the device into the sheath. So this kind of partially retracted the Occlutech device can be recaptured using the delivery cable of Occlutech device, and it can be introduced into the sheath, and you can retrieve the device. Another reason may be the unexpected the kinking of the snare catheter, as you can see here, or some exfoliated Teflon coating on the snare cable like this. And so it is a good idea to use a kink resistance catheter and avoid too strong tension of a snare cable, causing catheter kink or exfoliation of the Teflon coating. The devices in the septum, if you have any need to retrieve it, you can use the delivery cable of Occlutech device to recapture the RA pin. The snare assist recapture technique is useful when the device is in the cardiac chamber. The snare the RA pin and bring it into the sheath, then exchange the snare to delivery cable, and you can retrieve the device. The feasibility of this technique in the beating heart that depends on whether you can stabilize the device and the sheath with the RA pin inside the sheath like this. However, if the device is in the IVC or descending aorta, you can easily retract the device into the sheath using this technique. There may be some usefulness of other devices, including Maslanka forceps. There have been some report that this is helpful in retrieving the device with a small array pin. However, in our bench test, retrieval of an occlutech device using the Maslanka forceps was not successful by grabbing in the body. So successful retrieval using the Maslanka forceps requires grabbing at the clamping pin or very close bundle of wires to the array pin, or you have to unlatch the array pin by holding the pin using additional forceps or snares. LifeTech device also have a small array clamping pin. However, there is some slightly slapped the pin here. So if you grab the proximal portion to this array pin, the retrieval is possible. And if you use two snares, it is even more easier. So in conclusion, ladies and gentlemen, an operator should be aware of various difficulties in retrieval of embolized ASD device and be prepared with adequate technique, knowledge, and information on equipment. Different retrieval strategies are required for different kinds of devices. And the embolized ASD device with a smaller or no connecting pin may more easily be retrieved with a strategic approach using complex retrieval techniques. Thank you very much for your kind attention.
Thank you, Jae Young. Nicely demonstrated. We'll all call you if we have an embolized device. Moving right on to Kevin Walsh to discuss mitral valve regurgitation.
Thank you, Alison. Slides are about to come up. Great, thank you. Disclosures. Maybe space bar. Sorry. We ready? Okay, great. So this isn't uncommon to see after ASD closure, particularly in older patients where you have mitral regurgitation. Sometimes they're before, sometimes not, sometimes worse and sometimes better. So Nigel Wilson reported 227 adults and children, 97 to 2004, and they looked at the degree of mitral regurgitation, unchanged in 88%. In 2, it increased from trivial to moderate. In 18, there was 1 increase in grade, but interestingly, in 13, there was a decrease in mitral regurgitation of 1 grade, including a severe mitral regurgitation going to trivial. A Japanese paper, increasing LV preload may contribute to mitral regurgitation deterioration. 228 patients, mitral regurgitation increased in 32, reduced in 3, and stayed the same in 253. It was independently related to advanced age and female gender, and the degree of enlargement of the mitral annulus was greater in patients with mitral regurgitant deterioration. And it wasn't linked to any adverse clinical outcomes. Mechanisms for mitral regurgitation in patients with secundum ASD, certainly there's cleft mitral valve prolapse, which may relate to interventricular septum, dislocation of the anterior leaflet towards the LA side near the posterior medial commissure is meant to be the mechanism for this sort of prolapse of the anterior leaflet. It's well recognized even surgically with a large ASD using an edge-to-edge repair at the time of ASD closure rather than the ring that we normally see with it. In terms of trying to understand it a bit better, here's another Japanese patient or group, 27 patients, 19 females, 10 with worsening mitral regurgitation, and they were able to show that those who had a more globular right ventricle and a larger QPQS and older age were more likely to have a deterioration in the degree of mitral regurgitation. Looking at cases, here's one. Clearly, we do see these patients, not very often, but this is one where it's touching the leaflet, but the patient has significant functional mitral regurgitation, and the patients also had myocardial infarction. Another example of mitral regurgitation post, this is where 32 millimeter ASD device was placed 4 years before that. During dialysis, she had significant hypotension, but with a background of atrial fibrillation and hypertension. This is a picture of it, and this is how they planned an edge-to-edge percutaneous repair. They were able to simulate where the puncture should be and what the angle of approach for the delivery catheter for the clip should be. And this was the procedure, edge-to-edge repair, and a very significant reduction in the degree of mitral regurgitation. So a transcatheter solution. Another example of planning repair using transeptal access for left heart structural interventions. And this is, they're actually puncturing sort of inferior to the device to get an angle where they can deliver a clip to the mitral valve. This is what we've been doing for transeptal access. This is to show how we get the sheaths actually through the devices into the left atrium in this particular patient to allow pulmonary vein isolation and appendage closure. An important aspect of these punctures is that you need to enlarge the SL1 sheaths that we use for puncture with just a plain needle so that it'll take a 3-5 wire, because it's better to have an Amplatz extra stiff or some sort of wire in there to get your device, get your sheaths through the device. We use long balloons to be able to drag the sheaths in to the atrium. It's interesting that you can separate these fibers to the mesh, and it will close down, and you don't need to do it afterwards. So to conclude, it's often present beforehand. It's mostly due to changes in ventricular geometry and LV loading, often clinically silent, unusual to be related directly to the device, and edge-to-edge repair transcatheter is possible. Thank you very much.
Kevin, thank you very much. This kind of issue, for the say, after the issue after the device closure, that will be very big issue in the future. Thank you very much.
Thank you.
So next speaker is complication of the arrhythmia. Jun Yoshimoto, please start your lecture.
So thank you very much for inviting me for this great meetings. And my topic is how to survive from complications of ASD closure arrhythmia. Move, as always. Wait, okay. So no financial COI, but actually I'm an electrophysiologist. So I'm going to start with my case, the 11 years of female at the time of the ASD closure. She was found to have the ASD with this ECG screening test, and ASD was closed. But actually, she had a pre-procedural Wenckebach second-degree AV block, and closed with the ASO 40 millimeter. And then, unfortunately, we lost the detailed data, so now we see the full oral here and close in a good position, ASO. But still, she had a Wenckebach at this point. And with the echo, yes, the device is sitting in a good place. But she had a Wenckebach, and 1 year later, she had a master double test and one first-degree PR prolongation and Wenckebach. And now, 11 years later, she had a second to third degree AV block. And also, she had a relatively slow atrial rate, like 63 BPM, and ventricular rate 45. She's now really doing well, and she refused any pacemakers. So now just watching, and she's really doing good. So how it happens and how it goes, and how we anticipate for this one is a really big problem. And related to the ASD device closure, some kinds of arrhythmia happen, like bradyarrhythmia, atrial block, and sixth nerve syndrome, and tachyarrhythmia, atrial tachycardia, and atrial fibrillation. first we have to understand the anatomy. And AV nodes sit in a cough triangle, and they really close to the ASD. So we have to understand the actual compact AV node, not okay, compact AV node like here, and his bundle goes under the membrane septum. So we don't we really careful about the touching this area. And also sinus node is another problem. Of course, the ASD is really far from the sinus node, but coronary artery is just near in some cases. For example, in some kind of coronary artery anatomy, then maybe the compression may occur, or in some left-sided case, the LCX has a branch towards the sinus node, so the device may touch the coronary artery, so we have to be aware of that. The incidence of the AV block and after the ASD closure, there are many reports, and Montreal group reported that the AV block after the ambulatory septal occluded to be 6.2%, and most cases resolving spontaneously over time. And Royal Children's Hospital in Australia also reported the 5% of device, and compared to the 2%, surgical may be larger in number, but there are no significant difference. And even the surgical group had a larger ASD and smaller body weight, but still the same percentage. But she warned that this result has some bias because the surgical group tends to have shorter follow-up periods. And also, they're not only the amplatzer, but also other type of the septal occluder may cause the AV block. And also, even the gore can make the AV block, but the transient AV block in this paper. What is the risk factor of the AV block? The larger device is thought to be one of the risk factors. From the Montreal, the device size has a significantly larger in a patient with AV block. But the Australian group reported that pre-procedural AV block has a really important factor, like my case. In a multivariate analysis, procedure AV block has a significance. But most AV blocks spontaneously resolve, as you know, that both series reports that mostly spontaneously resolve. And usually, if you see the AV block during the procedure, you give some steroids and just wait, pray. And that is the usual case, and mostly it resolves. But in some case, you have to remove the device. And in this paper, they removed they had a complete AV block after the gore. So they removed that. And in this paper, really big picture, the device touched the cough triangle. This is really dangerous thing for the electrophysiologist because, yes, this device touches the cough triangle, tendon of Chojaro, and a huge fibrous tissue compress the tendon of Chojaro. And during the session, you will see the fluoro image or esophageal echo. But EP guys see the mapping and because we see this coronary sinus electrogram, so we can see the cough triangle. So if you want to see the actual image during the closure, then please ask electrophysiologist about the imaging. Sorry. Okay, so let's move on to another arrhythmia like atrial fibrillation and atrial tachycardia. In a meta-analysis of papers, the incident rate of atrial tachycardia after ASD device occlusion was 8.6%. And the new onset atrial fibrillation is higher in ASD device occlusion cohort. So we have to prepare for this. And after the ASD closure, the circulatory status get better, but still the atrial fibrillation or atrial tachycardia may occur. And risk factor is the age and history of atrial arrhythmia. So in such cases, you have to anticipate for the another ablation or something. And Okayama group in Japan reported the upfront coronary as catheter ablation may have the better, but still they have some recurrence or some other new atrial tachycardia, so you have to prepare for that. But as is already reported, that septal puncture is now available with a broken needle or RF needle, so we can do the ablation even for the left-sided atrial tachycardia. And for the atrial fibrillation, nowadays not only the catheter ablation, but the balloon, and now pulse field ablation is available. So with only one catheter, we can do the atrial fibrillation ablation. So if you see the atrial fibrillation, please ask the electrophysiologist. So for conclusion, AV block and atrial arrhythmias are common problems during and after an ASD closure. AV block may be predictable with history of AV block, larger device needs. It can resolve spontaneously, but may need pacemaker implantation or device removal. ASD closure may increase the number of the atrial tachycardia incidents, while pre-closure ablation may decrease them. However, decrease is careful consideration of patient history, age, and procedural factors is essential in managing arrhythmia risk post-ASD closure. Thank you.
Thank you, Dr. Yoshimoto. The discussion will be at tea time. So the next issue is erosion. Dr. Tomita is here. Hideshi is here. I haven't seen him today. Okay, so let's skip the residual shunt. Sorry? No.
Okay,
So,
Doctor, we'll look for him. Dr. Hideshi is with TIN for the next live case.
Yes.
Amal is here. You will save the day. Thank you. Okay, this topic is thrombosis. We seem to have a stoppage on the slides, though. So
Good
can
afternoon.
we find Amal's slides? Maybe 1 second on the slides.
Okay. No, it's not. Where's the first slide? Okay. So, good afternoon, everyone. I'm going to talk about thrombosis as a complication in ASD device closure, no disclosures. As we all know, ASDs account for 10% of all congenital heart disease, and it is the most frequent type of atrial septal defect is the secondum type. And the standard line of treatment now, of course, is the transcatheter device closure for 70 to 80% of cases, and cardiac surgery is deferred for those which are not suitable for transcatheter closure. And device closure now, over 25 years maybe, is comparable to surgery. Of course, we must do the anatomic assessment, and I'm sure all of us had a lot of lectures about that. So the thrombosis, there are a few literature reviews about thrombosis incidence and predisposing factors. However, it accounts in some of the literature for 1 to 2% incidence. It's mainly in adults, There are sometimes comorbidities that are predisposing factors. It usually occurs early within 4 weeks of the procedure. However, late thrombosis is also reported. In some literature review, it is related to device type. There are thrombosis cases in some devices more than the others. And also it is, in some literature reviews, related to persistent atrial septal aneurysm. The current common devices, as we all know, the Occlutech, the Gore, the Helix, and the ASD Amplatzer or Abbott device. And it was mentioned that there was no thrombosis related to the Abbott devices. The other predisposing factors is the coagulation and hematological disorders, the frame fracture in the wire-based devices. It's up to 15% in one series. The aneurysm, as mentioned, the residual shunt, the paroxysmal atrial fibrillation or arrhythmias post-procedure, incomplete endothelialization in surgically extracted thrombi. It was noticed that there were incomplete endothelialization in those cases which developed thrombosis. As I mentioned, the device type. COVID-19 infection also was related to some of these thrombotic events as case reports, the age, old age, and comorbidities. However, the anticoagulation protocol has no effect. Examples from the literature, right disc thrombosis of the new Gore cardioform ASD occluder because it has a metal framework. However, in this particular case report, there was absence of device frame fracture, which was thought to be the cause of thrombosis, late thrombosis in this particular cases. Persistent atrial septal aneurysm, thrombotic events cases were 4 cases reported in literature, and it was found as a significant predictor for thrombus formation. In 17 of the 20 patients, the thrombus resolved under anticoagulation therapy with heparin or warfarin. In 3 patients, the thrombus was removed surgically. These are some few pictures of interatrial aneurysms. Usually we use sometimes cribriform Amplatzer device in these cases. However, there were no cases of thrombosis related to this particular device. It also mentioned in the literature about the nitinol used in manufacture of these devices and the ability for vascular endothelial growth factor to induce endothelial cells in surrounding tissues to migrate, proliferate, and form and cover the device. However, it is not substantiated at all that is thrombosis related to this alloy. This is a review of literature of some of the case reports and some series of thrombotic events following ASD device closure. And the highlighted ones are the only children. So it's mainly an adult event. There was also a mention about the thrombosis site. It is more on the left atrial side than the right atrium or both. And that was found in 5 out of 407 series, accounting for 1.2%. The presentation, of course, can be related to the thromboembolic manifestation, stroke, pulmonary embolism, fatigue, headache, but in many cases it is completely asymptomatic, and also a thrombus can induce bacterial endocarditis, and that can be the presentation. Intra-procedural thrombosis can happen if no heparinization enough during the procedure or prolonged procedure, or in dehydration, sometimes prolonged wire in the pulmonary vein, no backflow. So we should have ACT monitoring and proper heparinization. Usually the intra-procedural thrombosis resolves completely with no late sequelae. This is a case report with device-related thrombosis on atrial septal defect occluder after simultaneous closure of left atrial appendage and atrial septal defect, obviously in an adult. This is also from the literature, how huge sometimes these thrombi can be. What are the preventive protocols? Some literature mentioned routine TE for adult follow-up at 4 weeks, 6 months, and 1 year to make sure there is no post-procedure thrombosis. In children, of course, transthoracic echo is enough. Anticoagulation protocols are based on clinical trial, and there's a difference between children and adults, but no consensus about the long term. Device choice. PFO closure did not stop the TIA and thromboembolic events in published series in old age. And some of these reports mention to avoid this problem is to do minimally invasive surgery. Of course, during the procedure, to avoid thrombosis, we have to do de-airing of the sheath. In case of the event of thrombosis, a lot of investigation, hematological investigations, and of course, hematological consultation must be sought. The treatment is anticoagulation, heparin or warfarin. There is no consensus. Thrombectomy, surgical thrombectomy in huge thrombi, or failure of the medical treatment. Of course, treatment of the predisposing factors, and there's no consensus about the long term. The bacterial endocarditis post-ASD device closure is definitely a rarer event. 3 cases were reported in a series of 28,000 patients. And with the removal of the device due to bacterial endocarditis, it was found that there was deficient endothelialization in these cases. This is an example of intra-procedure thrombus on the right side. On the right disc side, small thrombus. Usually, this will resolve spontaneously. This is a study we did in our center about the Axel occluder, Occlutech Axel occluder for transcatheter closure, which is a coated occluder. And these are the animal studies showing the endothelization with the Axel-coated occluder versus the non-Axel-coated occluder. We used this device in around 40 cases, and they were all successful. The long-term expectation after transcatheter ASD closure, of course, we do not want a thrombus formation. Thank you.
Okay, thank you very much. Fortunately, we have some time for the discussion in the whole of these sessions. So is there any other? Okay, Jay, please come up to the podium. We'd like to start for some question from each speakers. The retrieval is a very big issue, and technically, do you have any difficulty for in your practice or some other resolution for that new comment?
Jay, can I ask you, you had an excellent talk. That was really outstanding. You said that you need to stabilize the device first before you can really embolize it appropriately. What if the device is in the right ventricle or left ventricle and is not caught by the apparatus? How do you stabilize it?
So the left side device embolization is a problem, but fortunately, in the majority of left side embolization, the device, especially larger device, stays in the LA. Then we can manage that from the LA. Of course, we have to be careful for some air embolism or thrombus formation. If the device is in the LA, may I have my slides? If a device embolized to LV, there is a problem because LV is usually underloaded, chronically underloaded LV, and the volume is smaller. And there is a very important structure, mitral valve and mitral valve apparatus. And also aortic valve is very important. So smaller device, if it embolized to LV, it spontaneously gets some aortic arch position. But a little bit larger device, it there are some reports that they are retrieved through the retrograde fashion. The anterograde fashion shouldn't be attempted because it may damage the mitral valve. But there is one report that they retrieved the device from the main side through the ASD to the mitral valve. But I think it is very, very dangerous manipulation. But some device similar to the aortic valve annulus, you can by slides, please. The first one, embolization. You can try very carefully to move the device to the ascending aorta. So, no.
Maybe Jay, maybe that's difficult.
Okay,
yes.
yeah.
I think you also showed very quickly, but didn't discuss, Jay, the
I have a nice slide.
ONO device as far as basket retrieval. How many people in the audience would have access to something like the ONO? Maybe just a few of us.
I haven't.
It may be named that way for a reason. When you say, oh no, that should not have happened, or I should not have done that.
So may I?
You may make another comment, of course.
So if the device is once in the ascending aorta, you can try to get it back in the descending aorta. It may be more safe. It doesn't move. It doesn't move. Then usually I try to retrieve hold the system in the below level to the renal artery. So I have some in the end of the slides because in concerns of time I removed this from my talk. Yeah, that one. Before. You can see the device is in the LV. We snared and we confirmed that the device is free from the mitral valve apparatus. And I used one more snare like that. And when I tilted the device in various directions, device came out from the LV spontaneously without damaging aortic valve. And I put it back, and the descending aorta, I could retrieve it using the original the delivery sheath, not upsized, using two snare technique.
So
like
without putting it into the sheath, you pulled it all along the aorta.
No, it is the delivery sheath. They put the sheath, actually, but the same size as the original delivery sheath.
But Jay, I mean, it's very impressive what you suggested with this double snare and so on. This procedure here, somehow I would not like to do because I think the IVC is forgiving, but the descending aorta, you don't want to damage the intima. This is my thinking because the device is some devices are very tough. What do you think about what I'm saying?
So if a device is too large, we shouldn't put it back, to put it down to the descending aorta. But
thinking loud.
The alignment of the vessel to device is very important for the smooth retrieval.
Without resistance. So it is, I think borderline. 28 millimeter device is similar to the aortic diameter. So if it is too big, I think I consider it surgical retrieval rather than the transcatheter.
So what we are saying is that for smaller devices, we can do that because that would be fairly safe.
Exactly.
But obviously, if it's a large device, then you have to bring it into the sheath to really pull it back. Then it would not be feasible from the left side.
Exactly,
you have to go from the right side.
Exactly.
You didn't. You said that you need to stabilize the device, but you didn't say how. And I was lucky enough to work with Chuck Mullins in the cath lab, and he suggests if the device embolizes to the left atrium, he would push a wire across the device.
Yeah.
And hold it like this, and then start to think what to do
to prevent further embolization around the, yes, yes. And I think sheath size is pretty critical for these. So the right side is very forgiving. So I know sometimes when we're using the large Gore ASD device, we will use a larger short dry seal just in case. That device, you need to make sure it doesn't unlock if you need to retrieve it after you have locked it. We try not to do that. But there's also, I think, ways that you can minimize some of those complications by thinking ahead and hopefully not having embolization.
Yeah, in adult unit, they have some devices for the ECMO sheath, so the bigger sheath is available.
And Jay very rightly pointed out that we need to make sure that we are anticoagulating while we are doing the whole thing. Because sometimes you tend to forget that it has taken you half an hour or 45 minutes to actually retrieve an embolized device. At what ACT would you keep them while you are doing all this standard, or would you keep it at a higher ACT?
So I think try to maintain the ACT in between the 250 around. Yes.
200, 200,
Yeah.
250 usually.
So a little bit, 50 second higher than the usual maintenance.
Alison, you know you are also using the Gore in a retrieval Gore device. Sometimes difficult to the whole of the device.
I think it's very difficult to retrieve.
Yeah, right.
So we're very careful in terms of imaging, I would say, before we actually lock the device, although there's sometimes you actually need to lock, but we're making sure we don't have prolapse or too much where you have shunt. So I would rather reposition than lock and retrieve, especially for the larger devices.
Right.
GSO, not such a big deal, but still, making sure that everything is appropriate before you are locked and as you are locked, that you don't have to retrieve. But I think understanding when you need to do that is also appropriate.
Yeah.
You can see the retrievable. It is not the cardioform ASD device, but this is a GSO. If you use two snare, it is much easier.
Yeah, but this device, the last part of they have a locking mechanism. So last part is
very easy to unlock the GSO and it comes out no problem. The GCA is a little bit trickier,
Okay, I
I
see.
think. Kevin, you had a very nice talk on access, also with the mitral valve, and I know that as we see more and more left-sided interventions, we're trying to be proactive in terms of arrhythmia assessment or LAAO before ASD closure or things. So I don't think there's a situation now where we're too frightened to enter the left atrium, whether through a device or around a device, but it seems to be coming up more frequently.
Yeah, definitely as patients get older and, there's going to be a lot more mitral clips and, and there's so much ablation needed. And certainly if you present with an ASD, and you've had AFib or a flutter beforehand, you're probably going to be back with atrial dysrhythmia. So I think it's very important for people to be able to get back easily and patients not to be turned down for what can really be very significantly improving procedures for them. So we've certainly found going through the device much easier than we thought it would be. And initially we got ASD devices in because we usually get them in for cases because we were worried that we'd leave a residual ASD behind us, but the mesh, the nitinol mesh just seems to cover back over pretty quickly when we check it at the end of the case.
Let's say in probably the ablation catheter, it's a relatively easy, not easy, but I say can do it. But how about as an appendage closure? Is that still possible?
We've done quite a few trans-device appendage closures as well, and I think that works fine. The one thing we learned about in terms of puncturing the devices, we learned it's actually better to do it on fluoroscopy. Echo doesn't really help you that much because you have so much reflection off the metal and things. And the other thing we learned was that the the needle tip shouldn't be too close to the actual hub or screw, because it's like a bicycle wheel. The actual mesh is a lot tighter together, and it's harder to stretch it apart if you completely in the center of the device. Those were just a couple of bits we learned.
Yeah, especially cases for the smaller device, like usually 20 something, still the atrium has still space for the puncture. But the bigger one, for the over than 26, no space in the right atrium.
The ones that have a small, like PFO type device, I think it's always pretty much going to be easier to go around the edge of it.
Yeah, I think I've been surprised sometimes when even our EP colleagues will come with a patient who had 44, 48 GORE, GCA, show us the CT, and they said, you'll help us get through the device because you can go through power wire and make sure you're access to the left atrium. And almost all the time they're able to sneak around the device. They can find a spot, and it's usually in a more favorable location for ablation. It's different than even, mitral valve access in the same area also is typically not where our devices lay, more anterior, superior. Gareth?
Yeah, can I ask, I'm not sure, is Yan Ho still here?
Gareth, did you have a...
Yeah, I know it did, but I wanted to know if Yan Ho was in the audience because I wanted to ask something. Because when we talk about...
Yan, okay.
We talk about going around the edge of devices, and almost always when we close atrial septal defects, the edges of the devices we place are not in the primum septum anymore, they're on the secundum septum, and the majority of the secundum septum, I thought, was an invagination of tissue into the atrium and is not actually a true septum. So I appreciate that practically what we're doing when we're saying, oh, there'll be room around the side, but how worried should we be? Has anybody, and I'm sorry I missed the first couple of lectures, so I might have missed this, has anybody gone out and in and caused a problem when they've gone around the edge of a device? Because surely a lot of the time we're puncturing through two pieces of atrial wall and joining I suppose the transverse sinus, in some cases behind the heart. Because, I mean, that's why we puncture the primum septum when we do transeptal punctures.
No, that's a really good point, and I think, honestly, I remember back to the very first days of MitraClip in a transeptal access where it was not recognized that it was in that sulcus, if you will, posteriorly until the equipment comes out, and then you have hemopericardium. But I think we're used to tomographic imaging also and looking at that plane of tissue. I don't know, Kevin, you have a remark about that?
Yeah, no, I think the pre-procedural CT is going to help you a good bit. And then I think, although maybe it doesn't help you in terms of tenting with a device, but if you're going at the edge of the device and you would have some sort of echo guidance, we would anyway, and we would want to see some tenting, and we'd want to see our needle go into cavity. Not a really long course. I mean, although clearly when we're puncturing extracardiac Fontan conduits, that's very different. We are going out and going back in, and we're relying that everything is stuck down.
There we're relying on their multiple previous operations to stem the tide. Sometimes these patients are virgin chest.
Well, that's why I'm wondering is actually, what I'm thinking is if the device has been there for a while, are we actually getting a little bit of benefit from some fibrous tissue that's giving us a bit more solidity in that sulcus? Because again, I don't know. I haven't heard what the percentage of people getting hemopericardiums when we do this is. I'm guessing it's very low because the reports have been very, very positive. But I'm wondering almost, is the presence of a device causing a fibrous reaction that's giving us a bit like what we see with the Fontan conduits, where you're really actually stacking layers of tissue against each other rather than having a true gap?
Yeah, it would be interesting to see what the surgeons say in terms of dissecting out the parts on re-entry for other things, which often there will be.
Barrett.
Yeah, I just wanted to comment on that, Gareth. In the era when transseptal punctures were not done with guidance of transesophageal echo, this was not an uncommon phenomena called as the atrial stitch. As a matter of fact, we have reported atrial stitch maybe 20 or 25 years back.
And what you say is absolutely right, that you go through the posterior wall of the right atrium into the posterior wall of the left atrium, thinking that you have gone through the interatrial septum. The first clue to this is when you pass the dilator. Believe me, the dilator will not go like it will go through the septum. And when you have to struggle and struggle, you have to be very careful. And if you then go on to get with the dilator and formerly the Inui balloon, what Allison said, when you will bring everything out, within a minute or two, you will see the tamponade. Till that time, everything will be hunky-dory, till such time you come out. But it's a real phenomena which does occur, and if you have a large device, it's not beyond my imagination that it could occur even with a transesophageal control.
Yes.
Great,
Yes,
I think
yeah.
one more
Issue.
comment.
Yes.
Sorry.
And then we'll take a short break. Okay. So we're going to catch up a little bit on time here. TIN is not quite ready to go live from their cath lab, so we'll reconvene for the next session at 2:30. You have 8 minutes to get coffee.
Coffee time. Great.
Not that you're on time.
Thank you. My gentle bending for the cabinet. Yeah. Especially for the 44, 48. Without bending, it's almost impossible to deploy. Okay. Yeah, that's right. Yeah. Otherwise, very difficult to the bigger core device. But I see it's actually.
Okay, good afternoon. I think we'll start with the afternoon session. And I think Tin is ready. So Tin, we can see the patient and the lab, but I'm not sure. Okay, great. Go ahead. So Tin, let me just introduce to you our moderators and the panelists. So we have Martin Schneider and Oliver Stumper as my co-moderators, and Joachim Miro, Mulyadi, and Dr. Kin as the panelists. So now you can proceed. So, so Tin, what are the dimensions? Yeah, we can see. So what we can see probably is more from the left ventricular aspect. Can you show us a little bit more on the right ventricular aspect? I mean, either of them. Okay. So any comments, Martin, Joachim? Okay, so guys, they want to see the angiogram. Yeah, Tin, let me take opinion from my co-moderators and panelists. Yes, Martin, go ahead.
It looks like it can be closed with a small muscular VSD occlusion system.
Joachim, would you like to close this VSD at all?
Well, that's another issue, but obviously,
so Tin,
here they want to close it, and I respect that. I mean,
okay,
it's not,
that's
we
fine.
wouldn't close it in Montreal. Obviously, in Montreal, I don't think anybody would refer a VSD like this, but I respect that. The only thing, I would redo the angio with a little more contrast. It seems like a smaller VSD than the echo,
Yeah.
and then I would put, if it's smaller than 5 millimeters, I would put an ADO2.
So,
5 by 6.
Tin, I agree with you that you want to close it for whatever the indications, but have you done any kind of hemodynamic estimates like QP by QS or anything like that? Okay. Okay, tell me, have you looked at the left ventricular dimensions? Are they more than, is the Z-score more than 2? Or what is the indication apart from prophylaxis closure from point of view of infective endocarditis?
I had a case in.
Martin, you wanted to say something?
I had a case in China. The young man had no indication from the hemodynamic point of view, but a loud murmur. And I said, no, I don't going to close it. And everybody was very sad. And then they told me that the young man is going to marry and his wife won't get him with a murmur. So I closed the VSDs.
Okay.
The indication can
I remember when I first traveled to China, they would show me all the patients before the cath, and they showed me an ASD of 6-7 millimeters, and I told them, we don't close this one. And they just sent her to surgery because the family really wanted to. So they said, okay, well, the professor doesn't want to close it, so she goes to surgery. So, indication, I don't interfere with local indications.
Okay, so Tin, let's move forwards. We'll keep the indication as is. So tell us, what are the measurements on angiogram? Did you make them at all or difficult to make, and you're going by the echo measurements?
I would do another angio. It doesn't look like a big VSD. And it makes a difference because if it's smaller, they can just put an ADO2. ADO2 is going to be a wonderful device for this.
So what are your thoughts? Joachim is saying that he wants to do one more angiogram.
More contrast.
And maybe a different angulation. Different angulation from the lateral.
Steeper LAO in the frontal plane.
Bharat.
Or in the lateral. But
Can I make a comment?
Yeah, Ahmad wants to say something. Go ahead.
The indication may differ from the region to region, but the complications are not different from the region to region. So, transcatheter intervention, in my opinion, and also in literature data, that the risk of endocarditis is much lower than the complication of transcatheter closure of ventricular septal defect. It is not ASD closure. In small ASD closure, maybe very, very low risk of, even if erosion may occur in 1,000. It is not difficult to explain the patient the risk of endocarditis, the risk of marriage is not important, even if you can do extraordinary efforts and heavy sports with these small defects. With the prophylaxis of endocarditis, less than 1% of in your life is the risk of endocarditis, but the AV block maybe in permanent VSDs, I mean, more than 1% in transcatheter closure. closure in some centers, in some hands, and also aortic regurgitation, regurgitation, etc. So many risk of complications.
Okay.
So it shouldn't be difficult to explain to the patients, to the population, than to have complications.
Okay. Joseph.
Couldn't resist making a comment about the measurement of the defect in echo. Because if you measure in 3D, you are seeing the flow on your face and you can measure it, the width of the color, anything you want. And I feel that unless you do a three-dimensional MPR, multiplanar, at the restrictor point, you won't get the accurate measurement. I feel this is much overestimated if you say 5 to 6 millimeter, maximum 2 millimeter or 3 millimeter visually. But I think if you really measure a VSD or any defect, it has to be in MPR in 3 planes, and then you get the right measurement.
So, Tin, you have heard the comments from Ahmed, from Joseph. So what is your plan now? What they say is probably... So can you tell us something more about this device? So, so Tin, give us some more information. What are the various sizes of devices available? And what about the 11? Right. So the formula is you add 2 millimeters to the diameter that you measured on echo, is it? 3 millimeters. And he said something about the threads. What are those threads? To lock the device?
You know, what's wrong with permanent devices? Nitinol, we have now 30 years of follow-up of Nitinol devices. When I started training with Gymlock and the clamshell. The clamshell had to be retrieved because it was, falling apart. And by definition, a resorbable device is going to fall apart. This is what we ask her to do. So I just see disadvantages or potential disadvantages. I just see residual shunts eventually, or pieces of that material going into the brain. I don't find a purpose of designing stents. Yes, but intracardiac devices, nitinol intracardiac is very good.
Okay.
We're putting a device, it's much more complicated, a bigger sheet, and
I don't want to disturb Tin, but does anybody understand how the device attaches to the delivery system?
Come again, Gareth?
I don't want to disturb Tin, but does anybody understand how the device attaches to the delivery system? Because it's not clear how it actually attaches.
Tin.
Oh, okay.
Yeah, we can see that. Yeah.
But what is it you're screwing in?
So there's no screw?
So Tin, we want to know this thread is for what? For locking the device after you deliver it, before releasing it? What is the purpose of this thread? That's right. Because most of these bioabsorbable devices have to have a locking mechanism so as to flatten the device before you release it. The only issue is that once you lock this device, you cannot retrieve it. Till such time they load the device. Joachim, I agree with you that We have been with nitinol devices for almost 3 decades now. But the thing is that there are some long-term issues with nitinol devices, like the conduction system. Not only the AV blocks, but even late onset left bundle branch blocks. So I think that there is a room for improvement. I wouldn't say that probably.
I don't know of many AV blocks that have appeared 30 years after. I mean, we would start seeing long-term complications. We don't. We don't. I think nitinol is a wonderful material because it's permanent.
I will tell you, I have seen one case 2 years after. There are reports from China now, including the softest device, which is ADO2, having, I think, around 3 or 4 cases with left bundle branch block from one group. So late onset, and late onset left bundle branch block is the worst because dyssynchrony and left ventricular dysfunction is almost a rule there.
Well, maybe, but you know, maybe this device is going to elicit some inflammatory response, and you'll get also brain. Okay. I don't see that many long-term complications of nitinol.
Okay, take your point. I mean, this device could also have those issues related to inflammation and fibrosis. Anybody else wants to comment till such time? One more issue with biodegradable devices has been its radio opacity. It has been so poor that, God forbid, if this device were to embolize, I mean, getting it out would be a nightmare.
Thrombi. Normally, you expect more thrombi in the first months because you're degrading. You have an inflammatory response. So, I don't think it's that necessary. For stents, obviously, stents is another issue.
Martin, you have any?
Are there any markers on this device? You know?
There are markers, but they are so faint. There are, I think, platinum markers, but they are not so radio opaque. And believe me, you will have to scan from top to bottom to see where the device is.
It goes to the brain.
I have used this device in animals, and it was really a nightmare to see where the device is.
If it goes to the brain, you won't, unless you do a scan, you won't be able to see it.
So the main marker is the catheter itself? Or?
Yeah, but till such time it's on the catheter. And it's extremely echogenic. So you see wonderful images on echocardiography, but they are very, very poor in terms of radio opacity. So Tin, do you think that we can do one talk and come back to you? Is that okay with you, in the interest of time? So we will do just one talk and we will be back with you. Thank you. So I think we'll go with the first talk of this session on management of strategy for atrial septal defect with pulmonary arterial hypertension. Will be delivered by my good friend from India, Neeraj Awasthi. Over to you, Neeraj.
Thank you, sir, for the introduction, and thank you, Tin, and the organizing team for giving this opportunity to interact with such a lovely audience and people from all over the world. So I'll come out to my topic, which was given as ASD with pulmonary artery hypertension and management strategies. First, so it was like a puzzle to me. I thought how to approach. I thought we'll divide it into etiological work of a pulmonary artery hypertension, a misnomers, which can go for a ASD with PAH, which is very usual whenever the ASD presents with a pulmonary artery hypertension like morpho presentation. device modifications and the options in a literature review, and like to finish it within time. So whenever we have a ASD and PAH, we have to, moderate to severe PH is present in almost 9 to 22% with multiple publications there. The preoperative PH is a very important predictor for morbidity and mortality. And essentially, there are two causes. Either it's a long-standing ASD, which has secondarily led to a pulmonary artery hypertension, or its ASD is just an innocent bystander, which is actually the rule in most of the cases. Whenever it is there, the second question comes is whether it is reversible or irreversible. And if it is irreversible, is it idiopathic? And what is the etiology? Or is it Eisenmengerized primarily because of the atrial septal defect? Well, etiological workup. This lady has just entered. She is 41 years old. She has come with a ASD with a TR gradient of 45. She herself said she has come with a peak of Delhi sun in summer vacation, and you can see that scar. It is telling for itself. Rule out underlying etiologies. The face would speak for themselves. The hands would speak for themselves. And most of the time, ASD is an innocent bystander. Well, these are the common scenarios where you get ASD-like presentations. Are these systemic anomalies, such as there you had a ASD where hepatic veins were going to left atrium, unroofed left SVC was there, or left SVC was in fact draining to left atrium. And these are common scenarios where ASD is just an innocent bystander. In fact, ASD is not a cause of cyanosis, and there is needs to look at something else. Contrast injection is a very good adjunct whenever doing it. It rules out all these systemic anomalies, anomalously directed veins, associated AVMs, and of course it tells you the direction of the shunt. Another case, a 56-year-old ostium secundum ASD, diagnosed at 20 years of age, usual scenario. Now she has become 56-year-old with 3 kids with apparently asymptomatic period of pregnancy, now presenting with 7 days history of fever, with increased swelling. She was managed as LRTI and discharged without clinical improvement, and subsequently worsened and again got readmitted. And this was a similar history over a period of last 5 years that she presented each time with chest infection. She is not able to lie down. She has got a tachycardia with a very low saturation of 42%, and you put oxygen, it goes to almost 100%, mild pallor and raised JVP, all signs of heart failures which are there. And of course, remember any case of ASD, if he's having a very good ejection systolic murmur, it is telling you a difference between the lungs and the right atrial pressure. Ejection systolic murmur is a very good clinical sign which tells you probably the antegrade flow is very good and you are not dealing with a primary PH-like situation. She had a very good antegrade murmur. But she's in respiratory type 2, the ECG is sinus tachycardia, the patient was intubated and inotropes are initiated. And this is what the picture is, where you see the ASD, which is bidirection stenting, and IVC is outward dilated. Poor windows because the lungs are all hyperinflated, severe TR, and we waited. The TLC is high, PNB, pro-BNPs are high, LFTs are deranged, antibacterial have been started, and Klebsiella pneumonia was positive, and she's treated. Now, CT shows a lower low bronchoectasis with infective changes. So what was happening was each time she presented over last 10 years, she presented with infection of this bronchoectatic segments, and she used to improve and get discharged. This time, she continued to be on ventilator and we were unable to wean off, where the IVC improved over a period of time. The ASD started shunting left to right. Well, there is still a chest infection, whether I should put in my device or should I wait? Well, that was a question. 4 weeks later, she is off BiPAP. She's off ventilator, sorry, but on BiPAP with a saturation of 92%. Well, they have been given a trial of vasodilators also, which is not really justified with a type 3 pulmonary artery hypertension with lung issues. The TCRPs have become normal, the T shows adequate RIMS, and the TR gradient, which has significantly come down to almost 55. This time we took it to cath lab. The cath lab shows the hemodynamic data with a QPQS of 3.5:1, a significant step up. With a PPA mean of 35, balloon occlusion was done with no significant RVEDP changes, LVEDP was 10, the coronary artery angiogram was normal, and subsequently it was closed with the ASD without a fenestration with a 32 millimeter device, because the QPQS is significant and the PA pressures have actually normalized after chest infection. So she's doing wonderfully well, and it's almost, the last TR gradient was 40, and this is the last echo which is demonstrated. We published this case and demonstrating that the lung issues are a very important cause whenever dealing with ASD-like situation. Another typical scenario, when you have an apico-caval juxtaposition, that means where the heart is opposite to the side of IVC, invariably the interatrial septum is directed in such a way that IVC blood invariably goes to the other septum. And these are some of the series of patients where ASD was there, PA pressure was apparently normal. I would say ASD was an innocent bystander. which was there. Pulmonary venous hypertension is a very bad type 2 pulmonary artery hypertension. Always rule out a type 2 pulmonary artery hypertension whenever they're dealing like the ASD-like scenario, be it a diastolic dysfunction or mitral valve involvement, like mitral MS. Well, this was an interesting case. Just to summarize, this was a case who was actually with ASD with Eisenmenger, who presented with ASD Eisenmenger, was admitted with under adult cardiologist colleague, and who incidentally was a very good ejection systolic murmur, was having an unproved LSVC, which was leading to cyanosis, a borderline mitral valve, which was not picked up because of the ASD. The mitral gradients were not easily picked up, and that is why actually once we surgically treated him with actually the patient improved. This is another case where there was a malaligned septum. You can see the orientation of the ASD device in the AP view and the LA view, how the ASD intraatrial septum is placed. And when I give the IVC shot, in fact, it is going directly towards the device. So that was the reason that 1 year old 8 kg child was having a saturation of around 70%, which improved after the closure of the ASDs. So bystander is a very common scenario in ASD PH. It is actually not, ASD is not a cause of PH. It is always rule out mitral valve diseases, shunt lesions, non-cardiac causes, airway problems, and genetic syndromes. Now, what if it is not a that means it's isolated ASD with a pulmonary artery hypertension? The clinical decision, next what? First scenario is straightforward. It's mild to moderate pulmonary artery hypertension. The systemic saturation is more than 95%, QPQS is more than 1.5. We are going to close it. Scenario 2, there is severe pulmonary artery hypertension, which is attributable, Eisenmenger syndrome, less than 90%, we are not going to treat it. The challenge is in between, where you have in between the two extremes of scenarios. So whenever it is there, it is the decision question would be, is the data sufficient to attribute to PH? Remember, don't go by isolated measurements, by cath, take all the measurements, the clinical data, the ejection systolic murmurs, the echocardiographic data before you actually attribute. Then of course, see for reversibility, and of course, there are long-term issues. The decision of operability would come from clinical data, the X-ray, the ECG, and of course, the echocardiography with these parameters, which actually be suggestive of pulmonary artery hypertension. For borderline scenario, I would go to this particular indication, which has been highlighted in ESC, which class 2B indication. Whenever PVRI is less than 5, and there's a significant left to right shunt with QPQS more than 1.5, it's a clear indication to close with a fenestrated ASD. Well, fenestration has been discussed. We generally tend to do it surgically. It has been described and is a very good method, but we tend to do it with a wire, with a balloon, and target around 6 millimeters in such particular occasion where QPQS is significant. Before I came, I thought I'll have a review. We took a very soft criteria. We took PA pressures more than 20 over a period of last 3 years with 221 patients, which we could find in such a criteria, of which 6 patients we had closed with a ASD device. And follow-ups, if you see, most of the time the mean PA pressures are around 30 to 45. They are just beyond 30. So they're not very high pulmonary artery pressures. For high pulmonary artery pressures, I would still like to wait and let it have a natural course before I take a decision. The publications have been sufficient, that very interesting publications over these particular group, which actually 56 patients who actually did a medical therapy. Subsequently, the pressures could come down, and PA pressures actually normalized in 8 of the 19 patients. And what is actually a treat, repair, treat strategy may actually work in some cases. To summarize, it's actually a clinical challenge. You require a multi-dimensional approach, and if in doubt, better to follow up these patients or at the most perforate these patients. And follow-up means it is better to, like the last two cross-references which we have shown, it is better to treat them and then go for a closure rather than close and treat. And even better to treat and keep them and keep reassessing them once you go in for a closure. Even if you close them, it is better to keep reassessing them in follow-up, because you never know the natural history. Thank you.
Thank you, Neeraj. I think we'll discuss at the end all the topics. Together, we'll go back to the cath lab with Dr. Tin. Tin, we are back with you. Go ahead. What have you done so far?
Device advanced close
Yeah, we can see it on the echo in the left ventricle. Yeah, we can see that coming back. So,
Both discs are open in the LV now, eh? I hope it's easy to recapture.
so, uh, Tin, we just want to see the fluoroscopy for a minute. Why don't you show us the fluoroscopy? Just for a minute to see how radio opaque this device is. That's what I said. You can't see anything. Okay, thank you. Go back to echo. Sorry. Oliver.
I saw it very faintly.
Hey, Bharat,
Yeah? Yeah, go ahead.
can they do an LV injection? Left ventricle angiogram now. That will be helpful
Yeah.
to see the device.
You can't see it on fluoro.
Can they do LV injection, contrast injection?
Okay.
That will tell you if the device is in the VSD or where it is at.
Okay, so Zahid says, why don't you make one contrast injection in the LV to see where the device is?
I hope I'm not tempting fate, but this is going to be a bundle of laughs if it embolizes.
That's a recipe for disaster.
That's a major issue. That's a major issue. You just can't find this device.
They should be putting, better markers, because this device embolizes. The only way you will know where it is which organ is failing.
Yeah. 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 So what have you done, Tin? Have you locked the device or still to be locked?
How long does it take the device to bioabsorb? You know?
So the question is, how long does it take for the device to get completely absorbed?
Because if it embolizes, so how long it will obstruct some vessel?
I think, Martin, it will take at least a few months, if not years, before it gets completely reabsorbed. Yeah. Tin, if you're wanting to do something and go off live, then we can finish one more talk and come back to you. Okay. So can we do one LV angio and see? Can we see the fluoro? Okay. So you are happy with the position? Yeah. So Oliver, Tin Oliver wants to make a comment.
No, sorry I came late, but I wonder whether it might be possible actually to soak the device in contrast medium.
Well, contrast would probably go away, but they should insert something in the fabric that makes it a little more.
Yeah, or even to do a sidearm injection from the delivery sheath.
Soak it in something like nitinol, is that what you're suggesting, Joachim?
Tin Narayana is ready for live transmission, so you have a couple of minutes.
So Bharat, can I say something?
Go ahead,
So
please.
as it was seen with the absorb stent, when they used to implant in the coronaries, what it used to have, what they used to do when they started the absorb stent was that at the distal point there'll be a very microscopic marker, and the proximal point will have a microscopic marker. Similarly, they can put a microscopic marker which looks like a very little dot on the distal rim and the proximal rim.
Parag, there are markers, but they are not visible. When it comes to stent, the diameter is very small. When it comes to device with that kind of a diameter, seeing those markers on.
So a marker who's not visible is not a marker.
So how do you release it? Just unscrew it? And they remove the threads? So to release, I imagine you first need to remove the threads.
Yeah.
So again, everybody can see the device and everything before we move to the presentation.
The, the septal leaflet doesn't move very well, the
Yeah.
tricuspid septal leaflet.
Yeah. It is probably tethered a little bit.
Not going to be.
Okay, so Tin, can we leave you now and go to the second center for the live case?
Just one last question to Tin. If you're forced to get it out, how? How would you do it?
No, it's not possible.
Well, first of all, I think we need to congratulate the people who have done this. It's very interesting work, and I need to congratulate Tin and the Echo person because it's really very nice. But I don't see the utility of this device.
Yeah. Thank you. Thank you for the demonstration. Thank you. Okay, we go to Calcutta. Amitava, can you hear us? Good afternoon. Amitava, can you hear us? Yeah, very much. You are, yes. We can see you and we can hear you. Go ahead.
Right, thank you. So here we are in the afternoon. We have the case, my colleague Dr. Alikul is depicting the clinical history. Yeah, then we have the presentation case. Yeah, yeah. So I hope you can see the slide. So this is a 4.5-year-old kid presenting with right arm respiratory section, pelvic side, weighs only around 11 kg, has typical clinical features of an ASD with S2, ejection lumbar and tricuspid metathelioma. So next slide. Yeah, so X-ray DCTs are unremarkable, largely large. There is plethora, of course, there is cardiomegaly and incomplete right matrix block, typical features, right? So we do our plans in thoracic echo, and as you can see, there is an ASD, pathological defect, there is a central defect, which is only around 9 millimeters. So, but the child has the symptoms as well as the right-sided volume overload, which is probably out of proportion. So we looked a little bit deeper. Next, please. So there is an additional quite moderate size sinus defect. So this child has a moderate to large size sinus and an additional secondary defect. The 4D volume image also shows nicely both the defects, as you can see there. So we have taken this child back. Of course, there can be many plans. Can we have operator B? Operator B.
Yeah, I will ask Dr. Akhtar to sort of discuss the plan, and then we will move on to Dr. Sullivan for the echo. Yeah. So now, this morning, what we planned is that we'll close the San Francisco ASD because it's the bigger one and leave the smaller one ASD. Yes, there can be several thoughts about it, that why can't we close both of them, or maybe we close one of them, or maybe close both of them at a later date. Since the child was quite symptomatic and the largest ASD was the synovitis one, we choose to close this one first, followed by the smaller one, which still remains numerically significant. So we have taken an axis on the right. We have taken the axis of the right femoral vein, left femoral vein and the left femoral artery, and the right internal ventral vein. Of course, surgery was also an option, but the parents did not opt for a surgery. They opted for a interventional way. That's why we chose for this one, because surgery, maybe economically it might be debated as whether it would have been economically viable or economically cheaper. So now we are going to close, or rather we have gone beyond that one. We have gone for the sanitary closure with the ventrically graft covered stent. And my colleague Sanjeevan will show the key pictures and echo pictures now. Okay, can I have the POV? No, what is the POV? Okay, clear intuition? Okay, so as you can see, there is a right nominate incision where we can see the SBC. So I would like to highlight few important things here. First of all, there is a very high of nomination. So we have a very good landing zone of stent. And even later the landing zone is coming around 24 years. So probably putting a stent is not very unsafe for this particular child. I'll go to the T. I'll go to the T measure. Can you measure echo this? Echo this, please. Okay. As you can see, this is the optimum ASD, which is a central photovoltaic switch measuring around 9 millimeters. If you look carefully, there is another defect, the sinus is clearly seen here. The pulmonary vein is very visible defect, the right upper one. The photovoltaic defect is around 9 to 10 millimeters, and the sinus is measuring around 7 millimeters.
Bharat?
How old is this patient?
Bharat.
Sorry, go ahead, Zahid.
I just...
1 minute, there is a comment from Zahid. Go ahead.
I'm really, I'm trying to figure out, I don't have much concept about sinus venosus ASD closures, but the idea of closing the defect in an 11 kilogram child where you may never be able to grow the SVC with the patient as the patient grows, is that a good idea?
So the question is that in this child who is 9 years old,
11 kilograms.
Pardon?
11 kilograms.
And 11 kilograms, is it a good idea to do this, to do this case percutaneously?
Found that, of course, an adult SVC would be somewhere around 16, 18 millimeters. And in this case, we were, based on our balloon study, we felt we will be probably going up to that around almost like 14 or 16 millimeters then we will put. So it will almost go to the adult side in terms of the transverse growth. Of course, there is the vertical growth of the SVC also should be considered. But this stent can be redilatable, whatever we were thinking. Other thing is, we were also concerned not only about the SVC growth, but the pulmonary veins also. So that way we felt that we should keep the ostium secundum ASD open. In case later on we do the redilatation of the stent, we can always do a protection of the pulmonary vein, which we have done. We are going to do in this case also. So couple of things. It is challenging. It is debatable. It is common. Of course, this child can go for surgery. Surgery is a very decent option for this child. But we felt with the specific set of features which child has and the additional secondum ASD which gives us a scope for future redilatation of the stent, we felt we can possibly go ahead for closure of this defect.
How confident are you that once you place a covered stent across that sinus venosus defect coming back into the right atrial cavity, that you will be able to access the left atrium easily and that the right atrial disc will sit in a proper position once you have the stent across.
We have checked the length. Yes, sir. It's a very valid question. We have checked the length. So on PE, my colleague can show you a live one. That on PE, the low wave deployed the stent, and there is enough of a space so that we can approach the second AAC easily. Okay, can you listen to me? Okay.
Bharat,
Yeah.
one comment.
Yeah, Joseph has a comment. Excuse me. Just 1 minute. Just 1 minute. 1 minute. Let Joseph make a comment. Yes, Joseph.
It may be possible to dilate the SVC to 14 millimeter or 15 millimeter because it is quite stretchable. But the neighboring structure is the pulmonary vein. It will be expanding into the pulmonary vein. So how are you going to protect the anomalous pulmonary venous drainage? Ensure that there will be no obstruction when you dilate to 14 millimeter.
Yeah, that is one of the concerns. And as a matter of fact, that is one of the reasons why closing.
We are going to demonstrate it.
No, I agree with you that you will demonstrate it at one point in time, that your point is well taken. Here, the concerns are of growth.
So we have put a catheter and the wire inside the right upper pulmonary vein, and we have kept a Mustang balloon, 6 into 20 Mustang balloon in place, and we dilated the Mustang, protected the pulmonary vein, then we dilated the stent.
Okay.
We formed a small amount of dent, and already the place is protected. And as my colleague Rohit was saying, we have left the second ASD open. If we ever redilate, then we have the option of going inside the right upper pulmonary vein and doing the same kind of protection again, so that even if we do the procedure, it is slightly when the baby grows up.
Okay.
And the pulmonary vein is also expected to slightly grow up.
Okay.
Intentionally, we have left the second ASD open so that we can repeat the procedure, taking adequate protection from the right upper pulmonary vein, and at the same time dilating
Okay.
to the maximum diameter.
Okay, point is taken. Now let's see what you have done.
Bharat,
Yeah.
can I ask a question?
One more comment from the floor before you proceed. Just one more comment. Yes, Ahmad.
Yeah, I have consideration about the big graft, how much it can be expanded because of commonly we did flaring of the right atrial part of the stent for eliminating of the residual shunt after stent implantation in sinus venous defects. So as far as I know, it cannot expand it much more as Tenzik CP or XXL Andratech stents like this.
So the other concern is about the stretchability of these stents. Since they are covered stents, what happens to the covering over a period of time, and whether you will be able to stretch this stent further and to what extent?
Yes, sir. So what we did was, according to the hospital manufacturer's guidelines, it can be stretched up to even 1.5 to even 1.7 times. So the manufacturer of this particular stent, they say they can be dilated up to 20. And actually, we tested without balloon, with another balloon we did we did a bench testing, and then we retrained.
Okay, good. So now go ahead. Yeah, but in the interest of time, now you will have to proceed. Show us what you have done. Good.
So as you can see, one catheter is there in the right upper pulmonary vein, and we have ensured that we have crossed the osteocerebellum defect to enter the right upper pulmonary vein. Next. Okay, next. So going to do the balloon profiling. We are doing the balloon profiling using a MAPT 14 into 40 millimeter.
So this is a non-compliant balloon.
This is a non-compliant balloon.
Okay, okay.
So can you measure for me? Okay. So during the balloon profiling, as you can see, the defect is completely occluded, and the right upper pulmonary vein is clearly seen here.
Yes, we can see that.
Yeah.
Have you done any angiogram?
But one important thing I would like to highlight, there is some fluctuation across the right upper pulmonary vein. We have continuously pressure was approximately 15 to 16 millimeter of mercury, and during this balloon inflation, it went up to 18. So there was increment by 2 millimeter of mercury while doing the balloon profile. But we have ensured that we have completely occluded the shunt using a 14 into 40 millimeter maximum LV balloon. Okay.
Did it occlude the secondum defect also, or secondum was flowing freely?
No, secondum is flowing. So as you can see, like secondum is flowing.
Okay.
The flow rate is the secondum.
Have you done the angiogram during balloon occlusion or balloon interrogation?
So the balloon explosion, we have done the 14 to 40 millimeter balloon, and my colleague has injected to the right upper pulmonary vein, which is unobstructed, though there was a pressure increased by 2 points. Next, please. Next. So you can see there is some flow across the there is a electrolyte shunt, but that is to the defect. So ocular segment defect.
Okay.
The segment is completely occupied by the balloon testing. Now inspect the wire, 435 unpressure wire in the right upper pulmonary vein, the soft ender, and we first place the Mustang balloon 6 into 30 millimeter Mustang balloon in position. We didn't dilate it, we just kept in position. Thereafter, we took the stent over the wire, venomous loop wire. And after that, we have injected to the left vein, left arm vein, to just see whether the position, check the position of the illuminate vein. So this is a demonstration. We placed our stent as a cover stent just at the floor of the illuminate vein so that it does not overlap or jail, and we have got enough of a landing zone so that to give us enough of a friction to make the stent stay in place. Thereafter, next one please. So we inflated the Mustang balloon for the protection of the pulmonary vein. Next. Next please. Yeah. So now you see the Mustang is inflated up to 10 atmospheres, taking protection of the pulmonary vein, and then two of our colleagues have stabilized the venomous loop wire. The third colleague stabilized the stent in place, and under vision, we have inflated the cover stent. Inflation please. Yeah. Yeah. From start. Yeah. So this is inflation. So incidentally, we would like to give the measurement of the SDC once more. The SDC at the top measures about 9.5 to 10 millimeters. In the middle, it measures about 11 millimeters. And at the junction of the RA, it measures about 13 millimeters. So it shows a 14 millimeters set. Next. Balloon first, so that the injection on the stent. So the Mustang balloon usually is a much higher pressure balloon. So it is a way to protect the pulmonary vein. So Shivakumar often has mentioned in some of his articles. So the same way we have done. So we have indented the posterior wall of the stent to create a pathway of the pulmonary vein, because it's a higher pressure balloon. So after we deflate this balloon, then we deflate the Mustang. Next. Next. So this is the left hand angiogram. So there is clear unobstructed drainage from the innominate, and the stent appears quite stable. So next.
Sorry,
Why
are you injecting from the arm when you have a jugular introducer?
So yeah, so we wanted to see the.
We'll see it.
Sometimes when we inject from the right RIJV, we may not. We will see the negative clearance of the innominate, but we may not be able to appreciate the drainage of the innominate that way. So that's why we are. We have injected from the RIJV also, but we wanted to be sure that we are not jailed the innominate. That's why we injected from the arm. So this is the injection in the RIJV. It is again showing unobstructed drainage. So the pressure of hemodynamic drift. So we have the pressure now, pulmonary venous pressure. Yeah, just give us a moment. We'll show the live pulmonary venous pressure. The RIJV catheter line to the light. Yep. Okay, so as you can see, the right upper pulmonary vein is completely unobstructed. Yeah. So in this view also, this is completely unobstructed getting into the left atrium. You can see the oxygen is still open, and there is not much of a shine to the final surface. But you can clearly see there is a left right shine across the oxygen. Can you make a hemodynamic? Okay. Yeah, as you can see, we have started the right upper pulmonary venous pressure was around 50 to 30 millimeter of mercury initially. Now also you can see there is 14 millimeter of mercury mean. The patient is in a stable hemodynamic in minus rhythm, the blood pressure mean of around 82 millimeter of mercury. The stain looks quite stable. There is no residual shine across the final nervous system. Though there is a oxygen ASD, which is open, and drainage of the pulmonary vena is completely unobstructed. Any comment or any suggestion?
No, nothing. I was, yeah, go ahead, Jenny.
Hi, just wondering, is there a way that you can get an LA pressure to confirm that that pulmonary vein is unobstructed? Just by angiogram, it's not convincing. Looks, narrow. So if we get a simultaneous LA and pulmonary vein, just to see if it's really non-obstructed. You have the secondum ASD, I guess.
Hello. Almost a similar comment. We are taking a pulmonary vein pressure as 14, but we don't know the LA pressure. Secondly, your echocardiogram, we are looking the pulmonary vein at a scale of 71. So if you can come down on the scale, put a cursor across the pulmonary vein, and maybe have a simultaneously pulmonary vein and LA pressure will drop.
So they want to know the LA pressures. So maybe, the thing is, that flow is very difficult to say whether there is any amount of endo leak along with secondum. I'm not so confident as you guys are that this is only secondum flow. It's very close to the stand, so I'm not sure. So we have a couple of things. You can do a pressure pullback from pulmonary vein into the LA by using a guide catheter over the same wire and see whether there is any gradient across the pulmonary vein so that you don't lose the axis. And the second thing, you may tell me this is only secondum, but I'm not so much convinced as you guys are that this is not an endo leak. What do you think, Martin or Joachim or Oliver or Mulyadi, what do you think about the flow?
Secundum.
Yes, Garrett.
Well, just in favor of what you just said, I think the pulmonary vein angiogram did show some flow into the left atrium, but it also seemed to be that the flow was going from the pulmonary vein into the right atrium, and it felt to me as if there was still, that was supporting endo leak, I suppose, because unless it's coming from the pulmonary vein into the left atrium, then coming through the secundum ASD, but I thought when they did the pulmonary vein injection, it looked like there was flow getting into the RA.
I think you guys will have to, maybe if you want, we can go off live and finish off a lecture or two because we are quite behind schedule. Is that okay for you? Yeah, you can record everything, tell us what you have done, and then we'll come back to you. Okay, guys. So can we go to the lectures? No more live cases? Is there a live case, guys? Okay, I think we'll move on to the next talk by Ahmad Chilebi on ASD closure in cyanotic congenital hearts. Ahmad, over to you.
Thanks, Bharat. Before starting, I would like to thank the organizing committee, especially Dr. Tin, for their kind invitation. It It is my great pleasure to be in Ho Chi Minh City again. I'm going to talk, no disclosure for this presentation. I'm going to talk on the rare conditions that we need to close the ASD in congenital heart disease classified under cyanotic groups, but the direction of the shunt through the ASD may be right to left shunt more commonly, maybe bidirectional, maybe left to right, determining by the type of specific cardiac defect treated or not treated, RA pressure, RV hypoplasia, RV and LV compliances, and the balances between them. Direction of the shunt determined by mainly pressure gradient between the atria in small restrictive defects, determined by RV volume and or compliance in large non-restrictive defects, and also prominent Eustachian valve and persistence KRD network may also lead to the preferential drainage of the IVC blood to the left atrium. Why we close the secondary ASDs in cyanotic congenital heart disease? First, to eliminate the hypoxia oxygen desaturation in rest or induced on exercise, to promote the RV development for providing biventricular or at least 1.5 ventricular circulation, to eliminate the RV volume overload in treated cyanotic congenital heart diseases when fenestrated or natural hold is no longer needed, and to prevent potential paradoxical thromboembolism. Transcatheter closure of the shunt at the atrial level may be beneficial in several congenital heart disease, may be classified under cyanotic. Pulmonary atresia with intact ventricular septum or critical PS with RV hypoplasia, abstains anomaly of the tricuspid valve, and the defect left untreated or done intentionally after surgical correction in TOF or TOF type pulmonary atresia or complex congenital heart disease reported as 1.5 ventricular circulation, and fenestration in Fontan circulation, platypnea autodeoxys syndrome, and right ventricular infarction. Fenestration will be talked in this session in another talk, and the other one occurred, so I'm going to talk on the first three. In pulmonary atresia with intact ventricular septum, even though of appropriate perforation and then pulmonary balloon valvuloplasty, cyanosis may persist. Interatrial communication usually persists, but the direction of the shunt varies according to the RV volume and compliance, mostly right to left at the beginning, but also bidirectional or even left to right shunt. The direction of the shunt at the atrial may change with the improvement in RV volume and compliance in time, becoming is not longer necessary. ASD morphology in pulmonary atresia with intact ventricular septum and critical pulmonary stenosis may be different from other interatrial septal defects. Interatrial communication usually looks like intrauterine PFO-like, but it may have multiple holes. Prominent Eustachian valve and KR network persistence are seen more commonly. Septal malalignment and floppy septum primum are not unusual. In clinical point of view, underestimation and deciding the size of the device and misplacement of the device onto the prominent Eustachian valve may occur. Consequently, all of these may cause device migration. These are from 4 different patients, pulmonary atresia with intact ventricular septum. How to close? What are the technical considerations? We always prefer to do test occlusion of the defect before going on the procedure when a special oxygen saturation at rest less than 87% and or RV hypoplasia and is present. Mean RA pressure shouldn't exceed during balloon occlusion testing more than 50 millimeter mercury. Systolic blood pressure shouldn't be decreased more than 20% of the initial values. When occurred, fenestration should be considered. Balloon occlusion test may not be performed if oxygen desaturation is mild or not present, since and the shunt direction completely left-right. Balloon sizing for device selection should be performed in especially complex defects. This is an example of 8-year-old female, pulmonary interventricular septum, status post-transcatheter pulmonary valve perforation and pulmonary balloon valvuloplasty. Mild to moderate PS underwent balloon dilation in the follow-up. As the predominant right to left shunt, oxygen saturation was about 87% at rest. You may see the completely right to left shunt, but small defects. We prefer balloon sizing in this kind of patients in all, and always we prefer bilateral femoral access for measuring RA pressure during oxygen testing or before releasing the device, and also femoral artery access to observe systemic blood pressure as well. In this case, saturation of oxygen increased from 88 to 95% after device closure, while the RA pressure didn't change. Another patient, in this particular patient, you see the, excuse me, you may see the very large defect, but the movies are not played now. Bidirectional shunt after balloon atrial septostomy due to low cardiac output in newborn period after pulmonary valve perforation and duct stenting in this particular patient. Very large defect with bidirectional shunt and moderate degree of RV hypoplasia was present, and again balloon sizing and then deciding on the balloon sizing measurement and then closure of with a device. 1 month after device closure in this particular patient, RV inflow increased, as you may see on these movies. Another patient, history of pulmonary balloon valvuloplasty in neonatal period due to critical pulmonary stenosis, no significant oxygen desaturation, complete the left to right shunt. We closed this defect for eliminating the right ventricular volume overload. And again, we did prior balloon oxygen testing as well. In this particular patient, there was a moderate RV hypoplasia with a tricuspid valve Z-score between the -2 to -4, near -4. So fenestrated, hand-made fenestrated ampracceptal occluder was implanted. You may see bidirectional flow through the devices. What about Epstein's anomaly of the tricuspid valve? Symptoms and clinical manifestations show wide variety in accordance with the severity of tricuspid valve involvement and TR and adrenalization of the RV. It is associated with interatrial communication in approximately about 80%. ASDs may be small, large, may cause right to left, left to right, or bidirectional shunt. Conventional treatment of Epstein abnormality in symptomatic patients is surgical, of course, repairing of the registration valve and closure of the concomitant interatrial communication. However, in those patients, mild to moderate TR and good RV volume without symptoms, interatrial communication may be closed with transcatheter route due to right to left shunt causing hypoxia at rest or on exercise for improving systemic oxygenation, or significant left to right shunt causing RV volume overload, which may worsen the regurgitation already present. In this particular patient, moderate to severe PR, but without no significant symptoms, and also the patient was, and family of the patient was rejected the surgery, and we decided to close the ASD with an 18mm occludec device, again with prior balloon occlusion testing. You may see the right atrium not enlarged, no bulging to the left side of the atrium, and no surgery at 3 years of follow-up until now without significant symptoms.
Ahmad, 1 more minute.
I would like to show these extreme cases. 11-year-old female dextrocardias inverse totalis and Epstein's anomaly of tricuspid valve and mild to moderate TR, large tunnel PFO causing a bidirectional shot with an oxygen saturation 90% at rest. Let me show you. bidirectional shunt. And in this particular patient, transseptal puncture with sensitive endoto was performed, and after dilation of the puncture, we inserted a long sheen, and then amphilaster cribriform multifunctional occluder was used to close the defects. Let me show the last patient. This is, excuse me, an Epstein abnormality of tricuspid valve, a completely left to right shunt, but mild degree of the tricuspid valve regurgitation. For eliminating of the left to right shunt and right ventricular volume overload with this huge 31 millimeter on color flow diameter, we close with right upper pulmonary vein technique together with balloonist technique using 34. As you may see, this is our institutional experience in 25 patients, which means that about 1% in all ASDs that we have closed more than 2,000 cases in 21 years. So, in summary, ASD closure in cyanotic congenital heart disease usually technically similar to ordinary secondary ASD closure, except preceding balloon occlusion test. However, the situation for the defect in pulmonary atresia with intact ventricular septum is somewhat different. They are usually complex, as showing malalignment of the anterior and posterior rims of the defect, and prominence of the osteochene valve care network persistence may interfere with device implantation, and sometimes mistakenly osteochene valve can be evaluated as the septum. We always do and rely on balloon sizing in patients with pulmonary atresia intact ventricular septum and prefer to the Minnesota maneuver for being sure the device is secure position in addition to the more careful echocardial affiliation before releasing the device. And transcatheter closure of the ASDs in cyanotic congenital heart is also safe and effective procedure in carefully selected patients, and it may improve both oxygen saturation and exercise capacity. Thanks for your attention.
Thanks, Ahmed, for that comprehensive overview of closing ASDs in this subset. Before we go on to the next talk, let's go to Calcutta for 5 minutes to see what they have done. Over to you, Amitava. Go ahead. Hello, guys. Can you hear us?
So what we have done is, we have taken an injection in the left upper pulmonary vein, and we have checked the pullback. Can you show the recording, please? On the hemodynamics of pleurovit, pleurovit, pleurovit. No, back, 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 no, back, back. Yeah, so we could enter into the left atrium from that ostium addisonum or ostium secundum ASD. And can you make the hemodynamics this one? Yeah. So there was actually no difference in LA and pulmonary venous. We'll just show you in a moment. We had to record it because we were not live that time. Just give us a couple of seconds. Yeah. Yeah, that's it. That's it. That's the one.
Okay, good. Looks impressive.
Yes, so this is the simultaneous tracing, and
Yeah.
we also with this maneuver ensure that we can easily enter the ostium secundum ASD for any future right upper pulmonary vein protection, if at all we go ahead and dilate the ASD stent. So it is about 8 millimeters now. Dr. Yes, Yes, yes. it's about 8 millimeters. And after that, can we go back to pleurovit? Pleurovit. Pleuro. Yeah. Next. So we took, as Dr. Dalvi suggested that there is a possibility of some endoleak. So we did some more injections. We did SBC injections. We did not suggest much. We did one or two more pulmonary venous injections. There may be a small amount of endoleak, which we probably also appreciate on echo. But at this point, I think we are happy with this result. We don't want to aggravate it any further, and our most whatever shunt we are seeing on echo is completely through the ostium secundum ASD.
No,
we have decided not to do anything more at this point, and maybe
We, we appreciate and we appreciate and we respect your decision. The only thing we were saying is that do a good angiogram in the pulmonary vein as a baseline. We are not wanting you to do anything further. Do a good angiogram for your own sake for the subsequent follow-ups. That's about it. Yeah, we respect your decision and for an excellent demonstration of this very complex case. Thank you very much. Okay, so we'll move on to the next talk, Martin. Yeah, that's on fenestrated ASD device, when and how. And Martin, if you can stick to time. I'm sorry to hurry you.
Thanks, Parrot. So I will try to get a little bit time back. Fenestrated ASD device, when and how. So when, that's a huge bunch of different issues. For example, the surgeon very often do a little pouch in the interatrial septum when they do a fallow repair with hypoplastic pulmonary arteries. And after this, sometimes we can close it. A little bit more complicated is the situation in borderline hypoplastic left ventricle when they put in an interatrial septum with a little hole to provoke left ventricular growth. So sometimes we have to enlarge it, sometimes we have to close it. And at least one of the most issues in this is the post-capillary pulmonary hypertension scenario. We already heard about this. Another thing is the creation of a right to left atrial shunt as an access for following interventions like pulmonary vein stenosis, or we heard today something with ablation procedures, so for the EP studies, or at least for pacer implantation. So how and which device? We can do it before umbrella implantation to get the umbrella or with a hole or whatever, punch it. We can do it during umbrella implantation at the same time and after umbrella implantation, but then I would wait at least 6 months when the umbrella is completely ingrown. So which device we can have? We do have fenestrated atrial septal defect occluder from the Occlutech company. And on the other hand, we have self-made occluders, or we can do self-made occluders with a surgical punch, for example, the Gore umbrella before implantation, and we can stenting during umbrella implantation or even later. Again, 6 months I would wait until the umbrellas are completely covered with endothelium. So this is the Occlutech atrial flow regulator. That it comes with 2 different diameters, 2 different hole sizes. So diameters in 21 millimeter and 23, with a diameter of the holes of 8 and 10 millimeter. So at least it's designed for adult patients, not for kids. On the other hand, in Germany it's quite expensive. So the price, it comes with 14,000 euro. So alternatively, you can do your own implantation with some holes inside. Here you see the preparation of a Gore device before implantation using a surgical punch. And you see we did 2 different holes, or 2 similar holes. And before we did the implantation, you will see later on those holes were occluded by itself after a couple of months, after 6 months. So maybe this method is not very good for long term. But at first stage after the implantation, you see nicely the defects inside the umbrella by the punch. And they will occlude after a couple of months. I will show it to you. The other thing what I like to do is to load an umbrella together with a coronary wire system. You see there's coronary wire inside the umbrella, so you have to stitch the umbrella from the left side with a needle and then go across with the coronary guide wire through the needle and then remove the needle. And this is the way how you can do a fenestration immediately after implantation of this umbrella. You see, just put in, for example, coronary stent system, and then you have a fenestration done during the intervention. So I just want to show this kit. This is the kit where we implanted the GOR device with the punched holes inside, and they closed. It was a 7-year-old girl with stone complex after gland takedown and biventricular repair and postcapillary PHT. You see the LA pressure was 19 in the middle, anti-diastolic pressure 16, and we decided together with the surgeon to implant this umbrella with fenestrations before, and the fenestration closed, and then again we discussed with the surgeon, and they said, well, we should do another cast and looking after the pressures and, if necessary, do next step intervention. And what you might see, there's already a transeptal needle close to the umbrella, and there's a little wire in the LA already. So I use a transeptal needle, and then I use the stiff end of any coronary wire system across this needle, so I have a very sharp, at least, needle to overcome very stiff structures like this umbrella. And here again, you see the wire on the left side is already pointing into the left atrium, and then followed by the needle and the dilator and the sheath. Now, afterwards, we implanted a formula stent system into the umbrella. So, and this is what we can show afterwards in the echo. This is still open. It was done, I think, at the end of last year. So the same principle as for creation of fontan fenestration, at least. We do quite a lot of fenestrations in the fontan scenario because of further interventions from EP people or because of failing fontan. But the principle is very similar. So we go across with the needle and the stiff end of the guide wire, of the coronary guide wire, and then implant the stent. That's the same principle. So in conclusion, there are many reasons or indications for the use of fenestrated ASD devices, particularly for patients with postcapillary PHT. Those devices might help to decompress the pulmonary system. Currently on the market is the atrial flow regulator, Occlutech, only 2 different sizes and expensive, and handmade devices can be used alternatively. Thank you.
Martin, one quick question. Since you have finished well in time, how good are these handmade fenestrations in terms of their durability? How good are these fenestrations, handmade fenestrations, in terms of its durability over a period of time?
Oh, that's difficult. So in some cases, for example, if you do this in a fontan patient for an EPU study, and many patients we close it afterwards with a device. And in other cases, we can just, if there's a stent inside, we can enlarge it a little bit more. But it's hard to, yeah, we can close it and then create a new defect. That's possible. Otherwise, it's not possible. But at the end, we can fiddle around with everything with the surgeon together, and maybe we can increase or decrease the shunt, as I tried to show.
Thank you. Okay, now we move on to the next talk on LV diastolic dysfunction and ASD closure. Over to you, Dietmar.
Can you change? Good afternoon. I hope I can convince you by my first slide, and if because of time, we can even stop here. So I want a little bit complete Martin's talk, and based on a reviewer's comment for my last publication, just published, Bold New Indication of Transcatheter Pulmonary Flow Restrictors, I think it was a lady. What does it mean, holistic treatment strategy? And this I want to answer with my talk. The goal is not to close a hole, but to treat the patient. That have to listen my co-workers 25 years. So based on this, I want to listen the history and consider pathophysiology. And I appreciate this publication. That was from Peter Ebert 25 years nearly ago. It was the most cited publication from him. And he considered, okay, I have ASD, normal, let me say, AV valve, waves, and so on. And then I close it, and what happens on the left side? And so it detected, and let me say, a restriction of the left ventricle. It's a great, you have to consider it every day if you are confronted with such a patient. You find only what you expect. That's the next message. So the ASD in elderly patient can be, but even after 12 years or 24 years, depending on the disposition, and left ventricular disease. And then maybe you can use, if you have large communication, you can reduce it. Martin have given you some of these ideas. I will not repeat it, but only shown by this patient, for example, considering the data from Peter Ebert. But I thought it could be happened. I closed the interatrial septum by the Amplatzer, but I didn't release it. And then I talked with a 54-year fantastic woman and asked her, so how you feel? The left ventricular end diastolic pressure increased immediately to 20-25. And then I told her, now I want to see if your heart is still a young heart or not. But you look so young that it have to be a young heart. So I waited 5 minutes, and then the left ventricular end diastolic pressure goes down, and then I released the device and mentioned to her, if you have in 5-10 years again symptoms, exercise intolerance by tennis playing or whatever, come back, maybe we have to create a restrictive ASD. So why is it? Because 50 years you have a compensation of the normal, the QS is what the set screw is for the physiology. And if you have relation of the right to the left side from 1 to 3, then you can consider lifelong minimum 9 liter went through the pulmonary system if you have a systemic cardiac index of 3 liter. And that can be changed over time, but the body reacts with the neurohumoral stimulation, and that over time is a cause for the restriction of the left ventricle. So ASD can force us or even be related to the diastolic heart failure, but even cause it, age and disposition depending. Ask yourself if you have a QP/QS of 4 or 5 to 1, or even you have a common atrium and you have maybe a bilateral or bidirectional shunt or 1-to-1 shunt. The normal data of the diastolic dysfunction are in context of a huge ASD not reliable, or even the diameter of the left atrium, what typical is for example, in PFO patients, but it is not considered. And the guidelines, looking for restrictive left ventricular function is not written. And what these three patients told me when I read it, that atrial fibrillation was developed in 7% of all these patients when the PFO was closed, and that you have to consider it even. So you can close an ASD or a PFO very easily, and meanwhile it is done, in particular in Germany, in any hospital, and nobody looking on the heart or the patient, and then the patient will have atrial fibrillation later on or a congestive heart failure. I want not to go in detail, but that was our letter to the editor, and we want to ask why it's not written in the guidelines that the patient, that the physicians have to look on the left ventricular function, in particular the diastolic one. And the other one is, it happens, I think, not only in Germany, that even such a heart, a right atrial dilatation, right ventricular dilatation, but is misinterpreted as an ASD because they have a hole. And this patient was in 3 different adult cardiologists. And then he came to the surgery department and it was closed. And the end, the patient was on ECMO. Because it was a primary pulmonary hypertension, in addition with an ASD, so then creation of a restrictive ASD could be weaned immediately and with pulmonary specific treatment. In other words, you have to find out a direct diagnosis. Martin mentioned the situation of the Schoen complex or for the borderline left ventricle. Yes, that can be a very huge atrial communication in context of a really restrictive or endocardiofibrotic left ventricle. So the implantation of an fenestrated occluder is indicated, but in this case it was not enough. It's ended not only in a surgical ASD with fenestration, but even with a pot shunt. So in other words, that's the final slide. Maybe to the failure of my holistic medicine, I asked SK2 my mon amour, and he mentioned no. So maybe you won't find what you don't know. Thank you very much for your attention. I hope it is a little bit message that we have to treat patients and not hold. Thank you very much.
Okay, thanks, Dietmar. I think we have to go on because we are a little bit out of time. So the next speaker is about borderline cases. Or is it last? No. About borderline case. Marsham from Malaysia. Hisham.
Right. Thank you. I would like to thank Tin and the team for the invitations to be part of this meeting. All right, so this is my disclosure slide. I may have some disclosure. My talk is probably some overlapping with Ahmed's talk. So literally, there is no such thing that the borderline ASD. So it's neither clearly large or small, but falls into an uncertain category in terms of clinical significance. And it might involve the factors like size of the defect, QPQS, and also symptoms. And the clinical decision-making for closing this type of ASD might be some ambiguity, and it remains controversial. And the indication of the closure in this group of patients might be due to right heart enlargement, pulmonary hypertension, symptomatic patients, and also systemic embolism risk. But in the developing countries, like in this region, and unexceptionally Malaysia, our own local barriers like geographical, economic, and financial supports for patients, human resource, and scarcities of high-end equipment in providing optimal medical care or follow-up for this group of patients might be a bit different as compared to the Western country. Right, so I think for the past 1.5 days, I think we learned about the advantage of device closure in borderline cases. and definitely better as compared to surgical candidates. And also the outcome of borderline ASD cases in short term can relieve the symptoms and reduce right heart strain, and also long-term result in terms of improvement of quality of life, stroke risk, and also lower incidence of arrhythmia. There is from the literature that illustrate the borderline ASD. It's at the borderline shunt size, borderline right ventricle, as mentioned by Ahmed, and also borderline PA pressure or restrictive LV with a borderline left ventricle and diastolic pressure. I will not touch on the number 3 and number 4 as described well by the previous speakers. So when we go through the borderline shunt, is mentioned about QPKS ratio of 1 to 1.5. So there is one nice paper by the Poland group which highlighted that the ASD closure in patients with borderline shunt resulted in significant long-term clinical and hemodynamic improvement after percutaneous closure. And there is a significant difference compared to before ASD closure and 12 months after ASD closure in terms of exercise capacity, VO2 max, quality of life, right atrial area, and also right ventricular area. All right, so this is just one case illustrated the necessity of closing the ASD in a 5-year-old patient with incidental finding of heart murmur. Echo showed a secundum ASD, nice rims, size at least about 12 millimeter. Right, so all the rims are looks quite adequate from the 4-chamber view and also from the short axis view, and there's a mild RV dilatation. Patient was otherwise asymptomatic. QPKS was 1.4, so we decided to close the ASD with Occlutech 15 millimeter. So another group of patients is basically the borderline right ventricle, as described by Ahmed previously, those with pulmonary atresia with intact ventricular septum, and a minority group of critical pulmonary stenosis patients. And the goal of treatment in this group of patients is basically to achieve normal oxygenation, normal RV pressure with releasing RV outflow obstructions, and also a normal functional status and CVP. And the target for the adequate RV size is basically to achieve the 2 ventricle circulation, or at least 1.5 ventricle circulation for those with bipartite right ventricle. And of course, in those with inadequate RV growth will probably require additional bidirectional gland shunt surgery or RV overhaul surgery. And in our institution, the RV overhaul surgery was introduced for the past 12 years. And of course, not uncommon to have residual cyanosis. And this, if the RV can already achieve 1.5 ventricle at least, then final step is basically to close the ASD. And in less common indication is basically when there is frank left to right shunt, as usual ASD physiology, then ASD is closed transcatheter or surgical closure in a large ASD defect. So the indication is basically when there is a residual right to left shunt in patient with restrictive RV physiology as a most common indication when they have achieved biventricle circulation, and of course when there is no improvement in terms of RV size, and usually this is achieved when the age is about 7 to 8 years old. So if there is significant left to right shunt, and also when the patient achieves biventricular circulation, and again the ASD is also closed, and not uncommonly to have a severe cyanosis after RV overhaul surgery. So there's a nice paper illustrated the post PIVS ASD closure in this group of patients. And one of the paper is basically from the Dr. Lee Benson group, which concluded that transcatheter closure in children with hypoplastic right ventricle is usually well tolerated, safe, and effective. And from the 17 patients they have illustrated, 9 of patients is basically from pulmonary atresia intact ventricular septum group, and 6 in Epstein anomaly, and 2 patients with isolated right ventricle hyperplasia. And it's good to see the significant difference as compared to prior to occlusion in terms of right ventricular length and also the Z-score of the right ventricle length. So this is the prior to ASD closure and after ASD closure, which showed nice improvement in terms of Z-score of RV length. So this is our own data, which for the past 20 years, we have about 14 patients who require ASD device closure, and most of patients has achieved 2 ventricle physiology, and only 3 patients who had 1.5 ventricle physiology, and 2 patients basically due to RV overload when there is a significant ASD shunt, and 2 of our patients require early intervention post-RV overhaul surgery with due to severe cyanosis. And from the 14 patients who require transcatheter ASD device closure, 2 patients had transhepatic approach due to block both femoral veins, and we have 2 device embolization. One is due to a malaligned septum, and another one as a device sizing issue and was retrieved and reimplanted. All right, so just a simple example of a patient who has achieved 2 ventricle circulation. This is the initial RV angiogram, and quite typically require RF valvotomy and balloon dilatations and plus minus PDA stenting. And 12 years later, this patient has improved the RV cavity, especially the apical part, and regression of the apical muscular component. This patient's saturation was 92%, and so the SD was closed, and this patient has achieved a nice 2 ventricle circulation. All right, so this is another patient with 1.5 ventricle circulations. This is the initial angiogram in the neonatal age, which showed relatively small right ventricle with presence of sinusoid, and this patient had balloon dilatations of a pulmonary valve and also PDA stenting, and we have noticed that sinusoid has disappeared, but the catheter study at 18 months old has shown severe RVOT obstruction with sinusoid has reappeared. And this patient has RV overhaul surgery 4 months later and PDA stent division. And we have seen that the RV has grown appropriately, with no RVOT, residual RVOT stenosis and no sinusoid, but patients unable to maintain saturations. So what was done is basically this patient has a gland shunt surgery plus atrial septal defect closure. So the follow-up has shown that the RV has grown nicely from a very small bipartite right ventricle to a very nice 1.5 ventricle circulation after 22 months. So in summary, the ASD closure in the borderline right ventricle is basically indicated when there is a mild cyanosis or large ASD who left and to right shunt, and also if there is a significant severe cyanosis after RVOT enlargement or RV overhaul surgery. And of course, this group of patients will require a progressive and also follow-up to make sure there is no further RV enlargement and also early onset of atrial arrhythmias. So the key takeaway for today's talk is basically borderline ASD require careful assessment of hemodynamic and symptoms, and device closure is a safe and effective option for selected borderline cases, and early intervention can prevent long-term complication like arrhythmia or stroke in the borderline cases. And of course, the closure of ASD in borderline right ventricle, particularly in patients with pulmonary atresia interventricular septum, requires precise assessment and decision making. So with that, I thank you.
Thank you, Marsham. Nice talk. Just a comment from me, we use PFO occlusion system in this situation. But anyway, we have to go to the last talk, and it's funny enough, fenestration closure in Fontaine situation by Hideshi Tomita from Japan. Go ahead.
Yeah. It is my pleasure to have such an opportunity to give this talk. My topic today is transcaster Fontaine fenestration closure. This is my disclosure. Staged approach to single ventricle physiology is a common treatment strategy, while various therapeutic catheterization may be required for each stages. Transcaster closure, fenestration closure may be considered following Fontaine completion. Close or not to close the fenestration is a balance between Fontaine pressure and subsequent risk of PLE, plastic bronchitis, and liver damage, and the advantage and disadvantage of right to left shunt. As shown in this slide, there has been a lot of debates to close or not to close fenestration. Left side favors fenestration, while right side favors non-fenestration. This slide shows a simulation of the saturation, systemic oxygen availability, and systemic venous pressure based on underlying hemodynamics. In high RP, oxygen availability for a small fenestration may remain relatively constant until critical size will be reached, on which point it dropped very, very quickly. Delay et al. Reported in 2022, fenestration does not impact survival or risk of Fontaine failure, while it is associated with increased risk of thromboembolic events. DIP also reported in 2024, no significant association was identified between an open fenestration in Fontaine baffle and major advanced events. However, so far, no large-scale randomized controlled long-term study exists. In AHA guideline 2011, transcaster fenestration closure is class 2 recommendation if saturation less than 90% and test occlusion for 10 minutes, Fontaine pressure less than 16-18, increase in Fontaine pressure less than 2 to 5 millimeter mercury, increase in AVO2 difference less than 33%, reduction in systemic venous saturation less than 10%, systemic venous saturation over 40%. Fenestration may be created as a punched out hole or connecting by the graft between condy and atrium. A variety of devices have appeared in the literature on transcaster fenestration closure. However, Plaster septal occluder is only one device which is approved for fontan fenestration closure by FDA. No device has been officially approved for this procedure in Japan. This is a case of EPTFE2 fenestration, which was closed using 052 big coil. This is a case of 4 mm punched out fenestration, which was closed flipper PDA coil, where two loops of the coil were exposed in the systemic atrium, and the rest of the coil was delivered in the county. This is a case of 4 mm punched out fenestration, which was closed using AVP1. Also, 4 mm punched out fenestration in the 18 mm EPTFE tube, which is closed using 6 mm unplugged septal occluder. This is a case of 4 mm punched out fenestration in the 16 mm EPTFE tube, which was closed using 4 mm unplugged septal occluder. Picker reported in 2007 that most commonly used unplugged septal occluder was 5 mm. This is also a 4 mm punched out fenestration in the 16 mm EPTFE tube, which was closed using 6 mm figure flex 2. 4 and 5 mm figure flex 2 are not available in Japan, where smaller LA and RA disc, as well as its softness, may be more conformable to the conduit. This report shows the closure using covered CP stent. This may be particularly useful when complicated by condyle stenosis. This slide shows annual number of fontan variation and transcaster fenestration closure in Japan from annual report from Japanese Society of Thoracic Surgery, as well as from the Japan Congenital Interventional Cardio Registry. Approximately 400 cases fontan fenestration have been performed in Japan, while quite small number of fenestration closure has been reported. However, success rate of fenestration closure in our registry from 2012 to 2019 was 54 cases out of 55 cases in such a limited availability of the device. No systemic acute complication has been reported. However, data of long-term outcome is not available at this moment. This report shows that 51 cases is Plaster septal occluder 43, Goa helix 7, and Goa cardioform 1. And geographic technique at the end of procedure is 36%. Transcaster fontan fenestration closure leads to sustained increase in systemic venous and low incidence of adverse outcomes such as death and transplant. In conclusion, still there remain debate on to close or not to close fontan fenestration, particularly when saturation is over 90%. However, being symptomatic complicated by hypoxia, transcaster fontan fenestration closure is generally recommended when the fontan pressure is acceptable. Clinical decision-making should be more individualized when considering use of fenestration and subsequently fenestration closure. Although off-label, various devices have been used for this procedure. Thank you for your attention.
Thanks, Ndishi. I think there's a lot of stuff to discuss, but we will do this during the short coffee break. And then I will hand over to Shakureshi, and we finish this part of the day. Thank you very much.
Okay, ladies and gentlemen, if you can take your seats and we'll start the session very shortly. And I want to welcome Rohit, who's over here, Edwin, I can't see anywhere, Neeraj, and Chao Viet Tong, I haven't seen, and Porntep. I don't know if he's here, in which case he'll have to. We're going live, first of all, to Tin, I think, and I don't know who else. Tin, can you hear us?
Yeah, I can hear you. Meantime, what I want to make team from Spain and from Durham Hospital and we from my center. I review the last week. Team.
Would like to do a start. I would like to invite the team fellow to present the history. So good afternoon, everyone. For our next case, we have a 15-year-old male, weight of 44 kilograms, presenting with dyspnea in person. On physical examination, he had a grade 2 over systolic murmur at certain intervals prostate on the left upper parathermal corridor with notable fixed episode. On transthoracic echo, on four-chamber view and cross-axis, there was no sapatocundum ASD measuring 13 or 19 millimeters with an atrial central length of 44 millimeters with note of RAV and RV. On right atrial view, also in the previous views, the rings were noted to be sufficient. For the discussion, what device would you prefer to use and what size? Thank you.
Oh, Tin, I'm staggered. I was thinking there would be a coronary fistula. You left me speechless, so carry on now, yeah.
Okay, so well, the echo, we have quite a large ASD and comparatively speaking, the majority of we've got a good pulmonary venous ring here and not much of an aortic ring, measuring in this dimension about 16 millimeters maximally. As we move around to the short axis, we can see that we've got no aortic ring to speak of, however, we do have a good posterior ring in this projection. Again, this is measuring around 15 millimeters in the maximum dimension. However, as we go around more inferiorly, we do begin to lose a bit of perception. So infraposteriorly, the section is a little thinner and it's a little harder to visualize. And the measurements get a bit larger. We're getting about 18 millimeters per edge here. The defect doesn't really sit in the bicameral view. It's more of an anterior defect towards the aorta. And as you roll away, you begin to lose perception. So there is a little portion of the inferior section which is not there really. And we can see this in multiple views. And I think in fact it's quite difficult to measure in that view because the section goes off the screen there. We did do balloon measurements, I think, and the maximum we got on the balloon was 24 and a half millimeters. So quite a generous defect in the end with that slightly questionable inferior margin. But I think that's most pertinent news from the echo.
Okay, Sal, thank you. All right. Any suggestions, Rohit, very quickly, brief ones? Use the microphone next to you.
Why do you do balloon sizing? I mean, it appears fairly decent on T.
And what size would you use if you would from the images?
For images, it's maybe about 22.
22.
Maximum was 18.
Yeah. Okay. Neeraj?
Yeah, so what balloon was used actually for sizing? Was it a compliant balloon or a usual sizing balloon?
It'll be a sizing balloon, I think.
I'll go with the eco images actually.
Yeah.
As of now, I'll go with the eco images, not with the balloon size.
Okay.
This 24, I'll go with the size of the balloon.
Okay, so Tin or Ming Tai, tell us how far you've got. We can see TOE images with something across the left atrium.
Balloon sizing, the result showed the width is 23.5 millimeters. However, the simultaneous TE recording showed
So you picked a 27 device, yes?
Yes.
The balloon on the fluoro is 21. So
We have another measurement that is 23.
the Ponte.
I think for me, I think there is a waste on the balloon already. I think 27 for me. I think it may be too big.
So what device would you be using?
Okay, I'm not familiar with acoustic, but I'm not sure about 23, 24.
Okay. All right. So 27s, you wouldn't? No. Okay. All right. So 23 or 24, depending on which company devices are available.
Another reason we want to pick up a little bit bigger device is because of the diffusion of X-ray field.
Mm.
So we want to use a little bit bigger device to make sure we can finish the procedure.
Okay. So what have you decided then? 27?
Yeah.
Okay. Let's see.
Now, at this moment, we already advanced the delivery speed, which is 11 frames delivery speed at the left atrium, like the fluoroscopy demonstration.
Okay.
Okay, actually we already finished the assembly of the device, and now is advanced the device. So, I will push out the LAD.
So which device are you using? Occlutech 27. Just to be clear, yeah. Okay. So at 90 degrees to the defect. Yeah, so that's still at an angle, isn't it? I mean, would you rotate it towards the roof of the left atrium now? In order to make, yeah, oh, yeah. It looks what? Mhm.
Okay, so it's nice and played around the aorta. You've got good tissue capture at posterior. Let's just check on that bicaval area, because that was where we were a bit concerned. The aorta look good. Just coming across very
You've got septum there, yeah.
There looks like there's a little bit of septum there.
Yeah. And can you show us the aorta, sort of short axis view? You briefly showed it, but
Too quick for you guys. There you go.
no, we can't see any echo now. Okay, now we can see it. Okay, so what do you think of that? It's nicely splayed. Any compression on the aorta? Doesn't look like it to me.
No, not really.
Okay. So it doesn't look oversized. Are you able to measure the waist? And the other view? And also, if you could measure the waist on the fluoro as well, if possible. Yeah. Okay. Yeah. Anybody, any comments from the audience? Anybody? Looks quite good to me. All right. So, Ming Tai, are you going to let it go now, or? Yeah. Okay. Yeah. Yeah, that looks all right. Okay. So, Pontep, are you happy with that?
Yes, I think anyway it look okay. I think.
Okay,
just,
Rohit.
detach.
Happy, Neeraj? Happy. Okay. So, are you going to say, anybody going to say this is oversized? Because you were all suggesting 22 to 24. It doesn't look oversized, or not too much. No. All right. So, ready to release then, I would have thought. And fluoro, if it shows. Fluoro big. No, it's released anyway. Yeah. Yeah. Oh. Yeah. Yeah. It doesn't look oversized too much now, so that's fine. Yeah. Yeah. Okay. Tin, any comments from you before we move away from you?
Really nice. Starting we intend to use a smaller one, but based on echo, south north, there are some problem with IBC ring, deficiency, and we changed our mind. We use the oversized device 27.
Okay.
But finally, it looks okay. I think.
Yeah, so Tin, hold on. You sounded cheerful. I've got somebody miserable on the microphone. So Joachim.
It doesn't look like a 27 device. It's incredible. The waist measures 22, and the device still is not compressed.
Yeah. So what are you unhappy about?
No, I'm just surprised that it's not. It doesn't look like a 27.
No. There's going to be a bit of compression, isn't there, I guess? Yeah. All right. Tin, excellent. Thank you very much for a very quick case. I was expecting a coronary fistula because that's all we seem to have been doing today. So, all right. Well done. A big hand for Tin and his team. Okay, so we're going to go for first talk, which is, remember, this is a session on different devices. So Warrican, old friend, how flexible is really flexible?
Thank you, Shaq. So I'm grateful to be here. Thanks, Tin and the team allow me to be here in his 11th kind of meeting. So I remember the first time that I'm here, probably in 2013. So long time ago. So lovely to be here once again. So Tin gave me a question which is quite challenging for me to, to reply. But I would say that I would add like how flexible of the cable, so to make it quick within 8 minutes. So here's my disclosure. And here I would like to acknowledge Tae Yong Choi, Dr. Ko from Zedang, so he saved me. I'll show you later on why. And Supa from Hadjai and CC and my team at Queen Sirikit National Institute of Child Health to make this slide happen. So what do we have for flexible cable? I think you see at least two of them. So this one is the Ampasser one with the terrestrial cable. And the middle one is obviously, you just saw that the Occlutech one. And last but not least, the Seroflex, which have very sleek of the thread that hook the device together with the cable. So just to share some thoughts on this, I think all of you experiencing this kind of thing previously, but just to for the newbies, probably just to share that for the ASD device, I mean Ampasser one, you can appreciate that the regular cable is somehow quite stiff all the way through from the tip until the proximal part. So it may not give you a proper alignment. But with the bioptome type delivery system, something like, sorry, how can I go back? Okay, right. Like this one, the Occlutech, you can appreciate, like you saw that previously too, that in terms of the deployment, you probably need to be a little, slowing down a bit, and then it's likely to swing back quite nicely because of that elasticity is quite more compared to the Ampasser. But again, it's easier said than done. If you don't feel it yourself, you cannot completely say it. And this is what I like to thank Ko, because in Thailand we don't have the Seroflex device as yet for somehow. So I don't have any experience on using the Seroflex device. But as you can see here, that it looks like when you try to pull it back until it's touching partly to the septum, and then you just let the device flow to switch sandwiching the septum quite nicely too. And this is how also the trivial things could help. I would like to share this. I think we did that in live cases a few years back. And again, the recoil of the device is actually not much compared to the Occlutech and the Seroflex. But again, with the use of the cable to pushing the device coaxially aligned, because the tip of the cable is quite very flexible, especially for the very first few millimeters there. So with that, you can also appreciate that how does it behave, and quite a good way to manipulating the device in between the septum. And this is how it looks. Of course, if you see the angulation like that, it's likely to be the Occlutech, because you can see that the bioptome type device cable connection is allows the angulation quite nicely. But it's even more for the Seroflex, because it's almost no resistance at all. But for the Ampasser one, you can appreciate that it's not because of the because it's screw mechanism, so it's likely that it won't just angulate it by itself, but it's angulate because of the flexibility of the cable. So here's how it appeared before we release the device. You can appreciate there, if we have like a conventional screw type delivery system, it looks as if the right atrial disc somehow going to flare, and it may not completely align to the septal plane properly. But with the trivial thing, you can see that it more aligned, and this is quite similar to what you can appreciate from the fibrillar Flex device, and thanks for Core also. She just gave me the clip this morning. Yeah, so it looks also nice setting of the device in relation to the septal plane. And here's how when you release. I'll start one by one. You can see here with the screw thing, you need to unscrew it, right? And sometimes with a very flexible tip, you may not be able to just release it quite easily. I'm sorry for the clip, which is not completely recorded, but eventually it flipped out and the device is in the same position. And this is a ficular flex. Once again, because it's ball and socket type, so it's easier for you to release to. I'm sorry also that it's not completely released from what you can see this clip. Anyway, and again, you can see that all of these, when you release, most of the time it won't change much in terms of the geometry and also the angulation of the device in relation to the septum. Right, and here's what I can show you guys will be like comparison things between each of these device. And as to make a story short, either M-plus septal occluder, ficular flex, or M-plus occluder to the cerebral flex, or the this recently published, not recently, but in 2022, from IJN group, they compare the M-plus the ficular and also the cerebral flex. So in terms of success rates, not much different. Residual shunt also no significant, and complication either in early or late is quite similar. Well, there's a note that ficular septal occluder require larger sheets and cerebral flex somehow in some part of the world less cost. Less fluoroscopy time in ficular flex with the SUPAS publication. And from IJN, looks like M-plus has taking long procedure time. And here's my personal experience. If we have time, I think we should discuss on that. But just to share some thoughts that in terms of the softness, looks as if the cerebral flex is probably the softest one that I feel. Deployment mechanism depends on what you have. I don't have experience on Sarah, so I cannot comment on that. But Occlutech, also give a good way of the recoil. But if you want to play around with the cable, the Trisio thing is quite helpful. Device position assessment, of course, I think 3 of them are very, very best. Releasing mechanism, probably the Occlutech is much easier. Trevisio somehow it's quite challenging because it's not completely detached and it may jump quite quickly. The outcomes, as I showed you, no significant. So I would like to conclude from my talk that, how flexible is really flexible. I would like to say that depends on do you really need a flexible cable or not. If yes, which is likely to be yes for me, especially when I have difficulties on deployment, so I'll try to facilitate things using this kind of cable, and at least it gives me the confidence for the final position before I completely release it. So I stop here. Thank you.
Warwick, thank you very much indeed. That's excellent. Right, any questions or comments for flexibility side of it?
Jack, I would like to ask somebody who used the cerebral flex because I have no idea. So please, if you can share.
Who in the audience? Who's used the cerebral flex?
Yeah, Mario, please.
Mario.
Yes, I've been using cerebral flex. I must say very happy about that. I mean, the final position is exactly the same when the device is still attached because it is not attached to a cable. There is just a suture that is keeping the device attached. So when you release it, well, it's exactly the same, not a millimeter of change.
And whilst you're there, Mario, stay at the microphone. How important is for you having that flexibility where the device does not move on release?
Well, maybe not that much. With the older cable or the unplatzer, when you release it, that it jumps, that's a nice thrill for the procedure.
So you prefer a jumping device rather than
Yeah,
a still.
not that much.
Any other comments? Oliver, you've used a variety of devices. Is it relevant, the flexibility? Is it important?
Well, I think it's nice, but I think it's most important to use the device you're comfortable with, which device you know how it behaves. And I mostly use the Amplatzer device, and even before the Treviso cable, obviously, and so on. And it's use whatever you're comfortable with and what you know how it behaves, also in difficult situations.
Yeah. Any other points? Niraj, use the microphone there.
Few Seraflex devices, and I think it's a beautiful mechanism. Once you relieve, you don't get to have the kick of that release, which was scary at times. The only thing is the profile is slightly bigger for all these Seraflex devices. They tend to come in bigger, around 12 French is the usual, as compared to Emplatzer, which I can go for a lower profile. The profile of the devices becomes more with the Seraflex.
Okay, so it's really a matter of preference, isn't it? Is whatever is fashionable or whatever fashion you like.
Jack, how about yourself?
I've used all three.
Okay.
I'm comfortable with all of them. I'm comfortable, like Mario said, with a jump.
Okay.
And I'm comfortable with no jump.
So do you really need that kind of flexible cable or system?
I personally don't think so, but
okay.
Yeah, again, it's...
All right.
You need to be yourself flexible. You need to be yourself flexible to use any of the devices.
Yes. All right, Warkan, thank you very much indeed.
Thank you.
So is Masood here, or he's probably in the other room? All right, we'll come back to Masood's talk later on when he comes over. So Hasri, are you here? Hasri Samian? Oh, Hasri, yeah. Hasri is going to deal with how safe is really safe. So could you find Dr. Samion's slides and put those up? Because I can see Masood Sadiq's slides here on our screen. So it's the next talk, his slides.
Okay, thank you, Sheikh. Not this one, not this one.
That's not the one. Any luck? Otherwise, we could move to the next and then come back. That will really cause chaos, wouldn't it? Otherwise, tell me whose slides you can find, and we'll find a speaker. Do you have Oliver Stumper's talk? Oliver, if you make your way up. Right, Cobra deformity, device or deployment.
Good afternoon, all. It's getting quite late. I tried to compress this to make up for some time. So transcatheter closure of ASDs with nitinol memory-shaped devices introduced some 30 years ago, established techniques, gold standards, and really the original Amplatzer design was adopted, modified by many companies, as we have seen throughout the conference. Probably more than 90% of all cath ASD closures use nitinol devices. Unusual configuration of one disc of the nitinol septo-occluder is well known to us all. Most common deformity is so-called cobra of one side of the disc, most often the left atrial disc. An incidence probably was higher in the early days and with larger devices. Reasons are not fully understood. Other deformities are also known and well described with all the various devices. And really, most of the time, the cobra deformity exhibit significant torsion of the wires at the level of the device waist, and thus failure of the wire mesh of one or of both discs to reshape properly once they're deployed. And this obviously has led to discussions as to whether this abnormal configuration could be related to the device design or nitinol wire thickness. And then it's really important that Siva Kumar in Chennai really presented data from 450 consecutive cases, randomized into 3 groups, using either the Amplatzer septo-occluder or the Figula or the Seraflex device. And cobra deformations were noted in all 3 of them, and there was no significant difference between the 2 devices. But I think it's a beautiful study, 450 patients randomized to 3 devices. Other factors to be considered to cause cobra deformity is if you use an angulated or kinked sheath. If the delivery sheath is too large, there's a potential for pushing the device off center during delivery. Or if the sheath is too small, a potential for too much friction during delivery, and deploying the left atrial disc in either the right or left pulmonary veins or left atrial appendage. And we certainly have seen a couple of cases during the conference with pulmonary vein deployment. And the risk of pulmonary vein deployment is really to rotate the device during deployment, thus enabling to twist the wires at the waist. If it happens, and believe me, it will happen, you just retrieve the device and redeploy in a different way, reduce the tension on the delivery cable, reshape the device, or if that doesn't help, you take the device out, reshape ex vivo, clean the device, and retry again. Anything really. And if no success, you should use a new device. In the old days, certainly the company, or the Amplatzer company, was really quite liberal in replacing devices which we on clinical grounds discarded also from cobra deformity. I think that has become more difficult in recent years. And again, Siva Kumar, with their great experience, 6-year period, 950 devices implanted, they noted that there was device deformity in 12%. However, they were self-correcting in about 40% of the cases. And they only needed ex vivo reformation of the device in 19 cases, and 4 times they needed new device, which is 0.5% of all implants. And again, there was no difference between the various manufacturers or even with regards to device size. Again, univariate analysis showed that there was relationship to oversized or king cheese deployment technique and device twist. So in conclusion, cobra or similar deformities can occur with all nitinol occluder devices. These are memory-shaped abnormalities, and if they occur, various maneuvers can be used to rectify them. And as I said, if that doesn't help, take the device out, reshape, ex vivo, and reload, retry. If no success, use new device, and I hope that all the companies still commit to replacement free of charge. Thank you.
Thank you very much, Oliver. Very good. Any questions or comments for Oliver? Anybody? Because pretty much all the devices, not just the three that you've reported, they all have this issue.
Yeah, and no significant difference in a huge number of cases.
Yeah. Yeah. Okay. Any questions, or otherwise we'll keep moving? If not, thank you. Yeah, go on, Rohit.
Is there
microphone nearer?
Take out,
Rohit, microphone near.
Whenever cobra deformity happens, I normally take out the device and realign and then reshape it and deploy it. Is there any way we can reconfirm the device without taking out?
Sorry. The acoustics are really...
So in order to get rid of the cobra, you're saying you take it out and reshape it and put it back in. Any other method inside the heart without removing it where you can get rid of it? The answer is no, isn't it?
Well, inside the heart, you first retrieve the device fully in the sheath and redeploy probably in a different fashion and so forth. And most of the cobra deformities, even if you just push and pull the cable, quite often they spring back in shape.
Yeah.
But
Okay.
you have to see.
Yeah. Okay, Oliver, thank you. We'll move on. Right. Have we found, yeah, we found Hasri's slides by looks of it. Hasri, where are you? Now Hasri has disappeared. Oh, there he is. Hasri is a bit tired now. He's walking very slowly. So how safe is really safe?
Thank you. I think this is quite relevant topic to share with. Then the issue of safety normally first being highlighted is in comparison to existing device. Yeah. So I think safety review has been perhaps many years ago, because transcatheter ASD closure is actually something new as compared to conventional surgical closure. So we need to compare those with the conventional established procedure that have been there for many, many years with high safety, minimal complications, and so on. I think the first few things that they compare early 2000s in the US is the safety comparison with conventional surgery. Back then, the unplugged septal occluder is one of the devices that's easily available, and also the helic septal occluder. These two things has been scrutinized. And 2000s, what, for 29 centers for unplugged septal occluder, looking to as compared to the surgical group, 442 device versus 154 surgery. For pivotal study of helix, this is non-self-centering device in 14 centers, 119 patients for device, and 128 surgical group. We can see that the overall complication in terms of safety, the device has much lower complications as compared to surgical group. Though both has no mortality, as mentioned just now, surgery has been there for many years and without mortality. Another thing that need to look into the major adverse event rate device group is 1.6% as compared to surgical group 5.2%. Similarly to the helix device, the major event rate of 5.9% and surgical group almost double of that. So I think this is the landmark any new device being introduced, we need to look into safety profile and so on. But further to that, I think this is very important information that we need to share for all of us, the young one, those the earlier one. You may understand why this is very important issue about the perforation, device embolizations, and other complications. It's more manufacturer and user facility device experience being compiled and looked at. And I think the most important safety issues concerned back then was the perforations. Yeah, device embolization is one thing, but I think that is easily retrievable, though some of them are not easily taken out in the cath lab and may require surgical closure. But cardiac perforations concern is actually is only less than I think quarter that happened during that particular hospital stay for procedures. And most of them they can occur later, up to 3 years post implantation. I think Zahid, I mean, as highlighted on this many years ago, we got the erosion issues and the possible consequences and the risk to patient. Though the total numbers is not that huge, not that large, but the symptom may occur much later once patient has been discharged, and pre-report end up with death. Yeah, so perhaps this is very important concern. The key issue is perhaps the device, the first generation, is more stiff metals and the sizing technique with the oversize and so on. The assessment prior to implantation is the area that been looked at back then. So one of the possible factors, either one or in combination, may cause the perforations mainly at the superior aorta to roof of either left atrium or right atriums. Yeah. The following assessment of the second atrial septal defect, the majority, well, had some kind of absence aortic rim, whether this is the concern or otherwise, and whether you use the larger device for the defect size by the previously sizing technique, which is overstretched balloon diameter, we tend to be more overstretch it and tend to use large device. And also the morphology of the defect, whether this is so floppy, oval shape, location of the defect, whether it's more closer to superior, anterior area or posterior and so on. I think mainly though the high risk is more superior area, where absent of that and the sharpness of either left disc or the right disc may erode the roof of left or right atrium when the heart is beating, so may potentially cause some kind of erosions. Then about 10% also of ASD tend to have a mild alignment of septum. So once the device is being in place, it does not normally position to rapid aorta, but it's more slanting. And the absence of anterior superior rim plus mild alignment of septum and oversized defect, or oversized the device used may worsen the consequences of safety profile on this. So this is, I think, just run through. So the evidence that shown the area where the perforation happened, yeah. And also the assessment of transesophageal echo with regard to the mild alignment of septum, potential risk, and safety issues on that, yeah. Well, though the commonest, but I think this is less risk if it happened, which is device embolization. One of the key safety profile that we need to look at it. If we undersize using a smaller device for that particular defect size, especially those that has absence or minimal rim posterior inferior area, they may main reason to embolize. Other thing is technical issues and appropriate positioning of the device. Sometimes inappropriate, unnecessary wiggling or tension, trying to make sure whether the device is stable or not. If the device is not in good position, may tend to slip through and also potentially may cause. But that is also good, trying to test whether the stability of the device prior to complete deployment. The risk of embolization is very minimal, less than 0.5%. As I mentioned just now, generally able to be retrieved in the cath lab itself, but some require surgical intervention. That decision to retrieve in the lab or surgery depends on the facilities and the operator, and also reassessment of that particular defect, whether we can, the reason of embolization is because of inappropriate sizing, so that we can change the device to be more appropriate device use, or because of new findings, for example, unnoticed absence, significant absence of posterior inferior rim that cause embolization.
Actually, we'll have to speed you up a bit because we've got 2 live cases apparently.
All right.
And we've got gala dinner.
Okay, sure. Okay, I just go through. The question now is that currently available device, whether all this safety profile can be minimized and improved. Yeah? So this has been shown by the earlier speaker. Can have majority of non-self-centering to become a self-centering, reverse helix to become the new central device here. Then the latest like Occlutech tend to be said to be more softer. The Gore definitely has soft and does not cause risk of perforations, but limited by sizing back then. But now we have a bigger device size for a bigger defect. Cocoons tend to be a more soft, slim, and so on. That is for the device. On the other part is the assessment of the defect. Once that safety issue arises, we need to reassess the defect by careful examinations by TE and so on. I think pre-procedure evaluation is more important than doing procedure itself. So I think looking carefully, estimate the size, the fluffiness, rim, thickness, proximity, and so on. You need to be very clear pictures by the TE. If not so clear, you need to do 3D images prior to decision to deploy or implant the device. I think this is very, very important. Sizing technique and also case device selection, especially fluffy septum and large defect has been mentioned before. So in summary, the critical step in ASD device closure lies before the procedure itself. In case selection, defect assessment, device selections, and intra-procedure technique play a bigger role. Large defect may need to have some kind of balloon assist technique so that you can get a better first time in proper positions. Try to avoid unnecessary oversizing, unnecessary reassessment before complete release of the cable. Then post-procedure follow-up is also crucial to make sure safety is actually kept in check. Thank you very much.
Thank you very much, Hasri. We haven't got time really for questions. You can ask Hasri questions later on because Tin's ready to go live, and we've got 2 live cases and 3 talks to get through before the dinner. Okay, Tin, can you hear us? Hello, Tin, can you hear us? Not sure if you can hear us. Good evening, Tin. Can you hear us? I don't think they can hear us. Right. So are we connected to Tin Center or Narayana? Well, now we can hear you.
Okay, good. That's true. That's true. So I just clear just concentrate the funeral vein actually. So accepting fellow will introduce this case. Next slide, picture.
So is somebody going to tell us about the case?
Yes, the substance fellow is preparing the sensation. So this patient 8 kilogram Down syndrome with large second ASD with hypertension. So now ready to present soon.
So, Tin, where are you?
He is outside.
He's outside. Okay.
Overnight.
We can't hear whoever's going to present. No, we can't hear you. Okay.
Otherwise unremarkable. And so X-ray with cardiomegaly and EKG with a slide ventricle. You can see here right atrium, right ventricular dilation with normal function, and you can see that there is flow coming across from left atrium to right atrium. Looks like outcome of secondary ASD. You see the measurement there. And millimeter dimension of the fluid. Good SCC urine.
Okay.
That is the case, a small baby with pulmonary hypertension, ASD at least 6 labs, and now I will show you the echo live now.
Yeah. So what's the weight of the baby? Remind us.
Yeah, 8 kg.
8 kg. And what's the pulmonary artery pressure?
Pulmonary artery pressure, we just measure 40 to 45, 45, 20, 34.
Okay. Compared with systemic of?
Systemic pressure about 100 and 170.
Okay. All right. So we can see the TOE at the moment. So what are you planning to do? TOE quick. fairly strong rims all around. Okay. So what's the biggest diameter, Sal? 16. Okay. All right. And so, Tin, just to speed things up because we're a bit late, what are you planning to do in terms of balloon sizing or not, or rely just on firm edge measurements? Hmm. Agree. Yeah. Okay. Anybody in the audience would do balloon sizing in this one or not? Anyone? Oliver, very quickly, short answer.
No, I wouldn't do balloon sizing. But at 8 kilogram, I mean, we have excluded any other reasons for failure to thrive. This is a big hole, and unless the parents would feel very, very strongly against surgery, I would probably go for surgery.
Okay. There's a tiny PDA or small PDA we just saw, I think, unless it's a different patient. Also, right. Okay. Yeah. Yeah. Yep, yep. So focusing on the ASD then, you're not going to do balloon interrogation or sizing. So what device are you going to use and what diameter? Okay, so 18. So you're going to use 18 millimeter. Which device? Okay. Yeah. Okay. Joachim.
Are you using an ASD delivery system or a PDA? Because in small kids, I find the PDA gives a better angle.
I'm assuming they're going to use the ASD delivery system.
And the cable is also a little, well, now they have the trapezium.
Yeah.
The cable
Yeah.
is softer.
Mm. Okay, so what size sheath? Mm-hmm. You want it longer? Masood, yeah.
Yeah, Tin, I think the TOE gives you an underestimate when it comes to total septal length. I think the best thing is to do a 4-chamber on transthoracic echo, measure your AV valve rim, and then go anti-clockwise and measure your pulmy vein rim. So I think pulmy vein plus AV valve rim and plus an average of your ASD size probably will give you the best measurement as far as total septal length is concerned.
all
This
right.
is an underestimation.
Yeah, but also, Tin, what length of the septum do you want before you will proceed then? Yeah. Yeah. So you're going to try it, aren't you? Or are you thinking the septal length is 26 or 28 or thereabouts, and so you shouldn't do it? It looks as if you can. Yeah. 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 Okay. So the rim is getting smaller as we go along. The length of the septum, rather. Yeah. Yeah. So one of the suggestions Rohit is making, which is quite a reasonable one, worth a try, the rims are actually not floppy, they're firm, and the TOE dimension was 16, so why not try 16 device? So what do you think? Uh-huh. Well, either that or we can come back to you. We can do another lecture. We're a bit behind. So we can come back to you when you've made a next step or decision. Does that sound okay? Okay, all right. So let's cut away from the children's cath lab. So, and we'll do the next. Oh, India. All right. We're going live to India now. Which one, Narayan or Apollo? Oh, we're going to Narayan. Yeah, can you hear us? Is it Bhushan? Okay. Well, yeah, we're live with you. We can hear you.
go to the next slide. So our plan is to put a APS 20 with a 2,000 stent. So either a 7 into 16 or a 6 into 16 millimeter 2,000 stent for one APS. We are planning, so after the final review, we are going to select the stent. Okay, so handing over to our Goita. Whatever we have done so far, she can show.
Yeah, just about.
The recorded one, we have actually taken earlier. So this clearly shows that this systemic RV. Next one, fluoride. Fluoride. So what we have taken the measurements, we measure the RPA around 12 millimeter here, the LPA origin is around 3, and the distal LPA we have measured is 6.8 millimeter in the injection.
So angiographically, unless we can't see it very well, I haven't seen a tight LPA origin stenosis, but Joachim.
It's very strange, a systemic RV pressure,
Yeah.
only with a
Single
even
stenosis.
Yeah, on one lung, he should have much lower pressure
Yeah.
than this. So, I mean, he has pulmonary hypertension or distal RPA stenosis. He has something else.
Yeah. What was the RPA pressure out of interest?
Yeah, so RV and the NPA pressure is around, RV pressure is around 80, NPA pressure around 80 millimeter of mercury. There is hardly any gradient across the pulmonary valve.
And right pulmonary artery pressure?
It's very rare to have a unilateral branching stenosis with so much high PA pressure. That is true.
Yeah.
Or the RV pressure. And RV is also around the LPA, so around 80. And the distal LPA, we are getting a pressure of around 50 millimeter of mercury, and the dressing is totally non-pulsatile.
Okay. Yeah. So
After seeing the echocardiography, CT scan, there is no other reason for this high RV pressure. There is no residual VSD. There is no other contributing factor. So what we have decided to reduce the stenosis as much as we can. Then we have to see how much the pressure comes down.
yeah.
And another important finding, this study is having a pulmonary valve result surgery. So there is mild to moderate pulmonary irritation. We are not anticipating that this study will go for a future pulmonary valve replacement or something. So right now we are planning for APS 20.
Neeraj?
Reversal right in the distal pulmonary arteries. So I think there is a significant PR. It's almost like a free PR. Maybe our hemodynamics are influenced by that PR because each stroke volume, you are getting an extra volume into the RV. So probably, I'm not sure whether we will really decrease the RV pressures with LPS.
Okay. Right. So we'll need to speed you up, whatever you're planning to do, because.
Yeah, so what we have done.
Yeah, go on.
Can you make a hemodynamics read? Okay. So now my sheet is inside the distal LPA.
Yeah.
So you can see a aortic pressure and simultaneously LPA pressure. As I already mentioned, LPA we are not getting any pulsatile flow. As you can see, the LPA systolic pressure is around 12 millimeter of mercury.
Yeah.
So we have almost 65 to 70 millimeter of mercury gradient across the LPA origin. So right now, my 6-French destination catheter, I have tracked over the 435 another slip where. So my sheet is across the stenosis now.
Okay.
So now I'm going to put either a C
Okay, let's keep you moving because we're short of time. No, no, keep going because the only time I will slow you down is when it's time for positioning the stent. That needs to be done carefully. Yeah, go ahead.
I think part of the problem is I haven't seen any angio projection where I would feel happy to place such a short stent, especially in the context of severe regurgitation.
Correct.
I probably would use a longer stent, and you have to get a reference image where you can actually see the thing.
Yeah, I haven't seen landmarks really at the moment.
And moreover, LPA is at an angulation. You always tend to have slightly high, long. So you're going exactly by the CT measurement.
In the context of severe regurg, I definitely would go for 20.
Yeah.
Well, the pulmonary regurg was meant to be severe, but I haven't seen a diastolic PA pressure.
Yeah. Okay, so have you changed? Are you changing the wire or have you changed it? Yeah, let's keep you moving fast, yeah? Okay. And diameter is what? 6 or 7? 7. Okay. All right. Okay.
We are not really sure of the landing zone. Can you take a check shot
Are
here?
you going to do an angio there? Are you going to do an angiogram through the sheath now? Okay. Yeah. So come back. That's enough, isn't it? That's too much. Probably about, oh no, that's too far back, isn't it? I think a little bit more further in, isn't it? I think I would, now it's about 2 millimeters back.
I think you have to come back a little bit, otherwise you're going to interfere with the left upper lobe.
Just a short distance back.
Yeah, yeah. That's fine. That's fine. Yeah.
Just a little more. No, still a little bit more.
But, yeah. I mean,
That's a bit better, I think.
yeah. Take the destination teeth a bit back, otherwise the balloon, the shoulder on the balloon may spread it forward during the deployment. And I normally would pull it back a bit.
Watch the wire. Watch the wire. Might just be okay. Yeah. Watch the wire. Yeah. Interesting. Yeah. Just very quickly, if you could do a lateral, very quickly, if you can do a final lateral angiogram, and then we'll cut away because Tin is waiting. Show us the angio fluoro. Can you show us the fluoro machine? The monitor. Okay, it's just a little bit further in, isn't it? I would put the small one you had originally at the origin. Okay, so whilst you're preparing or getting ready for that, shall we go to Tin and see how he's progressing? Okay. Tin, we're back with you. Yep. Can we see the TOE as well? Yeah. Yeah, that's quite a lot. Those who would release. 2, 3. Okay, so at this end, Tin, the vast majority would remove the device because I think mitral regurgitation and that aortic root compression are two factors which are a bit alarming. What do you think? Well, I would try the 16. I would try the 16 before making that final decision.
Well, Jacques, may I make a comment about, so eventually, what is the real size of this defect?
It's around 14.
14, 16, 18, put an 18 French. I mean, if you don't size, if you don't use balloon sizing, and you rely on what? On the maximum size, you judge on echo. However, if you have an oval device, an oval defect, which is the case in the vast majority of cases, what is going to be the maximum size? Could be 16 in shot, could be 8 or 10 in another one. So by definition, if you put an advanced device in, you're changing an oval-shaped size into a circular defect. So that's why it's difficult to select a proper size device.
Okay.
And this device is clearly oversized to me.
Yeah, okay. All right, so Tin, what have you decided? Because we need to move. Sixteen. Yep. Okay, so shall we go to Apollo again and then come back to you? Okay, let's go to Apollo. This is great fun, isn't it? Before the gala dinner. All right, Bhushan, can you hear us? Bhushan, can you hear us? Apollo, can you hear us? This is like the spacecraft, isn't it? NASA. No, we still hear Tin and... Can we go to Apollo? Okay. Bhushan, okay. Bhushan, can you hear us? Okay, we'll back live with you. Yeah, that should be good.
So, yeah, my, go next. Angel looks perfectly all right. Make the hemodynamic break. Make the hemodynamic break.
Yeah.
As you can see, the patient is stable. The blood pressure is around 106 by 53 in the mean of 76. My pulmonary artery pressure is now much less. The systolic of 34 with a diastolic level and mean of 21.
Okay.
We are going on to track for the pulmonary valve.
Okay. Well, that looks good. Okay, Oliver, final word, and then we'll move away.
Oh, I mean, great.
Oh, I see. Right. Okay. So the RV pressure is still high. Yeah. Let Oliver make a comment.
No, I think great result, certainly with regards to the LPA. Disappointing that the RV pressure is still so high. But I would suggest, certainly, if you have a pre-procedure CT, you have to plan your angiographic projections better so that you always have a reference image for positioning of the stent. And I certainly would have used some sort of steep four-chamber view in the context also of dilatation. With regards to the stent delivery, it's very important to remove or to withdraw the delivery sheath far enough, because what happened is that the shoulder of the balloon jerked the stent forward.
Milks forward, yeah.
Equally, I think delivery of these stents should be a single operator thing.
Pardon? So, Bhushan, we haven't got time to stay with you, but can you, have you got an idea whether the pulmonary valve is stenosed, or whether there's still a bit of muscle around there, or whether you're going to balloon dilate the pulmonary valve or not? I missed that bit. Yeah. Okay. So we'll leave you to decide that and carry on, because we're way behind. So thank you very much for another very educational case. Okay, let's go to Tin again. Tin, we're back with you. No. Yeah, now.
No. Was there a MR? Was there MR?
So when you, Mira, good question that. When you retrieved the first device, was there MR or did it disappear? Okay. So we can't win on the wiser on that front. Okay. So Tin, what are you going to do now? Yeah. And by cable use were okay. Yeah.
The mitral rigor is actually a little better. On the previous device, you could see more than one jet.
Yeah.
I think it's at least this device.
It's 1.5 now. Yeah. Okay, so yeah, so you're going to release or what?
Or you can go maybe one for another view for MR. Is it really coming from the coaptation point, or is it really flat? I mean, can you have a look at the other view of our MR?
Show the MR mitral regurgitation, whether it's. Yeah. Captation area. Okay. Yeah. Okay. All right. Then decision time because we've got to then move. Yeah. Okay. Okay. Very quick look at the mitral valve, and then we'll move away and leave you to the PDAs. Show us the TOE mitral valve very quick. Oh, there you are. 2 jets. 1.5. Yeah. All right. Okay. Tim, we'll leave you to close the PDA. But again, very stimulating, very educational. Thank you very much to the team. Okay. So, it was Masood, wasn't it? Or yeah, Masood back. How soft is really soft? I'm going to ask all of you to speed up so that we don't miss the gala dinner. They've got to get in here and prepare this hall. So they can't start without us. All right, Masood, go.
Thank you very much. I don't think there would be much appetite now for something like this, but I would still carry on. There are no disclosures. I think you all know that there has been a tremendous progress in terms of disclosure of ASD, mainly for 2 reasons, obviously device technology and procedural techniques. But what we really are looking for is an easy and safe deployment, and that is adequate flexibility, capability, repositioning. But what we worry about in these patients is really 2 things. One is damage to the surrounding structures, whether it's an erosion or an AV block, and of course the risk of embolization. Well, how soft is really soft? This was a hard topic to really talk about, but I thought, would it mean that soft enough not to change the architecture of the atrial septum, and soft enough not to cause tissue injury, such as erosions or AV block, and should not be soft enough to actually embolize? So do they need upsizing if they're very soft devices? Is there a risk of residual shunt, which is higher in these soft devices? And what about risk of thrombosis and co-block deformities, which we heard from Oliver Stumper earlier on? Now, when I looked into the literature to see what softness actually means, softness of an object, it can be detected through touch. Most of us would do that. The perception of softness involves the perception of the relationship between displacement and reaction force. So 2 ways you can do that. You can touch it, or you can force it and see how a thing is soft or not. And this picture has been shown times and again. The currently available devices, which are mainly self-centering, except 1 or 2 potentially biodegradable or otherwise. We all know about implants after occluder, and we think that it's a relatively stiff device because the risk of erosion has been up to 0.3% in the literature. But the experience, obviously, with ASO is also much larger as compared to any other device, like Occlutech device, where the angles are created between left and right discs, which conform to the sphere alignment. But we know that the erosions have been described with Occlutech device as well. CX softness very similar to Occlutech and Occlutech, but again, I think so far, to my knowledge, there has not been deformation. Was almost similar in all 3 major devices, and residual shunt at discharge might be slightly different, but I think in follow-up, we know that the residual defect is comparable, residual shunt and thrombus formation. A soft device sounds like a better idea, and I think probably is, but softness alone is not the sole determining factor in device selection up to the literature known today. And I think every patient needs to be individualized to determine the pros and cons based on age, size, and morphology. And maybe we all know softer is better, but I think probably the biodegradable devices in future might answer this question. Thank you very much.
Thank you very much, Masood. That's a very thought-stimulating presentation. So we'll move on. Hisashi, wire fracture of Gore ASD device.
So my talk is a wireframe fracture of the Gore device. So chest X-ray and 3CT evaluation. So this is a Gore card from ASD occluder. So the 6 or 8 petals, 5 size selection, and the wire is made of the platinum filter nitinol wire and covered by the PTFE. And just a complex deformity and low metal mass and designed to reduce the risk of the tissue damage. So far, there's no report about the auric erosion. So this is the data. Previous presentation is the same. So the wireframe fracture is very common. But the wireframe fracture event occurred without sequelae. So this is the follow-up data after implantation. 6 months is a wireframe fracture rate is 31, and 36 months is more than 50. But no clinical sequelae. So this is the wire structure. It's zone 1, zone 2, zone 3, and zone 4. Zone 1, zone 2 is a fracture is common, and zone 3 and zone 4 is less than zone 1 and zone 2. So far, we have two papers, not the GCA device, but helix device or GSO device. Two cases of the pericardial tamponade due to nitinol wire fracture. And one paper from the helix device associated with the early frame fracture and mitral valve perforation. So checks X-ray evaluation is a standard technique. It's a zoom up and adjusted the contrast and to make a better view. And lateral also. So development of wire fracture, just after implantation. Then 1 month later, so this fracture, and this fracture, and this fracture, and green one fracture, and black one is bended. And 3 months later, so the gap between the chip of the fracture are getting bigger. This is the defect area estimated by the wire wasted point connected. just a stub implanted, so the estimated defect area is a circular, but change it to the ellipsoid. But the disadvantage of the chest X-ray is visibility is depend on the condition. So the tube voltage, the body motion artifacts, and the individual physics. So this is the same patient. 1 month later is very clear, but 3 months later is unclear. So the fracture rate during the follow-up increased from the 1 to 6, and then gradually increased to 24 months. So number of the fracture after implantation, 3 to 6 months is very common, and then
Sorry,
gradually
Hisashi, so
Yeah?
stay there, don't go away, but Narayana want to go live briefly, so if you just stay there. All right, let's go live. Yeah, just stay there and we'll... All right, Bhushan, we're back live with you. Can you hear us?
Yeah, yeah. Are we audible?
Yes, go ahead.
So basically we have video very quickly. We got a very nice pulmonary valve stenosis. The radius was approximately 50 milliliter of mercury, and that was the main reason our blood pressure was in 70 or 80. So what we did actually, we did a BPV because it was the last result we so we did a BPV. So now we show you the go next.
What was the annulus and what balloon did you use?
So basically, annulus was around 40 milliliter. We 40.6 to 50 milliliter, we took a 80 Kaiser.
Okay.
Okay, now next. Go next. Next. Okay, quickly let's show the full lab. You don't do that again? Or catheter is, okay. So catheter is in RPA.
Yeah.
Fully, okay. So RP pressure is around 50 now, 50.
Yeah. Okay. Up to about 70.
Yeah. So this one here, SCG.
Okay. So now I think what we're planning to do, because I think you've improved things both to the left lung and the valve.
Hemodynamics are much better now. RP pressure came down from around 100 to 60. So I think for the time being, we can keep the same follow.
Yeah. Okay. All right. Thank you very much. Again, once again, well done.
Yeah, in between, actually, we have done another Seraplex AC device in other lab.
Yeah. No, well, it might have to be tomorrow because we're waiting for our dinner as well. All right. So thank you very much. Thank you. All right. Brilliant. Well done. Okay, Hisashi, carry on now. Sorry about that. All right, let's bring the slides back on. Big hand for the, India. Right. Yeah, carry on now. They're coming up, the slides.
The limitation of the chest X-ray, the unsatisfied examination is about 30%. You can tell if the fracture is on the right-sided or left-sided. I can tell where the broken tip is going, and also the difficult to evaluate overlap of the wire on the outer circumference. So 3D CT evaluations for wireframe fracture. So we repeated the phantom study to reduce the radiation dose as much as possible, and to a dual source CT and SN filter reduces the radiation exposure. So this study's average radiation exposure is only for the 0.03 millisievert. On contrast, the single direction 0.06 millisievert. So this is an example. So you can see the any direction, and so vertical rotation and horizontal rotation. So vertical rotation, you can count in the number of the fracture and the right-sided or left-sided. So the horizontal rotation, you can see the direction of the wire chip. So this is an example of the same time chest X-ray and CT. So CT is better than the chest X-ray. So this is a chronological change of the chest X-ray of the GCA device. So the figure of the device changes from the round to the ellipsoid. So this is a 12-month chest X-ray and also the CT anterior. So the 3 fracture here, but 3D CT, so the 6 fracture. Mainly the overlap area. So you can see the fracture clearly. CT 3D evaluation for wireframe fracture, low radiation exposure, no contrast made, spatial resolution is excellent. The fracture chip direction could be easily detected. So the CT is almost 5 times of the chest X-ray is a disadvantage. The wireframe fracture is often observed, but is considered as the result of the adaptation of the device. The oversized device is or 6-pedal device was tend to be fractured. Chest X-ray is standard evaluation, but underestimated. So, but the 3D CT is very useful for spatial evaluation for the wireframe fracture. Adverse events were reported for the LX device or GSO device. Meanwhile, only 1 mitral injury of the GCA was reported so far. So we need a long-term observation for GCA device. Thank you.
Sashi, thank you very much indeed. Sorry for the interruption, but some important information in that talk. We'll have to keep an eye on things for the future, yeah. So last but not least, Joseph Kettle, new design for ASD device. Joseph.
Good evening, and thank you, Shaq, and thanks, Tin, for giving me this opportunity. And I want to personally thank each one of you here, because it was a long day and still you are sitting here, and I promise I'll make it as possible. So the presentation is on why a new design. And to be honest, I learned a lot. I was involved with ASD closure since my early training period, 1997 to 2000, and then as a consultant. So about 28 years I've been doing ASDs, and my first embolization was in 2011, and it was my 256th ASD. And I learned 2 things from that. One is that don't believe what you know and try to know a little more, and that's how this patient taught me that there is a spiral ASD. And also it provoked me to think more about a better design for an ASD device.